Hello guys, I'm Dr. Meenu, your Obs and Gynae faculty at Medico. So I know you have been through this whole rigmarole of last minute revision several times already, but now it truly is the final dash. We have covered all the topics in obstetrics and gynecology over our past sessions. So today we'll be going through only those topics that have been found to be very high yielding as far as your exams are concerned. All right, with that, let's take up our first question. Fertilization most commonly takes place at. Before we go into fertilization, we'll just brush through oogenesis and spermatogenesis. What is oogenesis? It is a process of development of a mature ovum. It starts at around 6 to 8 weeks of intrauterine life. 6 to 8 weeks of intrauterine life. Right. So what happens? You've got the oogonium. The oogonium undergoes mitosis to form the primary oocyte. You have to remember mitosis takes place only in the intrauterine life. By the time the baby is born, all the oogonia have been replaced by the primary oocyte. As soon as the primary oocyte is formed, meiosis 1 starts. What happens to the meiosis 1? It gets arrested in the prophase 1. Not just that, it gets arrested in the diplotin stage of the prophase 1, in the diplotin stage. At this time, the primary oocyte is said to be in the dictate state. In the dictate stage. So this is the stage of the ova at which the baby is born, right? Then what happens? At puberty, under the influence of LH, because of the LH surge, meiosis 1 is immediately completed. So what do we learn here? Meiosis 1 is the hormone dependent division in the process of oogenesis, right? So after that meiosis continues, a secondary oocyte is formed which is haploid. Along with the secondary oocyte, a polar body is also released, which is the first polar body. When is that released? At the time of ovulation. Right. Once ovulation has occurred, meiosis gets arrested in the metaphase 2 stage of the secondary oocyte is arrested in the metaphase 2 stage. If fertilization occurs, metaphase 2 is meiosis 2 is completed, a second polar body is released along with the mature ovum. That is when fertilization takes place. All right. So what are the important things you need to know here? Oogenesis begins at 6 to 8 weeks of intrauterine life. Meiosis 1 is arrested in the diplotin stage. Meiosis 1 is the hormone dependent part which is under the influence of LH. The first polar body is released at the time of ovulation and the second polar body is released at the time of fertilization. Okay, so one other thing you need to know, when is the number of oocytes the maximum? When is it maximum? When can you see the maximum number of oocytes? This is in the intrauterine life. That is at the 5th month or around the 20th week of intrauterine life, there are about 6 to 7 million oocytes. Now, these oocytes undergo apoptosis and the number reduces. That is, by the time the baby is born, at birth, there are only around 2 million oocytes. And by the time the child reaches puberty, there are only around 3 to 5 lakhs. Of this 3 to 5 lakh oocytes that are there at the time of puberty, only around 500 are released during the lifetime. Okay, that is about oogenesis. Now we'll come to spermatogenesis. Spermatogenesis is the process of formation of a mature sperm. The most important thing you need to know is there is no arrested phase. There is no arrested phase in spermatogenesis, unlike in oogenesis. Okay. Now, again, just like in oogenesis, there is a spermatogonia that undergoes mitosis to form the primary spermatocyte. Then there is a secondary spermatocyte, spermatids, and then the spermatozoa, right? Here, there are no polar bodies, nothing like that. From a single spermatogonia, you'll get 4 different spermatozoa. What you have to know is, The spermatids, once a spermatid is formed, the spermatogenesis part is complete. After that, there is something called the spermiogenesis. What is the spermiogenesis? It is the process by which the spherical spermatids transform into a tailed spermatozoa. That is spermiogenesis. Now, this here there is no mitosis or meiosis taking place, and there is no change in the chromosome number also. This takes around 14 days to complete. That is about spermatogenesis. There are a few other things you need to know. Where do the sperms attain motility? The sperms attain motility where? Sperms attain motility in the epididymis. Where in the epididymis? In the caudal part of the epididymis. That is not enough. The sperms just shouldn't be just motile. They should become hypermotile. Where do they become hypermotile? They become hypermotile in the fallopian tube. Okay, that is about the motility of the sperms. Now we'll come back to our question. What was our question? Where does fertilization take place? Now you've got a mature spermatocyte, you've got a mature oocyte. Now you need to have fertilization. What is fertilization? It is a process by which a mature oocyte joins with the mature spermatocyte to form a zygote. Where does this happen? You know that this takes place in the fallopian tube. Where in the fallopian tube? In the ampulla of the fallopian tube. That is your answer here. Fertilization takes place in the ampulla of the fallopian tube. There is another important factor to be noticed here. Because fertilization takes place in the ampulla, this is also the most common site of a tubal ectopic pregnancy. We'll come to that in a later question. Anyway, fertilization occurs in the ampulla of the tube. After that, the fertilized zygote starts dividing. It becomes a 2-cell stage, it becomes a 4-cell stage, it becomes 6, it becomes 8, it becomes 16. The 16-cell stage of the zygote, 16-cell stage is called the morula. This is the zygote that reaches the uterine cavity. When does the morula reach the uterine cavity? That is around 4 to 5 days after fertilization. The morula travels through the tube and reaches the uterine cavity. The most important factor that is responsible for this travel of the zygote to the uterine cavity is the peristalsis of the tube. So, it has reached the uterine cavity. If you are asked, you have to say that is around the day 18 of a 28-day cycle. Once it reaches the uterine cavity, it undergoes further division. It undergoes further division to become what is called a blastocyst. It is the blastocyst that implants in the uterine cavity. What is implantation? Implantation is a process by which the blastocyst penetrates into the uterine wall and starts establishing a pregnancy. Which is what implants? The blastocyst implants. Implantation most commonly occurs on the posterior surface of the upper segment of the uterus. The posterior surface of the upper segment. Once implantation occurs, certain changes happen. This we have to know. You have got the uterus here. This part is a myometrium. Okay. Implantation has occurred. This here you have the uterine cavity. This is the blastocyst that has implanted, say. Now, once implantation occurs, the endometrium of the uterus gets converted into the highly specialized endometrium of pregnancy. This is called the decidua. The decidua can be divided into 3. Here, you have got the decidua between the implanted blastocyst and the uterine cavity, which is called the decidua capsularis. You have got another decidua between the implanted blastocyst and the myometrium here. This is the decidua basalis. A third decidua, that is the rest of the decidua, is known by the term decidua paritalis. Okay, there are 3 different decidua. Decidua can be divided into 3: basalis, capsularis and paritalis. By around 14 to 16 weeks of gestation, the decidua capsularis fuses with the decidua paritalis. Why? The blastocyst enlarges, the uterine cavity becomes obliterated and the decidua start fusing. This is called the decidua vera. This is at 14 to 16 weeks. So what is the what is important here? What is clinically important? We can say twin pregnancy or multiple pregnancy is possible up to 14 to 16 weeks of gestation because the uterine cavity is still there. All right. That is the important thing with regard to decidua. We have got another term here, that is capacitation. What is capacitation? Capacitation is the biochemical changes, that take place in the sperm, which enables them to fertilize the ovum. It is not the definition that is important. Where does capacitation take place? Capacitation takes place in the female genital tract. It starts in the cervix. All right. That is with regard to oogenesis, spermatogenesis and implantation and fertilization. I hope you have got that. Okay. Now we'll go to the next question. We have a 22-year-old gravida 3 para 2 lady. She delivers a normal child followed by delivery of an intact placenta. Following delivery, the lady develops severe pervaginal bleeding when after 30 minutes, on-table sonogram revealed retained placental tissue. What is the suspected type of placenta? Here I have given you different types of placentae. Mostly you have seen, all of you have seen a placenta. It is a circular disc and it has got the umbilical cord coming and attaching to the center. Here they found that she has delivered an intact placenta. That is almost a complete placenta, but still something is remaining. What is that? This is called a placenta succenturiate or a succenturiate lobe of placenta. See, a placenta with an additional smaller lobe. This may be missed during ultrasound examination. The lobe may remain there, and once the placenta is delivered, the uterus fails to involute, and because of the retained placenta, she starts developing postpartum hemorrhage. That is about placenta succenturiata. Now, suppose these lobes are of equal size. It is called a bilobed placenta. Here also it can lead on to produce a postpartum hemorrhage, subinvolution of the uterus. We've got a few other types of placenta. What is this? This is a battledore placenta. What is the importance of a battledore placenta? See how the cord is inserted. In a normal placenta, we find that the cord comes and inserts where? In the center of the placenta. Here, where is the cord inserted? To the margin of the placenta. That is the importance of a battledore placenta. We have got another one where cord comes and inserts into the margin. That is a velamentous insertion of the cord. What is the difference here? You see how the cord comes. Where does it insert? Not directly into the placenta. It comes and inserts into the membranes. And what happens? Inside the membranes itself, the cord starts ramifying. It starts spreading out. And then it comes to the placenta. This is very important. Why? Because suppose you have got the uterus. Here you have got the uterus, and if it is a velamentous insertion of the cord, you have got the placenta here, and what happens? You have got the cord coming and then it is ramifying within the membranes. So what is here? Here you have got the cervix, right? When the cervix starts dilating, these vessels which are going into the placenta through the membranes can rupture, producing what? Producing antepartum hemorrhage. What is this called? This is called vasa previa. This is the only antepartum hemorrhage where you are what the blood that you are seeing is of a fetal origin. In all other antepartum hemorrhages, be it placenta previa, be it abruption, the blood that you are seeing outside is of maternal origin. So vasa previa is very important because if you don't take out the baby quickly, you can lose the baby, right? So which is the type of placenta that presents as vasa previa? It is a placenta with a velamentous insertion of the cord. You've got that. Then we have got the furcate placenta where the cord separates even before it reaches the placenta. Then there is a fenestrator, placenta fenestrator, that is there in the name itself. You've got several cotyledons missing. See how there are gaps within the placenta. Now, there are two other placentae, that is a circumvallate placenta and the circummarginate placenta. There are two folds of the chorionic plate and the amnion. Here in a circummarginate placenta, what you see is there is a single fold of amnion and chorion. See, this is a single fold. There is a smooth transition. While in a circumvallate placenta, there is a double fold of amnion and chorion. There it is a valve-like structure. That is why it is a circumvallate placenta. It is not about that. That is not what is more important here. What is important is what can happen if they've got such a placenta. We know what happens with the suction curate. We know what happens with the bilobed placenta. We know what happens with the velamentous insertion. What happens here is, see, the surface being smaller, what can it produce? It can produce a fetal growth restriction. It can go on to produce an antepartum hemorrhage because there is lesser area attaching. It can come off easily. It can also produce a preterm delivery. All these are complications of circummarginate circumvallate placenta, together known as the extrachorial placentae. That is with regards to abnormalities of the placenta. Some other things you have to know. Placenta secretes hormones. You know this, right? What are the hormones secreted? You have got progesterone, you have got estrogen, then you have got hormones like relaxin, you have got human chorionic thyrotropin, then you have got somatostatins. Like we said, there is estrogen, there is GnRH. The important thing is these hormones are not secreted by the placenta alone. They are secreted by other organs in the body also. But there are certain other hormones like the human placental lactogen, which is a most specific placental hormone. That is the importance of human placental lactogen. Another thing you have to remember is human placental lactogen has got nothing to do with lactation. All right. If you get a question and since you're seeing lactogen, don't immediately go ahead and write that this is important in lactation. No, HPL has got nothing to do with lactation. Now we come to the most important hormone that is secreted by the placenta, which is HCG. Why is HCG important? You know, it is a basis for diagnosis of pregnancy. This hormone is secreted exclusively by the placenta. Secreted exclusively by the placenta. It has got two subunits, an alpha subunit and a beta subunit. The alpha subunit is common to LH, FSH and TSH, while the beta subunit is specific to HCG. The maximum levels of HCG is seen at around 9 to 10 weeks. After that, it decreases and it reaches a nadir at around 20 weeks of gestation. HCG will disappear from the urine around 48 hours after delivery. Okay, that is with regard to placenta and the placental hormone. We have got the third question. This is regarding amniotic fluid. A woman presents to you at 36 weeks. She complains of breathlessness, excessive abdominal distension. Fetal movements are normal. Fetal parts are felt, but not that well. Fetal heartbeat is heard, but it is muffled. Her symphysiofundal height is 41 centimeters. Her abdomen is tense, but not tender. What is the most likely diagnosis? At 36 weeks, you have got a symphysiofundal height of what? Of 41 centimeters. What are the causes of increased symphysiofundal height? First one, whether it is increased or decreased, the first cause that you have to think about is a wrong date. You've got the wrong gestational age. That is the first one. Then another thing is it is a macrosomic baby, or there are fibroids in her uterus, or there is a low-lying placenta, it's a placenta previa where the baby is pushed upward, or the baby has got some other abnormalities like an hydrocephalus. And most importantly, or the most common one that you see is a polyhydramnios. What is a polyhydramnios? I've given you a scan picture here. I believe you can see that scan. How do you measure the amniotic fluid in the body, in the uterus? You cannot take a volume. What you usually do is you divide the abdomen into four quadrants, Q1, Q2, Q3 and Q4. You take the measurement of the single deepest pocket, the deepest vertical pocket without any fetal parts or without the cord, and then you add all these together. Normal AFI will be between, or the normal amniotic fluid index it is called. The normal amniotic fluid is between 8 and 20. Suppose you have got an amniotic fluid index of more than 25 centimeters, or the single deepest pocket that you measure is more than 8 centimeters, you say that the woman has got hydramnios or polyhydramnios. See, here you can see there is a huge vertical pocket here. what are the causes or what is the reason for polyhydramnios? So for that you have to know from where does the amniotic fluid come. In the early weeks of pregnancy, amniotic fluid comes as an ultrafiltrate of the maternal plasma. Later it occurs due to diffusion across the fetal skin. Once the skin becomes keratinized, that is around mid-pregnancy, fetal urine becomes a main component of the amniotic fluid. So, amniotic fluid is reabsorbed mainly by a process of swallowing. Anything that can cause increased production or impaired swallowing can lead to an increase in the amniotic fluid. That is only common sense, right? So, what causes impaired swallowing? You don't have to buy hard the whole thing, please, but just go through, because you might get some weird choices, like say here you've got chaos, which is a high airway obstruction sequence or something like that. So go through this, but please don't buy hard this. You'll be able to make it out from the choice. If you're asked what is the most common cause of hydramnios, your answer is it is idiopathic. You don't know. But if you're asked what is the most common cause of severe hydramnios, then you should have an answer. It is GIT malformations. That is the most common cause, impairment in the swallowing. This is followed by CNS malformations. All right. That is about hydramnios, and you'll go through the other problems that can cause hydramnios. What are the complications? Again, you don't have to buy hard. Think about it. You have got the uterus and it is filled with fluid. What is the first complication that can occur? She can go in for a pre-labor rupture of the membranes. It can even be a preterm pre-labor rupture of the membranes. She can also have PPROM. There is a sudden gush of fluid. There is a sudden loss of pressure. What happens? The placenta may be detached, so she can have abruption. Obviously, because the uterus was over distended, she can develop postpartum hemorrhage. Because there is this baby in a large amount of fluid, the baby has got lots of space to move around. There is a possibility of a malpresentation. Again, if PROM occurs, there is a greater incidence of what? Of cord prolapse. These are the problems with polyhydramnios. How do we manage? Depending on the gestational age. In obstetrics, most of our problems, most of the things that deal with in obstetrics depend on the gestational age. If the woman has got severe complications, severe symptoms, like has got severe respiratory distress, she cannot lie down, you've got problems like that, you may have to terminate the pregnancy depending on her gestational age. But if it is an early pregnancy, you should do a serial amniocentesis so as to reduce the amniotic fluid volume and bring down the amniotic fluid index. Here, what is your answer? Let us just look at the choices. A placental abruption is unlikely to raise the fundal height. Moreover, then nothing has been mentioned regarding, see, the fetal movements are normal and the fetal parts are felt, FH is heard. Okay, so it is not an abruption. Can it be a fetal or maternal ascites? Yes, it can be an ascites, but again, see, if it is an ascites, it is not just the symphysial fundal height that is increased. She'll have a generalized increase in her abdominal girth. Here the abdomen is tense, but it is not tend. Okay. In this case, your answer is what? It is polyhydramnios. Let us take the next question. Again, with regard to amniotic fluid only. I'm sorry, we'll take a short break. We'll take up the next question. A woman with 18 weeks of gestation presented to the OPD. On examination, the uterine size corresponded to 16 weeks. On ultrasound, oligohydramnios was found. Which of the following can be suspected? So, we have just discussed polyhydramnios. Here, oligohydramnios means there is reduced like. What can be, how is it diagnosed? When you have got an amniotic fluid index of less than 5 or a single deepest pocket of less than 2, you say that this woman has got oligohydramnios. Again, there is a reduced production in the amniotic fluid. The most common causes, just like in polyhydramnios, this one it is also idiopathic. Again, the most common cause of severe oligamnios, this is renal anomalies. You don't have to think twice there. We know that kidney is the main source, or urine is the main source of the amniotic fluid. So, when a woman has got oligamnios, the first thing you'd suspect is a renal anomaly. Renal anomalies will include renal agenesis, a posterior urethral valve, that is there is a urethral obstruction, prune belly syndrome, autosomal recessive polycystic kidney disease, that is there is bilateral dysplastic kidneys. Whatever the reason may be, whatever the final diagnosis may be, renal anomalies are the most common cause for severe oligamnios. Here, what is your answer? Ultrasound, oligamnios was found. What can be suspected? Your answer here is renal agenesis. Okay. Now, again, I have given you a list of the problems that can lead on to produce oligamnios. You've got chromosomal abnormalities, congenital anomalies, placental abruption, twin-twin transfusion syndrome, certain drugs. So, there is a mnemonic that you can use. It is called Dilper. Okay, I'll expand it out for you. D standing for drugs. It can be a intrauterine fetal demise. It can also be a diabetes mellitus with vasculopathies. Not GDM, remember GDM will go on to produce polyhydramnios. Diabetes with vasculopathies can produce oligamnios. Now you have got your I. I stands for intrauterine growth restriction. Then we have L. L is for leaking. Leaking in the sense it can be a PROM or a PPROM where fluid has been lost. P, if it is a post-term pregnancy. In case of preeclampsia, then we have A, which is for an abruption, not just an abruption, a chronic abruption. These are things you need to mug up. That is an amnionodosum. Some aneuploidies. And finally, you have R. What is R? R is renal anomalies. That is Dilper. Anyway, the first thing or the most important thing you have to remember is renal anomalies. Renal agenesis being the most common cause of producing severe oligamnios. We talked about drugs. That one also you need to know which are the drugs that are involved in oligamnios. That is a prostaglandin synthase inhibitors and angiotensin converting enzyme inhibitors. Right? Now we come to the complications. Complications, fetal or maternal complications. The most important complication is a pulmonary hypoplasia. This may or may not be in association with Porter syndrome, but it is the pulmonary hypoplasia that is the most common complication, the most important complication associated with oligamnios. How do you manage? Depending on the period of gestation like we talked about and the biophysical scoring of the baby, how the well-being of the child. Anyway, if everything seems all right, it is just an oligamnios, then it can be managed by an amnio infusion. Right, so we have discussed that. Now we come to the next one. This is another important, a favorite topic of the examiners. Which of the following is true regarding the color of normal amniotic fluid during delivery? What is the importance of the color of the amniotic fluid? It is depending on the amniotic fluid that you can assess the well-being of the child, of the baby. Normally, you have all seen amniotic fluid, right? when you have done an ARM, you have seen amniotic fluid. Amniotic fluid is usually colorless, or it is like a pale straw colored. That is here. What is the answer? Normal amniotic fluid is clear colorless to pale yellow. That is a normal color. If the baby is not yet mature, that is if it is a PPROM, you will see that it is a, if it is a mature fluid, it is if from the mature fluid, it is much lighter. That is how you diagnose a PPROM. There are a few other colors that you need to know. One is green. What produces green colored amniotic fluid? That is produced by, what produces green color? It is produced by meconium. It indicates fetal distress, which is a hormone, a biliverdin hormone can produce green colored amniotic fluid. Then we have got the golden colored amniotic fluid. Where is it seen? In RH incompatibility. Then you have got a saffron colored amniotic fluid, which is seen in case of a post maturity. A dark colored or blood stained amniotic fluid due to hemoglobin can be seen in abruption. A dark brown or a tobacco juice colored amniotic fluid is seen if there is intrauterine fetal demise or pus in the amniotic fluid. A purulent amniotic fluid is more likely of chorioamnionitis or an infection. Okay, please go through that. It is important that you know the different colors of the amniotic fluid. Now we'll take up the next question. What is the recommended dose of steroids for attaining lung maturity? When is lung maturity attained? Lung maturity is attained at around 34 weeks. Say, how do you know lung maturity has been attained? There are some tests for that. You know all these tests, but it has been asked before. So I'll just talk about it once more. If you can detect sphingomyelin in the amniotic fluid, that indicates lung maturity. What produces sphingomyelin? It is the surfactant cells of the lung that produces sphingomyelin. That is a type 2 pneumocytes. So we have got a sphingomyelin. This is the test that is most commonly done, which is the lecithin to the sphingomyelin ratio in the amniotic fluid. If it is more than 2, that indicates lung maturity. Then you have got phosphatidylglycerol. If the amount of phosphatidylglycerol is increased, that also indicates lung maturity. Then we have got something called a Nile blue sulfatase test. Nile blue sulfatase means the Nile blue dye will stain the surfactant containing cells blue. That is the importance of a Nile blue sulfatase test. And finally, you have a positive shake test. While these 3 tests are done on amniotic fluid, a positive shake test, that is if you take a gastric fluid, if you aspirate the gastric fluid and shake, you will be able to see bubbles. That indicates lung maturity. So this one is done on gastric fluid. But suppose you get a question, all the following tests are done for fetal lung maturity except, and all these 4 are in your choices. What will you write? They're all done for lung maturity only. But in that case, you have to choose Nile blue sulfatase test because this test is no longer done. This test has become obsolete. Okay, the most common test that is done is the lecithin sphingomyelin ratio. But that was not our question. What was our question? What is the recommended dose of steroids for attaining lung maturity? If the baby is born if you are suspecting preterm labor or the woman goes into labor before 34 weeks, before attaining lung maturity, you give steroids to hasten the maturity of the lungs. 2 steroids can be given, betamethasone and dexamethasone. Nowadays, dexamethasone is becoming the recommended steroid of choice, but until that comes in your textbooks, we'll stick with injection betamethasone. What is the dose? Injection betamethasone is given 12 milligram, 2 doses 24 hours apart. This is the answer. Now, if this was not there, or if you had to choose dexamethasone, if you had to have a better answer, that would have been injection dexamethasone. That can also be given. Injection dexamethasone. What is the dose? 6 milligram. How many? 4 doses, which is given 12 hours apart. Remember, this is also the correct answer. Okay, not just betamethasone, dexamethasone can also be given for lung maturity. Here, that was not our answer because 4 doses are given 12 hours apart, not 24 hours apart. Okay, I hope that is clear. Now we'll come to the maternal adaptations of pregnancy. Which of the following heart sounds may be a normal finding during pregnancy? There is a huge change happening in the cardiovascular system in pregnancy. What is the most dramatic of those? It is the increase in the cardiac output. How much does it increase? Nearly 40% it increases. Okay, this is the most dramatic change. In pregnancy, the cardiac output is maximum at around 28 to 32 weeks. But if you're asked, when is the cardiac output maximum? When is it maximum? Maximum cardiac output is seen immediately after delivery. Immediately after delivery, followed by the second stage of labor, followed by 28 to 32 weeks of gestation, followed by the early first stage. Okay, so look at the question carefully before you answer. Where if you get a question, when is the maximum cardiac output seen, don't immediately jump into 28 to 32 weeks. Maximum cardiac output is seen immediately after delivery. In pregnancy, it is maximum at 28 to 32 weeks of gestation. It returns to normal when returns to the pre-pregnant levels 2 weeks after delivery. There are also other changes happening in the cardiovascular system. There is an increase in the heart rate of around 10 to 15 beats per minute. There is because heart rate increases, stroke volume also increases. That is why cardiac output increases. There is an increase in the RBC volume. There is increase in the total blood volume. What reduces? Almost all pressures will reduce in pregnancy. There is a reduction in the systemic vascular resistance. There can also be a mild reduction in the systolic and diastolic pressures. While the central venous pressure, the pulmonary capillary wedge pressure and the ejection fractions will remain unchanged in pregnancy. Now, we'll come to the auscultation findings. It is also very typical. What are the auscultation findings? You will hear and we are discussing auscultation now. There will be an exaggerated split in the S1. Exaggerated split of S1. S2 is heard normally. S3 can also be heard. It is loud and it is easily auscultated. What about murmurs? Can you hear any murmurs in pregnancy? Yes, because there is an increase in cardiac output. You can hear up to a grade 2 ejection systolic murmur, where in the aortic and in the pulmonary areas. In addition to this, you can also hear a continuous hissing murmur. What causes a hissing murmur? This is due to blood flow through the increased blood flow through the superficial arteries. This is heard where? In the second and third left intercostal spaces. This is called a mammary murmur. Right? This is about the auscultation findings. What happens to the ECG? There is a left axis deviation on the ECG. There is also a slight straightening of the left cardiac border when you take an echo. But remember that there is no significant cardiomegaly in pregnancy. The heart does not per se increase in size. Now we have got some usual signs and symptoms. You know, there is breathlessness on exertion. There can be palpitations. We just talked about an ejection systolic murmur. A significant raise in the JVP is not seen. Remember that. There is no chest pain. There is not such an amount of breathlessness as to, as you classify, the woman will be able to do her day-to-day activities. Very importantly, remember the murmurs. If it is a grade 3 or more ejection systolic murmur, or if there is a diastolic murmur, that is not normal. It indicates a pathology. Also, no arrhythmias, none of the arrhythmias, no flutter, no fibrillation, nothing is part of the physiological process of pregnancy. All murmurs, all arrhythmias are pathological. Okay, what was our question? Which of the following may be a normal finding during pregnancy? Here, the answer is S3. S3 is normally heard in pregnancy. We've got a few other changes. First one is regarding the changes in coagulation factors during pregnancy. This has also been asked several times. You know that pregnancy is a state of physiological hypercoagulation. Why? In preparation for hemostasis after delivery. So what happens? There is an increase in all procoagulants and there is a fall in all anticoagulants. There is a fall in the fibrinolytic activity also. But all the tests of coagulation, all the coagulation tests, which is what the bleeding time, the clotting time, the PTINR, all the tests remain normal. Look at this, regarding the changes in coagulation factors, that there is something that is very important that has been asked multiple times, that is regarding the factors 11 and 13. These are the only two coagulation factors to fall in pregnancy, while all the other coagulation factors will rise. All right. So you please remember that one also. Now we come to the changes in the respiratory system. Again, what happens? There is an increase in the tidal volume. There is increase in the minute ventilation. There is increase in the inspiratory reserve volume. What remains unchanged? Interesting thing is the respiratory rate remains more or less unchanged, or there is only a slight increase. Again, the total lung capacity is also almost normal or only slightly decreased. You might find this different in different textbooks, but basically this is what happens. There is very mild increase, if at all, in the respiratory rate and the total lung capacity. There is also respiratory alkalosis. Pregnancy is a state of respiratory alkalosis and there is a shift in the oxygen dissociation curve to the left. That is also important with regard to changes in the respiratory system. Next question. What is the most conclusive sign of pregnancy? This is quite easy. Why this question is there? There is a condition called pseudocysis. I think you know this. Basically, it is with regard to some psychological changes in the woman who has an intense desire to become pregnant, and she has got amenorrhea, she puts on weight, she has got abdominal obesity, and she comes to you saying that she is pregnant. But what is the most conclusive sign of pregnancy? Very simple question this one is. It is a auscultation of the fetal heart sounds. With this, we need to discuss a few named signs in pregnancy. Remember that none of these signs are being used clinically now, because now we have got ultrasounds and Dopplers and things like that. None of these signs are being used. But for your exam, these are still important because they can ask. What is the first one? Jack-Coomer or the Chadwick sign. The Jack-Coomer or the Chadwick sign is the dusky hue or a purplish hue of the vestibule and the anterior vaginal wall. Why does it occur? This is due to local vascular congestion. More important is the time at which you see this. This is seen at around the 8th week of gestation. Now, since it is due to a local vascular congestion, this can also be seen in pelvic tumors. That is the Jack-Coomer or the Chadwick sign. Next, we have got the Osiander sign. Osiander sign is an increase in the pulsation. Where is it felt? It is felt through the lateral fornices. Again in the 8th week. It is also seen in acute pelvic inflammatory disease, acute PID. Then we have the Goodell sign. A Goodell sign is a softening of the cervix under the influence of hormones. This is in the 6th week, also found in oral contraceptive pill users. Like we said, this is produced under the influence of hormones. Then we've got the Heger sign. Heger sign is also softening, but not. Heger sign is also softening, but it is not of the cervix. Heger sign is softening of the isthmus. This is felt at around the 6 to 10 weeks of gestation. Now we come to the Palmer sign. Palmer sign means there are regular and rhythmic uterine contractions. Felt around the 4 to 8 weeks, felt from the 4 to 8 weeks of gestation. It is found on a per vaginal examination. We know that you no longer do a PV examination in early pregnancy. Okay. And then we have the Hartmann sign. Hartmann sign is also known as the implantation bleed. What is this? We talked about implantation. When the blastocyst comes and implants inside the uterine cavity, some bleeding will occur because of the displacement of the endometrium, and that can be seen. Sometimes it can come outside as a light pink colored or a light colored blood, which is called the implantation bleed or the Hartmann sign. Then we have got the, again, felt in early pregnancy around the time of implantation. Then we have got a Piscasex sign. Piscasex sign means, see, implantation occurs like this. Here you've got the uterus. You have the uterus here, and this is a uterine cavity. Implantation occurs here. Okay, this is called an eccentric implantation. Implantation is eccentric, not in the center. Because of the eccentric implantation, what is there? There is an asymmetric enlargement of the uterus. This is called a Piscasex sign. When you do a vaginal examination, you find there is an asymmetric enlargement of the uterus, again felt around the time of implantation. Then you've got the Braxton Hicks. Braxton Hicks, you know. What is Braxton Hicks? Braxton Hicks contractions are irregular, they are infrequent, they are spasmodic, usually painless, and it does not cause any without cervical dilatation. When is it found? It starts from early pregnancy itself and it continues till term. Then we have got quickening. What is quickening? The first appreciation of the fetal movements, felt at around 18 weeks in a primigravida and possibly 2 weeks earlier in a multi. Before we move on to internal and external ballotment, let me just tell you, you've got so many named signs. It is difficult to remember all of these. But one clue or one easy way in which you can remember is all the name signs. See, Jacumer, Chadwick, Osiander, Hagar, Goodell, all the named signs are in early pregnancy, that is around 6 to 8 weeks of pregnancy. So if you get a question, always go for early pregnancy. Within 8 weeks or maximum within 10 weeks, all these signs, all the named signs. While Braxton Hicks, you know, it extends till term, while the other signs that are not named, like quickening or lightening or internal ballotment, external ballotment, all these are felt towards the later part of the pregnancy. Questions more often come from a named sign. Okay. What is internal ballotment? Internal ballotment means if you do a vaginal examination and you tap the baby, you can feel the baby on your examining hand, which is kept at the fundus of the uterus. Baby can be tapped in between. This was used to differentiate between a pregnancy and a fibroid. Internal ballotment is felt from 16 to around 28 weeks of gestation. Likewise, you've got an external ballotment, which is if you tap on one side, you can feel the baby on the other side, which is felt at around 20 weeks of gestation. Then we've got lightening. What is lightening? As the baby's head becomes engaged, the baby's head enters the pelvis, the baby falls downwards and the uterus will fall downwards and forwards. This will relieve a pressure on the diaphragm. That is why it is called lightening. Felt at term, that is around 38 weeks of gestation. When can you start hearing the fetal heart sounds? That is also important. Fetal heart sounds, fetal movements can be detected by Doppler. When? Detected by Doppler at around 10 weeks of gestation. And you can palpate the palpation of the fetal movements can be felt by around 20 weeks of the gestation, and also the fetal heart sounds become audible by a stethoscope at around 20 weeks. Alright, you can palpate fetal movements, you can feel fetal parts, you can hear the fetal heart sounds. All this is by 20 weeks, while the fetal movements can be detected on Doppler by around 10 weeks of gestation. So, we have the next question there. Did we have our answer? What was our question? Yes, most conclusive sign of pregnancy is fetal heart sound auscultation. Let us take up our next question. Question number 9. A lady presents with 7 weeks amenorrhea, presented with slight vaginal spotting. Her CRL was 5 millimeters with well-formed gestational sac with a calculated GA of 5.6 weeks on transvaginal scan, what is the next line of management? Now we are coming to the diagnosis. This is early pregnancy. Why does she have slight vaginal spotting in early pregnancy? It could possibly be an implantation bleed. They've taken an ultrasound. When is the ideal time to take an ultrasound? A first pregnancy ultrasound is ideally taken at the booking visit, right when the woman comes to the OPD, followed by which is the dating scan. Fetal heart starts beating by around 36 to 37 days of gestation, but you cannot see it then. What are the things that you will be looking for, or what can you see? It is different on a transvaginal scan and a transabdominal scan, all right. So the first sign of pregnancy is the gestational sac. A gestational sac can be seen by a transvaginal scan at around 4 to 4.5 weeks of gestation, while in transabdominal scan it's always 1 week more at 5 weeks. The next one, or the first structure to appear inside the gestational sac, which is the yolk sac, it can be seen at 5 to 5.5 weeks of gestation, whereby in a transabdominal scan that is around 6 to 7 weeks. Then you've got the cardiac activity. The cardiac activity or the cardiac pulsations can be seen at around 6 weeks by transvaginal scan and by 7 to 8 weeks by a transabdominal scan. Alright, here they have got a well-formed gestational sac. A gestational sac is the first structure that you use for calculating a gestational age if you do not have a fetus. Okay, it is calculated based on the mean sac diameter. So based on the mean sac diameter, that is, if you have a mean sac diameter in millimeters plus 30 will give you the gestational age in days. If you have got a question like there is a early pregnancy, they have done a scan and they found that the mean sac diameter is 5 mm. What is the gestational age? It is 5 plus 30, that is 35 days. She is 35 days pregnant, and you can calculate the weeks from that. Okay, here they've got a CRL is there. She has already got a crown rump length. The fetus has formed. So you have the gestational sac, then you have the yolk sac. But this is not the most accurate measure of gestational age. The most accurate measure of gestational age is the crown rump length. That is the outer margin of the cephalic pole to the rump of the fetus. It is ideally measured at 7 to 10 weeks of gestation. You might get a difference of within 3 days. Okay, before we move on with the question, let's take a short break. All right, so we were talking about the crown rump length, which is measured at 7 to 10 weeks, which will be accurate to up to 3 days. So, this can be measured from up to 84 millimeters will give a correct value of the crown rump length. The smallest crown rump length that is visible, it is even visible at around 3 to 4 millimeters. Look at our question, our crown rump length was only 5 millimeters and they could already measure it out. What is the importance of calculating the crown rump length and the gestational sac in addition to the dating? Let us look at the question once more. Be very careful with these kind of questions. You have a crown rump length of 5 millimeters. There is a gestation sac. They have calculated the TVS, I mean, they have calculated the gestational age also. You need to know the next line of management. See here, they have only measured the crown rump. They have not mentioned anything regarding the cardiac activity. So, we assume that there is no cardiac activity that is seen yet. So, if a cardiac activity is not seen, we cannot comment on the viability of this pregnancy. So, what we need to do is, we need to see a cardiac activity. We tell her that we will repeat the transvaginal scan after 1 week, because we had said that by a vaginal scan, you will be able to identify the cardiac activity by 6 weeks. She is almost 6 weeks, not yet reached 6 weeks. So, by the time she comes for a next scan, that is nearly around 7 weeks, you should be able to see a cardiac activity. You should also be able to see an increase in the crown rump length. A crown rump length that is 7 millimeters or more with no cardiac pulsations, or a mean sac diameter, that is a gestational sac measurement of 25 millimeters or more with no yolk sac, in all probability will indicate a missed abortion. So, if the question said you had a crown rump length of 8 millimeters and a well-formed sac, what do you do next? In all probability, it is a missed abortion. But even so, you will have to go for, you will ask her to come back after 1 week for a scan. Okay, that will be your best answer. I have given a couple of pictures here. These are all pictures of early pregnancy scans. Here you see, this one here, this is the gestational sac. See how well rounded that is. This is a good gestational sac. Like we mentioned before, this is the uterine cavity and this here is the uterine cavity, and the sac is implanted to the laterally to the uterine cavity. Around the sac, you are able to see some hyperechoic area, right? This is called a double decidual sign. What is this? A double decidual sign. I'll tell you about the importance. Also, look at how the uterine cavity is. See? And look where the sac is. This is called the intradecidual sign. The double decidual sign and the intradecidual sign are both representative of an intrauterine pregnancy. If at all there is a pseudo sac which is occurring in an ectopic pregnancy, you will see that the sac is in the center of the uterus. A double decidual sign and intradecidual sign cannot be seen. You get this picture, you go for, you ascertain that it is an intrauterine pregnancy. Here you've got something else. You've got two sacs. See, there is one here and another one here. The one that is perfectly round, this one here, this is the yolk sac. This is the yolk sac. And here, this is the amniotic sac. This is also indicative of an intrauterine pregnancy. And this, it is called the double bleb sign. You can see two blebs, right? This is the double bleb sign. So, what you need to remember is, what are the two blebs that are seen in a double bleb sign? It is the amniotic sac and the yolk sac. Alright, this is also absent in an ectopic pregnancy. So, what was the question? 7 weeks amenorrhea, 5 millimeter CRL, what will you do? You will wait for another week and repeat a transvaginal scan. Okay, that is your answer. Question number 10. What is the given procedure? Identify the given procedure done in the labor room. See, this is the most common screening test that is done. What is this test? This test is the NST. It is the NST. You have all seen an NST being done. The principle of NST is that there will be a spontaneous fetal heart rate acceleration associated with the fetal movement, which is an indicator of the fetal well-being. When is the NST done? NST should become reactive by 32 to 34 weeks. Usually it is repeated weekly from 32 to 34 weeks. But if it is a high risk pregnancy, it starts from 26 to 28 weeks, where you may have to repeat it twice weekly or even daily. How do you read an NST? There I have given you a picture of a normal NST. This is a normal NST. How you read NST is based on something called you have a mnemonic for that. It is a Dr. C. Bravado. Dr. C. Bravado. DR means doctor. It stands for, first of all, what do? You define risk. Is this a high risk pregnancy or not? Next, you look at the contractions. How can you assess the contractions? By looking at the tachometer that is connected along with the NST. Here, there are no significant contractions. See, no contractions. Then we have got the variability. For an NST to be normal, there must be a variability of 5 to 25 beats per minute. This variability here, this is the single most reliable sign of fetal compromise. Okay, that is with regard to variability. See how there is a beat to beat variability in this NST. Then we come to acceleration. Acceleration means with every fetal movement, these arrows shown here, these arrows, these are fetal movements. With every fetal movements, there is a jump in the fetal heart rate of around 15 beats per minute that will last for 15 seconds or more. See, that is the acceleration. Then we've got deceleration. Again, there is a fall in the fetal heart rate of 15 beats per minute or more. Here there are no deceleration. There should not be a deceleration in normal NST. After this was acceleration, and then you had deceleration, and then you go for the overall assessment. You give an overall assessment, then you comment and manage. Here you find that this is a reactive NST. You needn't do anything. She can, depending on her risk status, she can come back after 1 week or maybe after a few days to take a repeat NST. Here I've given you some decelerations. Decelerations are of 3 types. They can be an early deceleration, variable deceleration, or a late deceleration. An early deceleration means the nadir of the deceleration will correspond to the peak of the contraction. This here, the one in green, that is an early deceleration. See how it corresponds. Then we have got a variable deceleration where there is no relation with the contractions at all. Then we have a late deceleration where the deceleration begins after the peak of the contraction. What causes the deceleration? These are the deceleration pattern. You can study it this way, wheel chop mine. If it is a variable deceleration, most commonly caused by cord compression, what do? You reposition the mother. You ask her to turn to one side, okay, and see if the deceleration is getting corrected. Then we have got the early deceleration, most commonly due to head compression. What do then? You identify the labor progress. You can do a PV and see whether the head has descended into the pelvis. Then we have got the late deceleration, which is the most ominous of the deceleration. In this case, you need to execute interventions. What are the interventions? If the woman is in labor, if she is on oxytocin, you have to stop the oxytocin. You may have to give her oxygen via mask. If none of these work, you will have to take her up for a cesarean section in order to save the baby. Then you've got the acceleration. Accelerations are okay. There are no need for any interventions. What is the basis for performing an NST? We talked about what is a reactive NST. Suppose a woman presents with no fetal movements. She says that she's not appreciating fetal movements. You do an NST. You find that there are no accelerations. That is, it is suspicious. There are no decelerations, but there are no accelerations also. In that case, you wait for 20 minutes. You repeat the test. Again, you find that there are no accelerations. You say that it is a non-reactive NST. What do? Then you will go on and perform a biophysical score or a confirmatory test. We'll discuss that in the next question. But if the woman is having persistent late or variable decelerations, you will have to think about delivering the baby. Here, this is a different kind of NST. This NST has got a stable baseline, right? The baseline is stable. It is remaining between 120 and 140, stable baseline. But the variability is fixed. A base-to-base variability is not seen. It just goes like that in a sinusoidal pattern. There is no acceleration also. This NST is indicative of severe fetal anemia. Where can you see severe fetal anemia? It may be associated with an Rh isoimmunization. It may be associated with a ruptured vasa previa. It may be associated with a twin-to-twin transfusion syndrome or a fetal intracranial hemorrhage. That is with regard to NST. Now we come to the next question. Which of the following is not a component of the biophysical profile? We had just discussed that if we get a non-reactive NST over 40 minutes, we will be going on to do a biophysical profile. What is a biophysical profile? You know it is a scan. What is not a component is the question. When do you do? What are the indications for doing a biophysical scoring? First one we just said, it is a non-reactive NST. In case of a high-risk pregnancy. These are the main indications of doing a biophysical scoring. Now we come to the components. What are the components? The first one is an NST itself. Then you've got the fetal breathing movements, where there should be at least one episode of a rhythmic breathing movement over lasting for 30 seconds, in a 30-minute period. Then you've got fetal movements. There must be 3 or more discrete limb movements which should within 30 minutes. A fetal tone, that is one or more episodes of extremity extension and return to flexion. And then amniotic fluid volume. You don't have to study all this. You have to know the components of the biophysical score. How it is scored? It is a score of 0 or 2. That is a maximum. There are 5 components. So the maximum score possible is 10. See, you can remember it this way, like Batman. There is a breathing movement, amniotic fluid volume, tone of the fetus, movements of the fetus, and the non-stress test. All of these indicates an acute state of the fetus. All these indicate acute state of the fetus except for the amniotic fluid volume, which indicates a chronic hypoxia. I'm just mentioning the things that you need to know with regard to your exam. Don't study all this. What are the components? What represents chronic? What represents acute? And the next thing is the first marker affected. The first marker affected is, what did we talk about before? What is the first indication for doing a BPS? It is a non-reactive NST. So, the first marker affected is the NST. These are the things that you need to know with regard to BPSC. Now, we can talk about the management. You have got a score of 10. You say that it is a normal, non-asphyxiated fetus. No need to do anything. If it is 8 on 10 with a normal amniotic fluid volume, again, there is no need for an intervention. You can repeat it weekly. Or usually you get a score of 8 to 8 if the NST is not being done. After that, a lower scores depends on the gestational age. Always you remember, if the gestational age is 36 weeks or more, then you can go ahead and deliver the baby. The problems come when there is a lower score with a lower gestational age also. For example, see, here if the score is 6 but the amniotic fluid volume is normal, and if the woman has not yet reached term, you might have to repeat the test when in 24 hours time. All right. Then you have got further reduction in the amniotic fluid. But if it is very low, 0 or 2, then you have to go ahead and deliver the baby. So, since we have studied all this, we learned that it takes at least 30 minutes to do a biophysical scoring. You don't have that much time. What will you do? You can go ahead and do a modified biophysical scoring, which takes only around 10 to 20 minutes. There are only 2 components, that is the NST, which is one representative for the acute state, and then you can measure the amniotic fluid index, which is the measurement of the chronic state of the baby. If the NST is normal, the amniotic fluid index is normal. That is, if the modified BPP is normal, then you can repeat the test weekly. If the modified BPP is found to be abnormal, then you have to go ahead and do a full biophysical scoring. Alright, that is about the biophysical scoring. What was our question? Which is not a component. Remember Batman, fetal tone is a component, non-stress test and amniotic fluid index are also components. So, which is not the component? DFMC, daily fetal movement count, is not a component of the biophysical scoring. Next question, which of the following statements is false? Each trimester has approximately 14 weeks. You know that is correct. How do you calculate the period of gestation? How do you obtain the accurate gestational age? And gestational sac is the earliest sign. This you know. Accurate gestational age from the CRL, that also you know. Each trimester has approximately 14 weeks. Yes. How do you calculate the period of gestation? How do you calculate the EDC? From the first day of the last menstrual period. You know that it is based on the Nagel's rule. I am not going into the details now. Then you've got the period of gestation on the basis of ultrasound. At 8 to 12 weeks, that is during early pregnancy, it is measured using the crown drum length. In the second trimester, you start using the BPD or the head circumference, and in the third trimester, you use the femur length. Okay, this is very important. We measured, we talked about the differences in the TVS and TVS of the gestational sac. This one also we discussed. What is the finding diagnostic of an early pregnancy loss? 25 millimeter more without a fetal pole, and a crown drum length of 7 millimeters or more without an cardiac pulsation. So here your answer is the period of gestation is not calculated from the last day. It is calculated from the first day of the last menstrual period. Increased nuchal translucency at 14 weeks is suggestive of. What is nuchal translucency? I have a picture here for you. It is the maximum thickness of this subcutaneous translucent area between the skin and the soft tissue which overlies the spine. This is the nuchal translucency. The nuchal translucency is the best marker for aneuploidy in the first trimester. When do you measure it? It is measured when the CRL is 38 to 84 millimeters. Remember that it is the best marker. What aneuploidy is? We are thinking about a Down syndrome. We are thinking about Edwards syndrome, that is trisomy 18, or a Pato, that is trisomy 30. These are the aneuploidies that you usually consider. How do you screen for Down syndrome? We have the first trimester screening, that is a nuchal translucency along with the biochemical markers. What is it? PAP-A and HCG. This together, this is called the Down syndrome screening. This is the double test, double marker. Okay. Later on, you've got the triple test, that is in the second trimester with the nuchal fold. You can look for the triple test, which comprises beta HCG, unconjugated estriol, and AFP. A quad test will include all these plus inhibin. You have to remember the markers. What happens in Down syndrome? H for H, high is HCG. Here also, if you're doing a double test also, you'll find that the HCG is high, PAP-A is low. Triple test also, you find HCG is high, the others are low in Down syndrome, remember. In the quad test, HCG and inhibin are high, the others are low. We just talked about AFP, so you need to know a couple of things regarding AFP. AFP is a glycoprotein. It is synthesized by the yolk sac in the early weeks, and later on it is synthesized by the GIT and the liver also. It is the AFP is the most abundant protein. It is the most abundant protein in fetal serum. Right? It increases till 13 weeks and then it decreases for the rest of the pregnancy. It remains that way. It remains at birth, it reaches around 1 nanogram per ml and it remains at that way till the end of life. Okay. So, it diffuses across the fetal membranes and can be found in the maternal serum. The concentration starts along with the increase in the fetus. The concentration starts increasing after 12 weeks and the maximum in maternal serum is at 28 to 32 weeks. So, we said that this increases due to diffusion. So, any open ventral wall defects, you can find that there is an increase in the maternal serum AFP. Look at this. If it is a wrong gestational age, if it is a greater gestational age, there can be greater AFP. Open defects, open neural tube defects in multiple pregnancy, in RH isoimmunization, in intrauterine fetal demise, if there are anterior abdominal wall defects, in all these, you can find that MSAFP is increased. Okay. When do you see a low level of MSAFP? We have got devil's gut, which is mnemonic that you can use, diabetes mellitus, gestational trophoblastic tumor, overestimated gestational age or obesity in abortion. In trisomies 21 or 18, you can find that the levels of MSAFP are low. There are a couple of other markers, that is acetylcholinesterase and pseudocholinesterase, also known as butylcholinesterase. This is the one that can help you differentiate between a neural tube defect and an abdominal wall defect. Acetylcholinesterase is high in neural tube defects and low in abdominal wall defects. Likewise, you find that the pseudocholinesterase is in low in neural tube defects while it is high in abdominal wall defects. Also look at the ratio, more than 0.14, that is acetylcholinesterase to pseudocholinesterase is more than 0.14 in a neural tube, less in an abdominal wall defects. Now, we talked about the screening test, that is a nuchal translucency. First trimester screening will include the combined test, that is the beta HCG, PAPE and the nuchal translucency is a combined test. Second trimester it's a quad test or a triple test. This is only screening. You need a diagnostic test. What are the diagnostic tests that you know of? Along with these screening tests, there is one other test which is the NIPT. Are you familiar with this? This is a non-invasive test where it measures the cell-free fetal DNA in the maternal blood. This has got a diagnostic value of sensitivity of up to 99%. Again, this is a screening test. You will need to do a confirmatory test. We'll start with the first one, which is the chorionic villus sampling, which is done in the first trimester. What do you do in chorionic villus sampling? You can take trophoblastic cells from the chorionic villi. This can be used to diagnose inborn errors of metabolism, chromosome anomalies. You can do DNA analysis. You can detect hemoglobinopathies. More importantly, in the first trimester diagnosis of the Down syndrome. Remember that this is not suitable for any structural defects. All right. So what we'll talk about the adverse effects. Adverse effects is obviously it is an invasive test. The first one is always abortion. There is around 1 to 2% rate of miscarriage. This is not the one that is important for your question. Your question will be, what happens if it is done below 9 weeks? Usually it is done after 10 weeks of gestation. If it is done at less than 9 weeks, there is an increased chance of oromandibular limb hypogenesis and limb reduction defects. There can also be a rupture of membranes, a preterm rupture of membranes can occur. Obviously, since it is invasive, there can also be infection. But the important thing you need to know is the increased chance of the oromandibular limb hypogenesis and the limb reduction defects if it is done before 9 weeks of gestation. That is with regard to the chorionic villus sampling. Now we come to amniocentesis. I believe you are more familiar with this. Amniocentesis is done at 15 to 20 weeks of gestation. You can do it using the amniocytes or the fibroblasts from the amniotic fluid. Again, you can detect sex-linked disorders, karyotyping, inborn errors of metabolism, neural tube defects. Also for fetal lung maturity, we talked about the lecithin sphingomyelin ratio. You can detect Rh isoimmunization from the color of the amniotic fluid. You can detect whether the liquor is meconium stained, right? What are the complications? Like before, she can have infections, she can have rupture of membranes, there can be abortion. Obviously, the rate of abortion is much lesser compared to chorionic villus sampling. This is only around 0.3 to 0.5%. Okay, there can be trauma, there can be because of the loss of the fluid, just all the complications of oligamnios you can see here, right? You're taking out the amniotic fluid. No, there can be fetal lung hypoplasia, there can be respiratory distress syndrome, there can be talipes. All these can be seen in amniocentesis, right? Next one is chordocentesis. Chordocentesis is also known as the perumbilical blood sampling. It is done after 20 weeks of gestation. after 20 weeks. It is done from the umbilical vein. What is the most common indication? Most commonly, it is done for evaluation and treatment of fetal anemia, where in RH isoimmunization. Here also there is a risk of miscarriage, which is around 1.5 to 2%. That is with regard to the diagnostic tests that are performed. So, what is the increased nuchal translucency at 14 weeks suggestive of? It is suggestive of Down syndrome. Okay, with that we will move on to our next question. This is about the anomaly scan. We have a routine ultrasound done at 20 weeks for a 31-year-old gravida 1 parasero. It revealed an anomaly. The patient comes to you with the following ultrasound film for a second opinion. What congenital anomaly would you explain to the couple? See, they have already marked the neck, the spine and the base of the skull. But what happens is, whatever structures that were above this, that is cranium and the other telencephalic structures above the base of above the skull base, above the orbit are absent. This condition is called anencephaly. Anencephaly is also a condition that you are familiar with. All right. What happens? The forebrain and the midbrain are absent. Cerebellum may be present. Cerebellum is present. The hind brain is also present. The pituitary gland is either absent or it is hypoplastic. The adrenal gland also decreases in size. That is with regard to anencephaly. See, there is another picture. This is the coronal view. This is called the frog eye appearance. See, doesn't it look exactly like a frog eye? What is this? That is, this is the coronal plane. You find that there is a cerebellar lobes are seen above as semicircular structures like this. This is what produces the frog eye appearance. This is also called the Mickey Mouse sign. So, if you are asked where a frog eye appearance or a Mickey Mouse sign is seen in ultrasound, your answer is in anencephaly. How can you detect it? It can be diagnosed by ultrasound, by an anomaly scan. Definitely you can diagnose it, but there is an increase in the serum MS-AFP. We discussed this before. This is a few things that you need to know with regard to anencephaly. This is the most common anomaly that is responsible for face presentation. If this progresses or if the woman goes into labor, the complications that are specific to anencephaly that in labor include, there can be obstructed labor and pseudo shoulder dystocia. Because the head will immediately come out through the cervix will not be cervix will not be fully dilated, or there may not be adequate space in the head will come, but the shoulders won't come. There is the structure, the cranial structures are not there. No. How do you diagnose? You talked about the screening. The screening is by, you can detect that there is raised amount of maternal serum alpha fetoprotein. But no, this is not the most specific marker. It is a neural tube defect. We talked about the marker for the neural tube defect. The most specific marker is the serum acetylcholine esterase. But if you're asked what is the investigation of choice, it is ultrasound. Okay, that is with regard to anencephaly. How do you treat it? What is the treatment of choice? This is not an anomaly that is conducive to life. So, if you detect anencephaly, your treatment of choice is to terminate the pregnancy. Okay. Since we are talking about anomaly scan, I have also given another picture here. Look how this looks like a lemon. Okay. The lemon sign or a banana sign is a sign of the cerebellum here. That is a banana sign. The lemon sign and the banana sign are usually seen in open spina bifida, meningomyelocele and Chiari malformation. Again, they are seen in neural tube defects. Okay, you need to remember that. So, we have got the answer there. Going on to the next question. Now, we come to the Doppler. You have a 28 weeks pregnant female. She presents with the fetal distress on examination and the test performed. That is an MCA Doppler is given below. What should be the next step in the management? What is a Doppler? A Doppler is done to assess the uterine, the placental and the fetal arterial and the venous systems. Basically, there are three vessels where you do a Doppler, which is the uterine arteries, the umbilical artery and the middle cerebral artery. Here they have given the MCA Doppler. What will you do? Look at this. I've given some Dopplers here. You can see the differences, right? This is a normal Doppler picture. This is a normal Doppler. What do you see here? Here you find that this part is not there. This part where the diastolic flow was supposed to be is absent. So we say this is an absent end diastolic flow. Here you find that the diastolic flow has been reversed. Both absent and reversal of end diastolic flow are ominous signs for the baby, and management depends on the gestational age. See, this lady, she is only 28 weeks pregnant. How will you manage her? Suppose she had a normal Doppler. Normal Doppler. A normal Doppler is reassuring for 1 week. If it is an absent end diastolic flow and it is more than 34 weeks, then you should consider delivery. If there is a reversal of end diastolic flow, you should definitely consider delivery, whatever the period of gestation may be, provided the baby is viable. That is around 28 weeks itself, you should think of delivery, because if there is a reversal, there is a high chance of intrauterine demise within 1 to 2 days. So it is ideal that you terminate irrespective of the gestational age. Here, she is 28 weeks pregnant. The baby has not yet attained lung maturity, but this is the Doppler. What has happened to the Doppler? There is an absence of the end diastolic flow. At 28 weeks, if she had shown a reversal, we would have delivered without waiting. But since there is an absent end diastolic flow, we can give a steroid cover so that whatever lung maturity we can afford to make for the baby, we can do. But still, you have to consider delivery. So you give a steroid cover, you monitor using Doppler and biophysical score, and then you plan the delivery. That is the answer. I hope you have understood how we have arrived at the answer, right? If you have got any doubts regarding this, please put it down in the comment section, because we cannot go into the details of the Doppler all now. Coming to the next question. You have a pregnant woman. She is coming to the clinic. She already has twins by a normal delivery. What is her obstetric formula? This is very simple. You all know how to do the obstetric formula. You need to know a couple of things. What is gravidity? It is a pregnant state, which will include both the present and the past, irrespective of the gestational age. Then you got the parity. Parity means a previous pregnancy which has crossed the period of viability. What is the period of viability in India now? The period of viability is 24 weeks. Any past pregnancy that has cross viability, it does not involve the number of children, and it does not involve the present pregnancy. It does not involve the present number of living children also. I've given a few examples. I don't want you to be confused by this, because this is one place where you can definitely get, because you have been practicing this also in your house urgency, etc. So you need to get this right. Here you have a pregnant woman. She has twins. They have not mentioned anything regarding, the live birth status has not been given in the choices. When we say that she had twins by a normal delivery, we assume that it was a viable pregnancy. So here, this is a second pregnancy. She already has twins. So the answer is G2P1. Okay, G2P1. So let us try doing a few examples. First off, we have got the GPLA status. This we'll take this question only. This is her second pregnancy, G2. She has had one pregnancy with twins, P1. How many children does she have? L2, because she had a twin pregnancy. Right. So GAB plus C. This is also being used now. We'll take a woman. She has, suppose I'll give you a question. You have got a woman. She is, say, 12 weeks pregnant with one child who is 4 years old. She gives a history of one intrauterine demise at 30 weeks and one abortion. How do you go about this? So now she is pregnant. She is 12 weeks pregnant. She has one child. She had an intrauterine fetal demise. She had one abortion. So each of these you can calculate for your gravidity. That means she is a G4. What about her parity? She has one child who has crossed 4 years, and then she has got an IUD at 30 weeks. That is also that can also be included in parity. That is B plus C means what? She has got a 2 and then she has got one living child. That is the GAPB plus C. Again, if you are going for this same question, let us take, you know that the gravidity is 4. T stands for the term pregnancy. What one pregnancy has reached term. So 1 plus P for parity. How many parity, how many times has she had a parous pregnancy, a viable pregnancy? Twice. That is 2. Plus how many abortions? 1. How many living children? 1. Okay. That is how you calculate the GPLA status. Next question. The number of fontanelles present in a newborn child is, this is easy. The newborn child has got how many fontanelles? 6 fontanelles. There is one anterior, one posterior, 2 anterolateral and 2 posterolateral, which is the sphenoid fontanelle and the mastoid fontanelle. Okay. So in all she has got 2 of this, and one anterior, one posterior. That is, the newborn child has got 6 fontanelles. Now look at the diameters of the fetal skull. Usually, if it is a vertex presentation in a well flexed head, what is the diameter that you expect? It is the well flexed. What you are expecting is the submentobregmatic diameter, which is around 9.5 centimeters. That is one diameter that you need to know, 9.5. Then you have got another diameter, the mentovertical diameter, which is how much? 14 centimeters. It is seen in bro presentation. It is because the mentovertical diameter cannot maneuver the pelvis that there is no mechanism for delivery in a bro presentation. Alright. So these are the important diameters. Here, this is what you need to know. You know the you need to know the mnemonic. It is Miss Tina so pretty, which is the smallest diameter. It is the bimastoid diameter followed by the bitemporal diameter. The longest will be the mentovertical followed by the submentovertical or the occipitofrontal diameters. Now we have a few things to say about the pelvis also. We have discussed the fetal skull. As far as the pelvis is concerned, what are the important things you need to know? Again, you need to know the longest diameters, the shortest diameters. Which is the shortest diameter? The shortest diameter of the pelvis is the interspinous diameter, which is only around 10 centimeters. The longest diameter will be the anteroposterior diameter of the outlet or the transverse diameter of the inlet, which is 13 centimeters. Okay, this the obstetric conjugate of 10 to 10.5, 10 centimeters is the most important diameter as far as the pelvis is concerned. And then we've got comparison between the male and the female pelvis. I am pretty sure you know all about this, but just go through quickly so that if there is any one point that you might miss, you can catch on to your head. Okay. Remember that the preauricular sulcus is absent and the ischial spines are more prominent in the male pelvis. Okay. Next question. You have a 32-year-old pregnant female with the infraumbilical flattening. Fetal heart rate is heard in the left flank. Which of the following will be the most probable presentation? Now we are coming to presentations. Presentation means with regard to presentation, what you need to know is it is the relation of the denominator, that is the most prominent part on the presenting part to the different quadrants of the pelvis. Okay, here you have got a subumbilical, infraumbilical flattening. Fetal heart rate is on the left flank. What is the presentation? This one here, this is an example of an occipito-posterior presentation. We've got the pictures here. Occipito-posterior means probably this is a, since it is heard on the left flank, this is a left occipito-posterior. The presentation, as the fetus enters the pelvis, there are certain mechanisms of delivery. We'll come to that. Anyway, the most common position of the fetus is the left occipito transverse position. This is the most common position. Usually, the fetus delivers occipito anterior. The most common occipito anterior position is the left occipito anterior position. The most common occipito posterior position is the right occipito posterior position. What about a breech? The most common position in breech is the left sacro-anterior, and in a face presentation it is the left mento-anterior position. That is with regard to the positions. Here when you say that it is occipito-posterior, means that the occiput is directed to the posterior, the sacroiliac joint posteriorly. Okay, this is the left occipito-posterior. You find that the heart will be in the flank. There is also an infraumbilical flattening. Whenever you get a question that says that there is an infraumbilical flattening, remember that this is a posterior position. Okay. Now we have our next question. A primigravida, she came to the labor room at 40 weeks and 5 days of gestation for induction of labor. On PV, you find that the cervix is 1 centimeter dilated, 30% effaced, vertex is at -1, cervix is soft posterior. What is the modified Bishop score? I know that you know what are the components of the Bishop score, that is PDESC, that is position, dilatation, effacement. Then we have got the station of the head and the consistency. I don't think there is a problem remembering that. So the problem comes when you are asked to calculate the Bishop score, especially in the exam settings. This was a previous Bishop score. Now we have got the modified Bishop score. I'll try to make this easier for you. The Bishop score is scored from 0, 1, 2 and 3. Okay, 4 scores, 0, 1, 2 or 3. What are the components? You'll start with the position of the cervix. Where is the position? It can either be posterior, it can come forward like mid position or anterior. So when you score, you say posterior means it is 0. Posterior, mid position or anterior. You've got those scores. No, we have discussed the position. Then the most important parameter, the most important thing here is the dilatation of the cervix. Is the cervix open? No, the cervix is closed. That is 0. After that, see where it goes. 1, 2, 3, 4 and 5. 1 to 2 centimeters, its score is 1. 3 to 4, the score becomes 2. And if it is more than 5, the score becomes 3. Okay. That is about the dilatation. Now we'll talk about the effacement. There is some change. Previously it was in percentages, 0 to 30, 30, 40, 50, 60, 70, 80 it was. Okay. 0 to 30 being score 0, 40 to 50 being 1, 60 to 70 being 2 and 80 or more being 3. Now there is a slight difference. It is the score is 2 or more, 1 to 2 and less than 0.5. This is how the latest score is. The modified score is like this. Cervical length, so you can it goes down to 1 to 2, less than 0.5. Length is decreasing, right? So that is about the cervical length. It is also only 0, 1 and 2. There are only 3 parameters. So we have the dilatation, we have the effacement or the cervical length, we have the position. Now we come to the station. Where is the head? We'll start with -3. -3, -2, -1 or 0, +1 and +2. Again, there are 4. And that is with regard to the Bishop score. See, you can learn the Bishop score only by practicing. I have actually tried to make this easier. Look at it. You have done the vaginal examination. Where is the cervix? First, you look where the cervix is. The cervix is posterior. What is the Bishop score? For the posterior cervix, the Bishop score is 0. Then, what is the dilatation of the cervix? It is only 1 centimeter dilated. We had discussed before, if it was 0, if it was not dilated, we would have said the Bishop score is 0. Here it is 1 centimeter dilated. 1 to 2, the Bishop score becomes 1. Next, you have the dilatation. You look at the effacement. Here they have given a percentage. 0 to 30 means how much effaced? It is 0. Now we have come to the effacement. What else do you look for? what we are also to discuss the consistency of the cervix. What is the consistency of the cervix? It is soft. Cervix can be firm, medium consistency, or soft. Soft means the score is 2. Where is it? Where is the station of the head? It is -1. 0 and -1 will give you a score of 2. That means 2 plus 2, 4 plus 1, 5. Your Bishop score is 5. You may hear PV examinations. You can form PV examinations of your own and try to write out at least 3 or 4 Bishop score before you go for the exam, because at that moment if you try to calculate, you'll find that you're forgetting the table. If you've learned it beforehand, you'll have no problem in calculating the Bishop score. What is the importance of calculating a Bishop score? If the Bishop score is less than 4, it means that the cervix needs ripening. How do you ripen the cervix? These are the methods. You've got some mechanical methods and you've got some pharmacological methods. Mechanical means you can do a PD examination. You can stretch and sweep the membranes to release prostaglandins, which will help in cervical ripening. You can keep in some mechanical dilators like Foley's catheter. You can go for extraamniotic saline infusion, right? Then you have got the pharmacological methods, which will include misoprostol, dinoproston gel, sometimes mifepristone, relaxin. Okay, all these are the methods that are used for cervical ripening. Next question. A nursing assistant posted in obstetric care was asked to plot a partograph to monitor the progress of labor. How much dilatation of the cervix should she start plotting the graph? We are coming to partogram. Partogram is the best method to assess the progress of labor. This is usually done in a place where a hospital that is being run by midwives, or where nursing assistants are conducting the delivery. It is very helpful for them. So we have a picture of a partogram here. There are 2 lines. You have got an alert line and an action line. When does the partogram start? Previously, partogram started in the latent phase of labor itself. Now, partogram only starts in the active phase of labor, which is presently defined as 4 centimeters. The latest WHO care guide, if you are asked instead of the partogram, if you are asked in the WHO care guide, labor care guide, where does the partogram start? You have to say it starts at 5 centimeters. Okay. Here the partogram starts at 4 centimeters. As the labor progresses, we will be plotting the dilatation of the cervix and the descent of the fetal head on the partogram. So, we expect that the rate of progress of labor, if at a minimum of, the labor should progress at a minimum of 1 centimeter per hour, and in this case we expect that the lines will remain to the left of the alert line, that it will not cross the alert line. The action line is drawn around 4 hours to the right of the alert line. Suppose you find that as you are plotting the graph, you find that it is crossing the alert line. What does that mean? It means that this is going to be a prolonged labor. In that case, you have to refer the patient to a higher center. All right. That is with regard to the partogram. Next question, you have to arrange in the correct order. This is the mechanism of labor. What is the order? I think you know this. Every decent female I choose to employ rises extremely. First of all, we have got the head floating and then it becomes engaged. After engaged, it starts descending. How does it descend? It descends with flexion. Okay, further descent, there is flexion of the fetal head. After flexion, there is an internal rotation. And once the internal rotation is completed, the fetal head starts to crown. That is, the biparietal diameter starts to come and stretch the introitus. After that, there is extension. Remember that the fetal head is born by extension. There is extension. There is complete extension. Then there occurs restitution, and finally you have got the external rotation and the delivery of the head. So, what is the order here? We have got the engagement, then there is a flexion, then we have extension followed by external rotation. Okay. All right. Along with that, let us just look at the grips. Grips have often been asked. You have a fundal grip where you face the mother, you palpate the fundus and ascertain what is the part at the fundus. If it is a soft, broad, bogey mass, it is the breech. If it is a round, ballotable mass, you say it is the head. Then you go on to the lateral grip, where you have to ascertain where the back of the baby is, where the limb buds are. Then we have the Paulick's grip. The Paulick's grip means you keep the ulnar border of your hand on the pubic symphysis and try to move the part that is occupying the lower pole of the fetus. That is, you can identify which the presenting part is. You can also know whether the presenting part is fixed or not. In the last one, which is the second pelvic grip, what do? You face the feet of the mother. This is the only grip where you are facing the feet of the mother, and then you slowly move both your hands down. What do you want to know is whether the head is well flexed or not. In a well flexed head, you found that you can see that you will be able to palpate the sinciput, that is this part, much above the occiput if the head is well flexed. Also, if you are able to bring together both your hands below the presenting part, it means that the head is not engaged, it is still a floating head. All right. Next question. Mrs. S, she is a G2 P1L1. She presented to the hospital with labor pain. On examination, she had 3 uterine contractions of 20 seconds in 10 minutes. Cervical dilatation was 6 centimeters. Fetal heart rate is 145 beats per minute. What is the stage of labor? We are moving on to the stages of labor. Here she is in stage 1. What is the first stage of labor? First stage of labor means the onset of the uterine contractions from the time the woman starts perceiving true labor pains till full dilatation, till 10 centimeter dilatation is the first stage. Second stage means from 10 centimeter dilatation to the birth of the baby. Then you have the third stage, that is the birth of the baby to the expulsion of the placenta and membranes. Then the fourth stage, which is the 4 hours postpartum. About the first stage, there is a latent phase and an active phase. You need to know this. So many questions have been asked from this. Latent phase is from the time when the mother starts perceiving labor pain till the cervix reaches a diameter of 5 centimeters. This is around 12 hours in a nulliparous woman and 8 hours in a multi. Then we move on to the active phase. Active phase means the cervix is 5 centimeters or more dilated. What is the rate of dilatation? It is around 1.2 centimeter per hour in a nulliparous woman and 1.5 centimeter per hour in a multi. Remember that we started plotting the partogram in the active phase of the labor. So, the minimum dilatation that is needed is 1 centimeter per hour, be it a multi or a nulliparous woman. What about the descent? The descent of the fetal head also occurs at this stage. The descent should also occur at a rate of 1 centimeter per hour in a nulliparous woman and 2 centimeters per hour in a multi. Now you come to the prolongation disorders and the arrest. Prolonged means in the latent phase we said it is 12 and 8. It is said to be prolonged if it is more than 20 hours in a nulliparous woman and more than 14 hours in a multiparous woman. What do? You can get a question like this. There is a woman, she is getting 2 contractions lasting around 25 seconds in 10 minutes. You find that she is dilated 2 centimeters. You repeat a PV, she has been having the same kind of pain for nearly 16 hours. What is the next thing you do? You find that there is no progress of labor. Then the next thing that you do should be, what do? The preferred treatment, or the next thing that you do is therapeutic rest. Therapeutic rest means you give her morphine. She can sleep and she'll wake up after maybe 4 or 5 hours, either in active labor or she will have, the labor pain will have stopped. Okay, that is a prolonged latent phase. What about prolonged active phase? What do you do then? If the active phase is prolonged, as in this case, see, she has got 3 uterine contractions, 6 centimeters, 145 beats per minute. We expect that she'll dilate at 1.5 centimeters per hour. So, you do a PV examination after 4 hours and you find that she's still only 7 centimeters dilated. That means the active phase is prolonged. At this stage, what do? At this stage, you can either you can rupture her membranes, or you can, if her membranes are already ruptured, you can start her on oxytocin because you are suspecting that the contractions are inadequate. Alright. If this does not work, you may have to resort to a cesarean section. What happens if there is an arrest? Arrest means the woman is 6 centimeter or more dilated. She has got ruptured membranes, but she has got ruptured membranes, adequate contractions also, but there is no dilatation for 4 hours. I'll tell you, that is more than 6 centimeters dilated with ruptured membranes. Unless the membranes are ruptured, you cannot diagnose an arrest. With ruptured membranes, she has got adequate contractions also, but there is no dilatation. For how long? For 4 hours. Or suppose she is on oxytocin, she has got adequate contractions but no dilatation. For how long? For 6 hours. In both these cases, you say that an active phase arrest has occurred. What do you do then? In this case, in all probability, you will have to take her up for a cesarean section. Okay, this is with regard to what we are talking about right now is with regard to the first stage of labor before she has reached a full dilatation. Now let us talk about the second stage of labor. What is there in the second stage? In the second stage of labor, it is the expulsive efforts of the mother that are most important. This is also different for a nulliparous woman and a multi. It is in the second stage of labor that you can offer her epidural analgesia. Remember that also. In a nulliparous woman, normally the second stage, that is from full dilatation to the delivery of the baby, will take around 1 hour, and in a multi, it is 30 minutes. You say that it is prolonged, and she is not on epidural anesthesia if it is 2 hours and 1 hour. If she has already taken epidural anesthesia, you say it is 3 hours and 2 hours. Okay, I have studied it this way. I think it will be easier for you also. When do you say it is prolonged? You write it down like this: 1, 2, 2, 3. 1, 2, 2, 3. That is, if this one here, 2 and 3, this is for a multi and this is for a priming. I'm sorry. We have 1, 2, 2, 3. This here, 1 and 2. What is it? It is prolonged without epidural. This one here, this is for a multi and this one is for a nulliparous woman. What happens? What happens? Without epidural anesthesia, more than 1 hour is prolonged. With epidural, more than 2 hours is prolonged. Likewise, without epidural, more than 2 hours for a nulliparous woman is prolonged. More than 3 hours with epidural is also prolonged. So, prolonged, you can learn it 1, 2, 2, 3. What about the arrest of the second stage? Arrest is, you can learn it this way, 2, 3, 3, 4. This one is for a multi and this here for a nulliparous woman. That is, after 2 hours without epidural, she has not delivered. That is arrest. Okay. What is the cause? What are the most common causes? Most common cause is usually a cephalopelvic disproportion. You find that the labor is prolonged. You can do a vaginal examination and assess the position of the fetus. If the fetus is in occipito-posterior position, it might take some more time. In that case, you will wait and watch. You won't do anything. But the management later, as far as the arrest is concerned especially, management depends on the station. You do a vaginal examination. How do you manage? You find that it is below +2. Below +2. At that time, you can go for a vacuum or a forceps delivery. But you find it is the head has not descended at all. It is above +2. Then you will have to resort to a cesarean section. Okay. But suppose there is an arrest, no movement, you should diagnose an obstructed labor. You are doing a PV, you find there is molding, there is caput, it is an obstructed labor. What do? You go for a cesarean section. I hope this is clear. This is very important for your exams. Okay. Let us go to the next question. In shoulder dystocia, what is the next step in management? What is shoulder dystocia? It is a difficulty of the delivery of the shoulders after the head has come out. What are the risk factors? When can you see? You've got a big baby. It's not just a big baby, a diabetic mother with a big baby. That is, the baby has got adipose tissues around the shoulder, making it a chubby baby. That is the first risk factor. Then there is an obesity. maternal obesity or a fetal obesity. It is a post-term pregnancy. Then we discussed pseudo shoulder dystocia in anencephaly. All these are risk factors for shoulder dystocia. Look at this. What is this? This is the turtle sign. Do you see the turtle? What happens here is once the head has delivered, the head will retract against the perineum, just like the head of a turtle goes back into its shell. The head of the baby will retract against the perineum. This is called a turtle sign and is seen in shoulder dystocia. What do? You have diagnosed shoulder dystocia. Then you have got your helper drill. Helper drill means first thing is you call for help. You call the senior obstetrician. You call the anesthetist. Then you put in an episiotomy. You evaluate for the need for the episiotomy. Then legs, the McRoberts maneuver, which is the most important maneuver that you do. What you do is you flex the mother's head. The mother's legs are sharply flexed onto the abdomen. Why? This is to provide more room in the pelvis for the baby. Next, you do give a suprapubic pressure. Remember, it is a suprapubic pressure. Often we see that what happens when there is difficulty in delivering the baby, somebody will jump on top of the mother and start giving fundal pressure like that. No, it is not a fundal pressure. It is a suprapubic pressure to dislodge the shoulder of the baby from behind the pubis. Then we have got the enter maneuvers. The enter maneuvers means you have got the Rubin's maneuver. You can next thing is you can remove the posterior arm. Try to put in a hand and try to take out the posterior arm of the baby so that it will be easier for the anterior arm to just slip out. After that, you have got what is called the Gaskin's maneuver, where you roll the patient over onto an all fours position. Okay, this is the helper drill of shoulder dystocia. What do? You have shoulder dystocia. What is the next step? The best answer here would be call for help, since that is not there. The next one is to episiotomy, that is also not there. What do you do here? You flex the hips onto the abdomen. Flex the maternal hips to allow more room for the baby. What are the problems? What are the complications? The most important complication is the brachial plexus injury. Usually, whenever you have difficulty in delivering out the body of the baby, what do? You start pulling on the head, right? Whatever you get in your hand, you start pulling. At that time, here, the roots of the brachial plexus will get impacted under the pubic symphysis and get injured there. Which can lead on to produce, it can be a high palsy or a low palsy. That is, the child can have an Erb's palsy or a Klumpke's palsy. Right. So, you have got brachial plexus injury. There can be a fracture of the clavicle or the humerus. The baby can have an intracranial hemorrhage. There can be a cervical spine injury. Likewise, the mother can also develop a postpartum hemorrhage or genital tract trauma. Next question. Arrange in sequence for a third stage management. Now we come to the management of the third stage. What is the third stage? You've got the placenta has expelled and now you are trying to manage the third stage of labor. There are two different methods by how much usually the average time for third stage is around 15 to 20 minutes. If more than 30 minutes have elapsed, we say that this is a prolonged third stage. There are two methods by which it can be managed, either physiological or active management. Physiologic method of third stage management means you don't do anything. You just wait for the placenta to separate on its own by gravity and possibly maternal effort, and the cord is clamped later. But now what we follow is the active management of third stage of labor. This will help in reducing the postpartum hemorrhage and blood loss to a great extent. What are the components? As soon as a placenta is delivered, the next thing that you check for is there another baby? Usually, since we've got ultrasound and everything now, this is not that important, but still, check for another baby. Next thing that you do, what do? You give oxytocin. Which is the oxytocin? Which is the oxytocin that is given? It is oxytocin. After that, you go for cord clamping. Remember that there is no place for immediate cord clamping. That is, you can wait for up to 3 minutes to clamp the cord, provided the woman is not bleeding profusely. or the one single most important point where you have to do immediate cord clamping within 1 minute of delivery of the baby is when there is fetal asphyxia, and you need to hand over the baby to the neonatologist so that the baby can be resuscitated. So once the cord is clamped, then you deliver the placenta by a controlled cord traction. You give a controlled pull on the placenta so that the placenta can be delivered out, along with the counter traction on the fundus. Why is this important? So that you don't give undue traction and cause a uterine inversion. All right. So here you check for a second baby, give oxytocin, control cord traction and delayed cord clamping. Okay. These are the components of the active management of the third stage. What is seen here? We said that even after 30 minutes, if the placenta is not separated, we say that it is a prolonged third stage. In this case, you may have to manually remove the placenta. That is what is seen here. This is the manual removal of the placenta, preferably done in operation theatre under general anesthesia. Look how you insert the hand, you go through the plane of cleavage and you bring out the placenta. Next question. A lady with 35 weeks of pregnancy is admitted in view of first episode of painless bout of bleeding yesterday. On examination, her BP is 120, her hemoglobin is 10 and her BP is 120 over 70 millimeters of mercury. Uterus is relaxed, cephalic floating, fetal heart sounds regular. What is the next line? What is your diagnosis? This is a case of placenta previa. She has come with a painless bleeding, vitals are stable. A placenta previa means the placenta is implanted somewhere in the lower segment as opposed to the upper segment. How does this present? It is a recurrent painless bout of fresh bleeding, and it usually ceases within 1 to 2 hours. When you are examining the patient, you find that the uterus is proportionate, it is non-tender, the fetal heart sounds can be heard, and in all probability the head won't be fixed. Why? Because the lower position is being occupied by the placenta, so the head won't be fixed also. Fetal heart sounds are heard well. If you do an ultrasound, you can find the placenta in the lower segment. What is it that you need to differentiate it from? It is an abruption. If it is an abruption, the placenta is attached somewhere normally, but it has separated from there. Okay, and it is a painful condition. The woman will be presenting in pain. The uterus will be tense and tender, and usually you will have signs that are even greater than the symptoms. There will be a fall in the hemoglobin. There will be a fall in the blood pressure. The bleeding may be visible. It may be concealed also. All right. So, what are the things you need to know here? First one is regarding the classification of placenta previa. That is, it is called the Brown's classification. Brown's classification. How was it classified? It is pretty simple actually. You have got the grade 1 where the placenta dips into the lower uterine segment, but it does not reach the os. Then you have got 2 where the edge reaches the os. 3 where it covers the os but not when fully dilated. And 4 when it covers the os even when it is fully dilated. These are the 4 classifications. You know that in 3 and 4 normal delivery will not be possible. You will have to go for a cesarean section. 2, there is 2 can be divided into 2A and 2B. 2B is posterior, also called the dangerous type of placenta previa. All right. 2B, that is the dangerous placenta previa. There also normal delivery is not attempted. You will be going for a cesarean section only. And another thing you need to know is the Stalworthy sign. What is a Stalworthy sign? Stalworthy sign means, suppose you are pushing the head of the baby into the pelvis, there will be sudden fall in the fetal heart rate. Why? Because there will be decrease in the placental perfusion and a sudden fall in the fetal heart rate. As soon as you release the pressure, the heart rate comes back to normal. This is a Stalworthy sign seen in the type 2B or the posterior placenta previa. We are talking about placenta previa. What are the risk factors? The first risk factor is a past history of a placenta previa. Then you have got increasing age, any surgeries that have been done on the uterus, if it is a multiple pregnancy, if there is a succenturiate lobe on the placenta, all these are risk factors for producing a placenta previa. We'll go on to the management. How do you manage? There is something called a McAfee and Johnson's regimen. This is the expectant management of the placenta previa. Always remember, after all, this woman is presenting with bleeding. So, expectant management can be cancelled at any time. How do you determine the expectant management? This depends on the gestational age, whether or not the woman is in labor, and the severity of her bleeding. Like in this case, she is 35 weeks pregnant. She has had, this is her first bout. Her vitals are all stable and her uterus is relaxed. She is not in labor. She has not reached term. You can offer her expectant management or the McAfee and Johnson regimen. How do you conduct? You advise bed rest. She has to be an inpatient. You advise bed rest. You send all the investigations. You inspect her periodically. Then you will have to give her hematinic so as not to produce a fall in the HB. You can do a gentle speculum examination. This is done in a double setup. That is, no PV examination is done, but a gentle speculum examination is done in the operating theatre. Then you can give a tocolysis to prevent her from going into labor. Ideal tocolytic here would be nifedipine. You may want to give her RH immunoglobulin depending on her blood group. Termination is done always at 37 weeks. You will not take it beyond term. She may need steroids if she is going into labor before that. Alright, that is with regard to the McAfee and Johnson's regimen of placenta previa. Now we come to abruption. We have already talked about the symptoms of abruption, how it presents. This is about abruption is also known as accidental hemorrhage. Accidental hemorrhage. What are the risk factors? Always the first risk factor is a past history of abruption. Then if there is an increased age, if she is a multiparous woman, preeclampsia or anything with regard to hypertension, chronic hypertension, if there is chorioamnionitis, we discuss polyhydramnios, and if she is going in for a rupture of membranes, multiple pregnancy, if she is a smoker, thrombophilia, there are so many risk factors for abruption. Okay. Now, there are two classifications. One is the Scher's classification, other is the Page classification. Just go through that. I haven't seen this being asked, but still, Scher's classification, easy to remember it. That is why I given it. 1, 2, and 3. 1 means abruption is mild. There is just a retroplacental clot which you will be able to identify usually post-delivery only. 2 means the abdomen is tense and tender. The fetus is live. Third means there is already intrauterine fetal demise has occurred. 3A and B. A means there is coagulopathy. B means there is no coagulopathy. That is a Scher classification. Now we have got the Page. Again, 0 means there is only a small retroplacental clot. 1 means there is bleeding, no compromise. Again, 2 means there is vaginal bleeding, there is signs of fetal compromise. And 3, you have got uterine tetany, abdominal pain with signs of fetal and maternal compromise. Okay, just remember the names. Scher's classification and Page classification, both are for placental abruption, while Brown classification was for placenta previa. How do you manage abruption? In almost all cases of abruption, there is no place for an expectant management, right? Usually the patient will present with severe bleeding, severe pain, and the fetus will be in distress. You will have to take out the baby to save the mother, save the baby and the mother. All right. So what do you do? Immediate delivery. You make sure there is sufficient blood available, sufficient analgesia, and in almost 90% of the cases, you will have to resort to a cesarean section. Make sure you're doing a coagulation profile because there is a 30% chance of developing DIC. I have mentioned vaginal delivery here. If it is a very low gestation dead baby with a fully dilated cervix, but remember that this is a very, very rare condition. In almost all cases, you will have to resort to a cesarean section. Now, you do a cesarean section, you find that the uterus is ecchymosed or black in color. It is called a cuvular uterus. What do you do for a covular uterus? You don't do anything. There is a possibility of postpartum hemorrhage associated with abruption. But if you see a covular uterus, you know that the blood has just seeped in between the myometrium. You need not do a hysterectomy, or you need not resort to any bold measures to save the uterus. All right. So we have answered that one. What do you do? What is the next line of management? What is the next line of management? Here we had discussed this. She's pretty stable. So you can offer her the expectant management. You can wait and watch. Now let us take up the next question. Before that, we'll take a short break. Next question. Choose the correct statement regarding management of postpartum hemorrhage. This is regarding the complications of the third stage of labor. You all know the most important complication is postpartum hemorrhage. What is postpartum hemorrhage? That is, there is a bleeding of more than 500 ml after a vaginal delivery or more than 1000 ml after a cesarean section or more than 1500 ml if there was a CS hysterectomy. Along with this, you should also remember if there is more than 10% fall in hematocrit, that is also after delivery, it is also called considered a postpartum hemorrhage. What is asked is regarding the management. Before that, there are a few things we need to know. Postpartum hemorrhage may be primary or secondary. Primary means the hemorrhage occurs within 24 hours and it is most commonly due to the atonicity of the uterus. Secondary means hemorrhage occurs from 24 hours to 12 weeks. And this is most commonly due to a retained products of conception leading on to a subinvolution of the uterus, or it may be due to a uterine artery pseudoaneurysm. Alright, that is with regard to the primary and secondary PPH. What are the risk factors? I don't think you need to by heart all the risk factors. If there is an atony, what causes these are the main risk factors, 4 risk factors. The TON, uterine atony. What causes uterine atony? There is over distension of the uterus, polyhydramnios. If there is a multiple pregnancy, there is a molar pregnancy. All these cases can produce. If there is a macrosomia, all these cases can produce a atonicity of the uterus. Then tissue in the sense there is a retained placenta or trauma like lacerations of the cervix or vaginal wall tears. Thrombin, as in if the woman has gone in for DIC. When can she go in for DIC? What are the condition we just learned? That was abruption, or there is she has sepsis, or there is an intrauterine fetal demise for 3 weeks or more if she has in a HELP syndrome. All these are the conditions where there can be, where she can go in for DIC, thus producing a postpartum hemorrhage. What we were talking about the management. How do you manage? Before that, we need to talk about the shock index. Now, postpartum hemorrhage is managed based on the shock index or the obstetric shock index. What is the shock index? It is a heart rate divided by the systolic BP. That is the shock index. Normally, what is normal? 0.7 to 0.8 is considered to be normal. If this value is more than 0.8, but it remains less than 1, we say that the woman is in a compensated shape. She has got a normal BP. That is, it's around 500 to 1000 ml of blood has been lost. But if it is more than 1, you say that she's becoming mildly decompensated. Mildly. That is, the systolic BP is around 80 to 100. She has lost 1 to 1.5 liters of blood. More than 1.5 means there is moderate shock. Moderate shock means 70 to 80 is the systolic BP and she has lost 1.5 to 2 liters of blood. More than 2, she is in severe shock, meaning the systolic BP is only 50 to 70. She has lost more than 2 liters of blood. In this case, the woman can collapse. She can have air hunger. Okay. This may be new to you, but it is important that you know the shock index because it is depending on the shock index that we go in for management of our patients. We have got a management algorithm which is the hemostasis. Again, H always stands for call for help. Then you assess and you resuscitate. That is where your shock index comes into play. Then you have to ensure the etiology. Is this which of the T's is responsible for the postpartum hemorrhage? Do you massage the uterus? These days, massage is not that common. Instead, you give a bimanual compression. We'll come to that. Then you give oxytocin. You may need to shift the woman to the theatre. You may need to tamponade. Then we'll have the sutures and the pelvic devascularization, etc. The first management is medical management. You have diagnosed PPH. What do? You go for the medical management. Medical management means we've got the medicines here. The drug of choice for medical management of PPH is oxytocin. How is it given? 10 units intramuscularly. Remember that I know that 5 units in the active management of third stage, you can give 5 units slow IV, but bolus dose of oxytocin is never given intravenously as it can cause sudden hypotension. So you give 10 units intramuscularly, or 10 to 40 units are given in a normal saline or ringer lactate solution. All right, so the drug of choice is oxytocin. Then you have got methyl ergometrin, you have got 15-methyl prostaglandin F2 alpha, you have got PGE2, you have got PGE1. Remember that all these are used for the induction of labor also, except for PGF2 alpha. That is a prostaglandin which is used for the postpartum hemorrhage, but not for induction of labor. These are the main drugs that are used. Then you have also got something called carbitocin. This is a newer drug. Carbitocin is an oxytocin analog given at a dose of 100 microgram intravenously. And you have got tranexamic acid, which is given as 1 gram intravenously. So, as we are talking about the medical management, you also need to know some contraindications. Here, we said that oxytocin cannot be given if the woman is hypotensive. Likewise, 15-methyl PGF2 alpha cannot be given in asthmatic patients, or if you are suspecting contraindicated in bronchial asthma, or if you are suspecting amniotic fluid embolism. In these cases, you don't give prostaglandin F2 alpha. And what about methyl ergometrin? You cannot give it in these cases. Toperitis. What does this stand for? Here, T stands for twins. O is for if the woman has got an organic heart disease. P if she has preeclampsia. E if she has eclampsia. Remember, in any case of hypertension, you don't give methergine because it can cause rapid vasoconstriction. And finally, you have got R, which is Rh isoimmunization. These are the conditions where methergine is contraindicated. Methyl ergometrin is contraindicated in these conditions. While in bronchial asthma and suspected amniotic fluid embolism, prostaglandin F2 alpha is contraindicated. That was about the medical methods. Let us look at the question. What was the question? Regarding the management, oxytocin, is it given to all patients? Yes, oxytocin is. Is uterine massage the first step in the management? Uterine massage is not the first step. That is, uterine massage is not even done these days. Suction evacuation is done? No, suction and evacuation is not done, but suction is done, which is a mechanical management. We'll be coming to that. Beal suture is put if medical management fails. That is also correct. Here our answer is both B and D. So, we have discussed medical management. Now, we are going on to the mechanical management. What are the mechanical management of postpartum hemorrhage? We have the picture here. This is the first one. What is this? This is the bimanual compression. Bimanual compression. What is being done here? There is a fist that is placed inside on the anterior wall of the uterus, and from the abdomen, the posterior wall is pressed downwards and the uterus is being compressed between both the hands. That is bimanual compression. Next thing is here, what is this? This is called a Bakri balloon. In the same way, you have also got a Foley's catheter, which can be, both of these are being introduced into the uterus and inflated with saline, so that it will exert a pressure on the uterine walls, causing compression, causing mechanical compression, preventing hemorrhage. You also got something called the Sengstaken-Blakemore tube. Or you can go for a condom tamponade. All of these act on basically the same principle. That is why we are discussing that together. Now here you've got something else. Are you familiar with this instrument? This is a suction cannula. this is an instrument that is more commonly being used or becoming more popular these days because it has got a great, it helps more in preventing or stopping PPH. You introduce a suction device, you raise the suction to around 600 to 800 millimeters of mercury, and what happens? Due to the suction pressure, the uterus immediately starts contracting around the cannula. You keep the cannula in situ for around half an hour. This is something, this is an instrument that can also help. This is called a transvaginal uterine artery clamp. What you do is you pull on the cervix downwards and you introduce this instrument into both the up to the fornices. You clamp the ankles of both the cervix where at the 3 o'clock and 9 o'clock position, whereby you are occluding the descending cervical branch of the uterine artery. In lots of cases, even the transvaginal uterine artery clamp alone can prevent the atonic postpartum hemorrhage to a great extent. No, these are instruments that are becoming more popular these days. So please look at the diagrams and memorize these diagrams. Keep it in your heart. Okay, keep these pictures in your heart. Because they are gaining popularity, they are not very expensive. They can be used in peripheral settings also. All right. So that is about the mechanical methods. Now we come to the surgical methods. So you have gone for you have done all the medical management, you have done the mechanical management, all this has failed. What do? You shift the patient to the operation theatre. You're thinking about a surgery. First thing that you do is you apply some compression sutures. These are the common sutures. This here, you have got the B-Lynch. Suture bite is taken here it goes behind the uterus and it comes back to be tied in front. Here similar vertical brace suture called the Hayman sutures. Something is different here. You have created windows by which the anterior and posterior walls of the uterus have been opposed. This is called the Cho suture. You have also something called the Gunshila suture, where sutures are put like this all around. Okay, this is the Gunshila. These are the main brace sutures that are used, which is a mechanical method. Then what do? You will have to go for a pelvic devascularization, which is by serially tying off all the arteries that supply the uterus. You remember that the uterine arteries, first of all, you start with tying the descending vaginal artery, then you go for the unilateral uterine, bilateral uterine, unilateral and bilateral ovarians before you move on to the iliac arteries. The uterine arteries are tied in the broad ligament. The ovarian arteries are tied in the infundibulopelvic ligament, while the internal iliac are tied at the level of the internal os. This is with regard to pelvic stepwise devascularization. All this fails, what do? You will have to go for a hysterectomy only. Usually the hysterectomy that is done in case of a postpartum hemorrhage will be a subtotal hysterectomy. Your next step is a uterine artery embolization. What is this? This is an angiographic embolization of the uterine artery. Angiographic. That is, you can do use materials like polyvinyl chloride. Okay. Angiographic embolization or gel foam. This is done under fluoroscopic guidance. And the vein that is threaded to reach the uterine artery is the femoral vein. Alright. So these are the methods by which postpartum hemorrhage can be treated. Let us take the next question. Which of the following imaging modalities can be used for the diagnosis of placenta accreta? What is placenta accreta? Placenta accrete syndromes, also called the morbidly adherent placentae. Morbidly adherent. Placenta accrete syndromes are divided into three. That is accreta, increta and percreta. Accreta means it attaches to the myometrium. Increta means it invades the myometrium. And percreta means it penetrates the myometrium to reach the serosa. That is about accreta, increta and percreta. One thing you have to know, this is the one that is often seen or often asked. In placenta accrete syndromes, there is absence of the decidua basalis. Remember decidua basalis, that was between the implanted blastocyst and the myometrium. That is not there. It is directly implanting into the myometrium, right? So the decidua basalis is absent. Absence of the decidua basalis and the fibrinoid layer of the placenta. Fibrinoid layer, also called the Nittabux layer. The fibrin placenta accrete syndromes. What are the risk factors? Why does this occur? Always there must be a past history. Usually there is a past history of any uterine surgery. It can be a cesarean section, it can be a myomectomy, it can even be a DNC. So the placenta goes and attaches to the scar site. There may be an associated placenta previa, usually seen in a multiparous woman or age more than 35 years. All right, these are the risk factors for accrete syndromes. What our question was, how do you diagnose accrete syndromes? The diagnosis is, first of all, for any obstetric case, your first diagnosis is always based on the scan findings. You do a transvaginal scan. What do you see? There is absence of the subplacental sonolucent zone. Which was the decidua basal, that is the fibrinoid Nittabux layer we were talking about, that is absent. There is absence of the subplacental sonolucent zone. And you find that the myometrium is very thin, less than 1 millimeters only. It is so thin. And then you're also able to see some placental lakes. If you're asked, where do you see placental lakes on ultrasound? It is in a case of an accrete syndrome. You'll be able to see placental lakes. After this, what do? You will go for a Doppler or an MRI. Look at the picture. This is the MRI picture. See how you've got a normal placenta and a thick myometrium, and look, as it becomes an accreta, it is attaching to the myometrium is thinning out, and increta means it has invaded, and in percreta it has gone beyond, gone out of the myometrium to come out. This is the bladder, it can even come out and involve the bladder. All right, now this is about the investigations. What do? Which is the imaging modality, right? Which is the imaging modality that is used? You can use an MRI, you can use an ultrasound, a Doppler ultrasound. It is not an angiography that is used, okay? So now we'll talk about how we will deliver, management of the labor. There won't be a plane of cleavage. Usually, how do you identify the placenta? There is a plane of cleavage between the placenta and myometrium. In this case, such plane of cleavage is not there. So at delivery, you don't try to pull on the placenta. Always it is managed in a tertiary center, only in tertiary center. If you are seeing a placenta accreta in if you get a question like in a peripheral center, what do? Peripheral center, you're diagnosing an accreta at 28 weeks. What have you done? What will you do? Your answer is refer the woman to a tertiary center by the time she's around 33, 34 weeks. Okay. So this is done only in a tertiary center. You are anticipating bleeding. Make sure that all blood products, everything is arranged. When is it delivered? At 36 weeks. You can say from 34 to 37 weeks, but if you are asked to pick a single answer, the answer is 36 weeks. Usually, you'll have to do a cesarean hysterectomy. But there are conditions where there is a focal accreta, only a part of the placenta is attached. In that case, you will go ahead and do what is called a triple P procedure. What is a triple P procedure? There is a preoperative placental localization. You know exactly where the attachment is. Then you will offer pelvic devascularization, which we discussed before. And then you don't remove the placenta, you don't pull on the placenta. Instead, where the placenta is attached, suppose this is the point where the placenta is attached, you only remove this, you cut off that part of the myometrium also, and then that part of the myometrium is excised, and whatever is remaining is repaired. This is called the triple P procedure. The advantage is that the woman can go ahead and retain her uterus, right? Especially in a younger woman. Next question. A 36-week or 36-week primigravida presents with transverse lie. What should you do? Transverse lie. What is transverse lie? The baby is lying transversely in the uterus. Lie means depending on the uterine ovoid, the baby is transverse. What are the causes of transverse lie? transverse lie. We'll discuss the causes. The most common cause is prematurity. Okay, and this is usually seen in a platypeloid pelvis or in multiparas, and it is seen in a second of twin. There is no mechanism of labor for a transverse labor. How can you take the baby out transversely? You cannot. The pelvic grip and the fundal grip will be empty because the baby is lying across like that. When you do, if you are doing a PV examination, you will be able to make out the ribs and the intercostal spaces in transverse lie. This is called the grid iron field. If you do a PV, you will be able to get a grid iron field, which is the ribs and the intercostal spaces. How do you manage? Management is by, first of all, at around 36 weeks, you can offer external cephalic version. What is the external cephalic version? You're trying to push the baby so that the head comes and occupies the lower part. Suppose this fails, or if it is contraindicated, there are certain conditions where ECV is contraindicated. It is contraindicated in case of placenta previa. If there is any other condition where vaginal delivery is contraindicated, in case of if the woman has got some other complications, and the problems are, or the adverse effects that can happen with ECV are non-reactive fetal status, which is usually transient, and also abruption. So this has to be done very carefully. That is why it is done closer to term. Suppose the ECV fails, you can offer 36 weeks, you can offer ECV for transverse lie. If this fails, you will have to go ahead and do a CS at 38 weeks. If the woman comes in active labor, immediately go for a cesarean section. What are the problems? Cord prolapse. The greatest chance of cord prolapse is with transverse lie. Then you can have a hand prolapse. There can be an obstructed labor, fetal death. All these are the complications of transverse lie. Next, we come to the most common malpresentation. What is it? It is breech. What was our answer here? She presented with transverse lie. What do? You should admit her at 36 weeks. Why? You want to try an ECV and we'll probably have to terminate. Should you repeat the ultrasound for confirmation? Yes, definitely you have to. The most common cause is placenta previa. Is the most common cause placenta previa? The most common cause is prematurity, but you can say that placenta previa is also one of the common causes for this thing, for transverse lie. Okay, she should be prepared for CS at the onset of labor. Yes, definitely. She has to be prepared for CS at the onset of labor. LSCS is done by breech extraction. Usually, usually LSCS is done by breech extraction. I don't think you've got a proper answer here. She should be admitted at 36 weeks is true. Ultrasound should be repeated for confirmation is true. The most common cause is not placenta previa. The most common cause is prematurity. But if C is given as true, you can take that also. She should be prepared for CS at the onset of labor. Yes. LSCS is done by breech extraction. That is also true. So these are the answers. Please don't go for the choices. So this is how the answer will come. Next, we'll go for the breech. Breech is the most common malpresentation. Again, most common cause is prematurity. There are 4 different types of breech. Frank breech, which is more common in a primary or in a nulliparous woman. A complete breech, which is more common in a multiparous woman. Then we've got the footling breech and the kneeling breech. Previously, we had talked about cord prolapse in association with transverse lie. After transverse lie, if cord prolapse occurs, the most common associated is transverse lie. It is followed by the footling breech, followed by the knee presentation, the frank breech and the flexed breech. The most common position in breeches, we discussed this once before, it is the left sacro-anterior position. How do you deliver the breech? Usually by cesarean section, primary breech definitely by cesarean section. But you need to know about breech extraction, which is usually done for the second of twin, and assisted breech delivery. These are the main maneuvers that are involved in assisted breech delivery. We'll start with the buttocks will come out, then you will put in your hand and if the legs are extended, you will exert pressure on the popliteal fossa by which the legs can fall downward, delivery of the extended leg, which is called the pinard maneuver. Then if the hands are extended, you can again go in for delivery of the extended arm, which is the Lausset maneuver. Then we have got the Burns Marshall, the Morrissus Mellivit, Pratt maneuver, and the Derson's incisions, which are put on the cervix, all of which help in aiding the delivery of the aftercoming head. Look at this. This is the assessment, or this is how the breech is delivered. First of all, you make an antenatal assessment. How is the fetus? What are the maternal conditions? You can offer a external cephalic version at around 36 weeks. It is done in the labor room. A continuous CTG monitoring is a must because we have already discussed that non-reactive fetal status can occur with the ECV, right? Then you offer elective cesarean delivery at around 38 weeks of gestation. If external cephalic version fails, or if it is a primey, or if the weight is more than 3.5, then if there is a hyperextended head, this is known as the stargazer fetus. Right. Suppose the ECV is successful, you can deliver out the baby. But if the ECV fails, you can either offer her a trial of breech delivery, or you'll have to go for a cesarean section. Okay. I've given two pictures here. These are the ones that are more commonly used in delivery of the fetal head in breech presentation. This one here, the one that is standing up with something like a lordosis, this is the Piper forceps. This one was delivered specifically for delivery of the aftercoming head of a breech presentation. While this here, this is a Neville Barn forceps. This is also used for delivery of the head in a breech presentation, but know that Piper forceps is not available in India. It was the one that was originally designed for delivery of the head in breech presentation. Now we have got the Bro presentation. In Bro presentation, we discussed before, there is no mechanism of labor. Bro is a partially extended head, right? This is the part that presents in a Bro presentation, which is a diameter that is a mento-vertical diameter that is around 14 centimeters, the longest diameter of the fetal head. That is what presents. It cannot maneuver the pelvis. So, when you are doing an abdominal examination, on your fourth grip, you can find that both, since it's a partially extended head, you can find that both the sinciput and the occiput are at more or less the same level on the abdomen examination. What about when you do a vaginal examination? In a vaginal examination, what you are feeling will be the frontal bone, the supraorbital ridges, and the root of the nose. That is, this part is the bro. You have got the frontal bone, the supraorbital ridges, and the root of the nose. If you are feeling this on a vaginal examination, immediately you can stop your oxytocin or whatever that you have been doing and take her up for a cesarean section, because there is no mechanism for delivery in a bro presentation. We'll also just talk about the cord prolapse. If you have detected cord prolapse, you know the risk factors, right? You determine whether this baby is alive or dead. Also determine whether it is a preterm or and what is the cervical dilatation. Suppose a baby is dead, it is a dead baby, you can confirm, you have to confirm it with an ultrasound, then you can wait for a spontaneous expulsion. But if the baby is alive, what will you do? Your treatment of choice is a cesarean section. But if you think that an immediate vaginal delivery is possible, and if it is a vertex presentation, you can put in a forceps or a vacuum and deliver out the baby. Breech, it is very difficult to deliver out a breech with a cord prolapse. In most cases, it will go on and you'll have to go and do a cesarean section. These are a few things you need to know. Anyway, cord prolapse, if you're asked treatment of choice, cesarean section. But you need to know these. What do you do? These things you need to know. You will immediately fill the bladder using a catheter. And then you should put in a vaginal finger and lift the presenting part. Suppose it is a head. The cord has slipped out. The head is coming and pressing against the cord. that means that the baby is not getting any more oxygen supply at all. So you put in a hand PV, please don't manipulate, you don't manipulate the cord, you just lift the head off the cord and keep it that way. Then this one you need to know the posture, that is the elevated Sims position or the Trendelenburg position or the knee chest position. The patient should be kept in this position before she is shifted to the theater or before she is taken to a hospital with a better facility. Okay, this you remember. All right, that is the important thing with regard to a cord prolapse. This is a Robson classification. Robson classification is for cesarean section. What does it include? Modified Robson classification 1 includes a nulliparous singleton cephalic presentation in spontaneous labor. Okay. That is a modified Robson one. Please just go through the Robson classification. If this is last moment and you haven't studied this before, it will be difficult to remember this. But know that there is something called a modified Robson classification and it is for cesarean section. I'll just mention a couple of things that you can keep in mind. That is Robson 10. Robson 10. This is the one for preterm. If you get a question, you have a 34 weeker for whom you did a cesarean section, what is a Robson score? It is 10. Robson 10 is for preterm. Robson 5 is the one for previous years. Robson 5 is for previous years. Robson 6 and 7 both are breech. Both are breech. And 8 is multiple pregnancy. Other lies are 9. See, this is how you can, these are some of the things that can be asked that you can remember. That is 5 to 10. 10 is always, 5 is previous years, 10 is preterm. That you can remember, right? Then you have got 6 and 7, with both of which are breeches. 6 being nulliparous, 7 is a multi. And then you have got all other, 8 is for a multiple pregnancy, 8 is for a multiple pregnancy, and 9 is for all other lies. Try this, see if you can remember a few. That is enough. Don't waste a lot of time with Robson classification, right? Let us go to the next question. We have a 34-year-old female. She with the previous classical CS, now presenting with the breech presentation. It is confirmed on ultrasound at 34 weeks. She is insisting on a normal delivery. What will you do? Now we come to the trial of labor after cesarean. TOLAC. Whom will you offer TOLAC to, or whom will you not offer TOLAC to? More importantly, see, nowadays trial of labor after cesarean is possible. There is a great success rate. But this cannot be done for everyone. This can only be done in a tertiary center where all facilities are available, blood bank is available. But even so, there are certain cases where the trial is contraindicated. The most important thing, if she has had a previous classical CS, there is no role at all for a trial of labor. If she has had previous 2 cesareans or an inverted T, main thing is the previous incision, what the previous type of incision was. That is the most important thing. Then what was the indication for the previous? Suppose it is a non-recurring indication, like she had a previous CS for a breech, then possibly you can. Or she had a previous, say she had a previous indication was a non-reassuring fetal status, you can offer her a trial of labor. But in these cases, you cannot offer her a trial of labor. In this, see, she has had a previous classical CS. Then and there itself, the trial of labor goes right out of the window. However much she insists, you cannot do a cannot wait for a trial of labor for her. What will you do? You will plan a cesarean section at 37 weeks. Next question. Which of the following structure is not cut in a mediolateral episiotomy? What are the structures cut in episiotomy? We have the vaginal mucosa. Then you have got your muscles, the superficial and the deep transverse perine, the bulbospongiosus and the levator ani. You've also got the internal pudendal blood vessels, the subcutaneous tissue, perineal skin. What is not cut? The obturator nerve and vessels are not cut. Now, we'll just a bit about episiotomy. Is episiotomy a must? No. Episiotomy these days is restrictive episiotomy. Episiotomy will not help. Please remember that episiotomy will not help in preventing perineal tears. What will help in preventing perineal tears? The only thing that has been diagnosed to help prevent perineal tears is the modified Ridgen's maneuver. What is a modified Ridgen's maneuver? It is a controlled delivery of the head by controlled flexion. How you keep one hand for perineal support and how you keep the other on top of the head while you're delivering it. That is a modified Ridgen's maneuver. That is the only method, only approved method to prevent perineal tears, not episiotomy. Episiotomy is of two types. It can either be midline or a mediolateral. Everything is easier for the midline. The surgical repair is easy, cosmesis is better, healing is better, postoperative pain is less, blood loss is less, dyspareunia is very rare, while all these are more for mediolateral episiotomies. But what is the episiotomy that you all have seen more commonly? It is a mediolateral one, right? Why? The most important complication of a midline episiotomy, that is extension of the incision, is very less with the mediolateral. Even if it extends, it will be extending that way only. While if it is a midline episiotomy that is extending, it will be extending right into the rectal mucosa and the anus. That is why we are usually putting a mediolateral episiotomy. Along with this, we'll just mention the classification of perineal tears. You have a first degree tear where only the perineal or the vaginal skin is involved. Then we have the second degree where the muscles are involved. For example, the mediolateral episiotomy that we put is a second degree perineal tear. Then there is a third degree. It is divided into three, A, B and C. A means only less than 50% of the external anal sphincter is involved. B means more than 50% of the external sphincter. C means the internal anal sphincter is also torn. And now you come to the fourth degree where the rectal mucosa is also torn. That is with regard to the classification of the perineal tears. How do you repair this? When do you repair this? What do you use to repair this? Let us start with the first and second degree tear. First and second degree. What do you use to repair? You have all seen this being done. Usually you use a vical to repair. That is a polyglactin can be used to repair this. What is the technique? If it is ideally first and second degree tears, you are supposed to use a continuous technique of suturing. Now, if the internal anal sphincter has been torn, that is a 3C. If it is a 3B tear, what do you do? 3A or a 3B tear, you can go for an end-to-end or an overlapping technique. If it is a 4th degree 3C or a 4th degree tear, you go for an end-to-end. Sutures used, that is the ideal suture for the rectal mucosa is a polyglactin always. If it is the external anal sphincter, you can use a PDS or a polydiacenon. For the internal anal sphincter, again PDS or Vicryl, which is polyglactin. If it is a rectal mucosa, again polyglactin. Next, you come to the timing. As far as the first and second degree tears are concerned, you can repair it immediately. All tears are to be repaired as soon as possible. All are to be repaired as soon as possible. First and second degree tears you can repair in the labor room itself under regional or local anesthesia. While third and fourth degree tears are to be repaired in the operation theatre under a general anesthesia. All are to be repaired as soon as possible. But suppose you are not able to repair the tears soon. Suppose a woman has had a home delivery. She is coming to you at 3 months or 4 months. When do you repair this? The ideal time to repair a late presenting tear is around 3 months. You cannot, by 3 months, all the inflammation will have subsided. You will be able to repair. If it has crossed 6 months, that means there will be fibrosis around there. You'll have to make a fresh cut before you start repairing the perineal tear. If she has got a third or a fourth degree perineal tear, the ideal time for her to conceive again for the next pregnancy will be after 6 months. Okay. So with that, we come to the end of that question. We'll take up the rest of the questions after our lunch break. back. So before we take up the next question, there was one doubt about placental lakes. See, placental lakes are basically just sonolucent area or hypoechoic areas within the placenta where you can see, which is bled actually. I'll try to show you a picture. In fact, I'll draw a picture for you. This is actually part of the placenta. It was in the placenta accrete spectrum that we discussed placental lakes. See, you have got the placenta like that. Okay. And then you'll have some hypoechoic areas within the placenta. These are the placental lakes. These can be just innocuous, they can be seen even without an accreta also. But remember that if you get a question, placental lakes are a characteristic feature of, and you're asked to pick a choice, then you'll have to go for placenta accreta. In fact, more than the lakes, it is the placental lacunae that are features of placenta accreta. There are spaces in between the placenta. There are gaps in between the placenta. That is all. There is other than that, there is nothing specific with regards to placental lakes. But just so that you understand what it is, like a lake within the placenta. Okay, that is why I talked about that. Now we'll take up our next question and move forward. Here we have a 30-year-old. She is 14 weeks pregnant. She has two painless deliveries at 16 weeks earlier. What is the next line of management? She's presently at 14 weeks of pregnancy. It says that she has had two painless deliveries. That is very important. She has had two painless deliveries at 16 weeks. What do you do next? Now we are coming to preterm labor, in particular cervical incompetence. Cervical incompetence means there is a sudden dilatation or sudden effacement of the cervix followed by rupture of membranes or expulsion of the fetus. This is not associated with any painful contractions. It just occurs spontaneously. All right. So, how can you measure the cervical length? The cervical length is best assessed by a transvaginal ultrasound. Normally, a normal cervical length is around 3.5 centimeters at 28 weeks of gestation. And this will remain more or less constant till the third trimester. All right. That it is just 10 weeks prior to the delivery, 10 weeks before the onset of labor, that the cervix starts to shorten. Now, look at this picture. We have got a picture here. This represents the various stages of cervical incompetence. Here, when you do an ultrasound, you can see that the cervix here is in the shape of a T. And later on, as the cervix starts opening, it takes up a Y shape. This is called funneling, like a funnel, no? And furthermore, it opens up further to become a V. And once it is fully opened, it takes up a U shape. Do you get this? It goes from T to Y to Y to V to U. This is how cervical incompetence is. Now, this is not just the only marker. There are a couple of markers that can help you to identify preterm labor. One of those is the fetal fibronectin. Just know these names. Then we have got the salivary estriol. Fetal fibronectin in the vaginal swab, salivary estriol, IGF binding protein, all these help in identification of the preterm labor. What we are talking about cervical incompetence in particular, what causes cervical incompetence? Now, if she has, most important factor is a past history of any kind of surgical procedure done on the cervix. It could have been a cornication, it could have been a cervical amputation. Any of these can cause a cervical incompetence. Like we said, it presents with usually painless, sometimes even painful uterine contractions. They may have a low backache or a pelvic pressure. A rupture of membranes, that is it presents as a watery discharge PV. It may even be a blood-stained discharge PV or a bloody show. This is how the cervical incompetence presents. Anyway, what is our question? What is the next line of management? How do you manage? We'll talk about this in detail in the next question. Anyway, since I've asked here, the next line of management, when she already gives a history of 2 mid-trimester losses, she's already 14 weeks pregnant. It is to go for a cervical encerclage. Here, there is no role for a serial assessment of the cervical length. You might think you'd want to look at the length of the cervix. No, she has had 2 miscarriages at around 16 weeks. You will go for an encerclage directly. Let us take the next question. We'll explain it further then. See, a female comes to the gynae OPD for preconceptional counseling. She gives a history of 2 second trimester abortions. What is the next thing you'll advise? Here, she is not pregnant. All right. She is planning pregnancy. She has come to you for a preconceptional counseling. What do you advise here? In this case, the next investigation you'll advise will be a transvaginal ultrasound. You would like to assess the length of the cervix. But even if you assess the length of the cervix in a non-pregnant state, you will always suspect that this woman can go for a cervical incompetence during her pregnancy. The treatment of choice is the cervical encerclage. Look at this. There are 3 different types of encerclages seen here. We'll start with when or for whom you will do an encerclage. Encerclage can be done for 3 indications. First one is a prophylactic cerclage, one that is done prophylactically. She gives a history of 3 or more past history of preterm birth. Now the 3 has been cut down to 2 or more. Anyone with a presenting with a history of 2 or more preterm births or a second trimester loss. That is a prophylactic cerclage. You can change this to 2 or more. Then a therapeutic cerclage, that is an ultrasound indicated cerclage. You do an ultrasound for her, say at around 20 weeks, and you find that the length of the cervix is less than 2.5 centimeters. Then we have, she has got a past history of 1 or more preterm births, with the ultrasound showing whatever we have mentioned before, a Y or a U or a V pattern. This occurs before 24 weeks. You can offer her an ultrasound indicated cerclage, which is called the therapeutic cerclage. Then we have got the third one, which is the rescue cerclage or the emergency cerclage. This is when a woman comes with a threatened preterm labor. You do a speculum examination and you find that the cervix is taken up and you can see the membranes bulging. That is a rescue or an emergency cerclage. There are 3 multiple kinds of cerclages. These are 3 of them. Here, this one here, the one at the lower end, is the McDonald cerclage. Here you have got the Shirodka. What is the importance of Shirodka? Shirodka means different from a McDonald cerclage. In a Shirodka cerclage, you are dissecting the bladder upwards before you put in a cerclage. The material that is used to put a cerclage is the Merceline tape. Here, this is part of the abdominal cerclage. Suppose this woman has had some kind of a surgery, say for example, Leaford surgery that was done. She has she had cervical amputation or something. While doing the surgery itself, you will put in a cerclage. Sometimes even otherwise, laparoscopically also you can put in an abdominal cerclage. Only thing is, for a woman who has had an abdominal cerclage, she will need to have a cesarean section for delivery. She cannot have a normal vaginal delivery. That is about cervical incompetence. Before we proceed further, a couple of things we need to know regarding preterm labor. Okay, just about preterm labor. One is about the torcolysis. Know that this has got nothing to do with cervical incompetence. I just wanted you to know a couple of important points about preterm labor. First one is torcolysis. Torcolysis means you are trying to keep the uterus quiescent. It is not given for more than 48 hours. All right. Why it is given is probably for some antibiotics to act or for helping in transfer to a tertiary center or something like that. That is torcolysis. So, what are given as torcolysis? You can give prostaglandin synthase inhibitors. For example, indomethacin. What else? You can give calcium channel blockers like nifedipine, which is the one that is most commonly used. You have got oxytocin antagonists like etoposide. Then you've got magnesium sulfate. Then you have nitric oxide donors like a glyceryl trinitrate. Then we have got the beta agonists. Beta agonists will include ritodrin, terbutaline, isosuprin, all these will be there. These are the main tocolytics. Now you need to know the tocolytic of choice in certain conditions. Tocolytic of choice, that is the one that is most commonly used, like we said, it is nifedipine. Nifedipine is the one that is most commonly used. If it is a woman with a heart disease, the tocolysis of choice in heart disease is atosiban. This is the one with the maximum maternal adverse effects. It can cause hyperglycemia, tremor, hypokalemia, even pulmonary edema. Okay, which is the one with the maximum fetal adverse effects? Obviously, it is indomethacin. It can cause early closure of the ductus arteriosus. All right, then we have got something that is Maxelf. Another important thing about Maxelf is that it also helps in neuroprotection. So it is if given before 32 weeks. All right, this is in general about tocolysis. Now we'll take up the next question. You have a 20-year-old woman. Did we answer the question? Yeah, we did. So we have the next question. You have a 20-year-old woman. She presented at 7 weeks of gestation, unwilling to continue her pregnancy. What are the ducts used for medical termination of pregnancy in this patient? Now we'll talk about AMTP. Up to 7 weeks, you can give her medical termination. You can give her medical termination up to 15 weeks, but medical abortion is usually done up to 7 weeks. 7 to 15 weeks, the ideal thing would be suction evacuation using a Carmen's cannula or a vacuum aspirator. After that, you can give her prostaglandins to ripen the cervix and then expel the baby. What are the drugs that are used in a first trimester abortion is the question. In a first trimester abortion, you can offer her mifepristone, 200 milligram, followed 48 hours, 24 to 48 hours by what? Misoprostol, 200 to 600 microgram. So it is mifepristone plus misoprostol, or you can offer her misoprostol alone. Misoprostol is PG1, remember? That is around 800 microgram. Or you can offer her methotrexate and misoprostol. Look at the choices. What was our 7 weeks? She's unwilling to continue. What can you give her? You can give her misoprostol and mifepristone. Right? Not mifepristone and methotrexate or others. It is misoprostol and mifepristone that is usually given. That is about the first trimester abortion. What about the second trimester abortion? Again, you have got mifepristone followed by misoprostol, or you have got misoprostol alone, or you have got, these are the ones that are different, dinoprostone or oxytocin. These can all be used for a second trimester abortion. Now, suppose she has taken PG1, that is misoprostol, she has taken for a first trimester abortion and the pregnancy is continuing, or she has decided to continue the pregnancy. What is the condition that you can expect in the fetus? What is the teratogenic effect? Misoprostol is a drug with a teratogenic effect. What is the teratogenic effect you will expect in a woman who has taken misoprostol? This is called the Mobius syndrome. Okay, so you will remember that, right? Now we come to the suction evacuation. This is the instrument that is used. See, the Carman's cannula. What is it? It is the Carman's cannula. Now, Carman's cannula comes in various sizes. I hope you can see this. Look at this, for example. They all have numbers written on them. See, here you've got a number. It says 12 mm. Can you see it? It says 12 mm. What is the importance of this number? It is not just a randomly written number. This number has got its own importance. It is the, say, the diameter of the Carman's cannula. This number corresponds to the gestational age. You want to do a suction evacuation for a woman who's 12 weeks pregnant. You need to do it using a Carman's cannula of 12 mm. All right, the suction evacuation using a Carman's is done under a local anesthesia or a paracervical block. That is enough. Okay. The next question, which site of implantation will cause severe vaginal bleeding, no sign of rupture ectopic despite 22 weeks of gestation? Now we are moving on to the ectopic pregnancy. What are the sites of the ectopic pregnancy? Here you see she has got severe vaginal bleeding, but the pregnancy has progressed up to 22 weeks. She is having symptoms, and how did it progress up to 22 weeks? That is because this is an abdominal pregnancy. First of all, we have got certain criteria. What is an ectopic pregnancy? Any pregnancy that implants outside the uterus is an ectopic pregnancy. We'll come to the sites and things later. Anyway, the most common site is the fallopian tube. It is almost synonymous with a tubal pregnancy. You know that, right? Before we go into the tubal pregnancies, let us just see the criteria for different pregnancies. First one we'll start with is the primary abdominal pregnancy. The criteria is called the Studi-Fort's criteria. Abdominal pregnancy, it is the Studi-Fort's criteria. Next, you have got the ovarian pregnancy, where the criteria is the Spiegelberg criteria. And the cervical pregnancy, which is the Rubin's criteria or the Palmer's criteria. Please remember the names of the criteria. It will be kind of difficult for you to remember it all in detail, but remember the names. Abdominal, it is Studi-Fort. Ovarian, it is Spiegelberg. Cervical pregnancy, it is Rubin's criteria. What causes an ectopic? The most important risk factor for any ectopic pregnancy is the past history of the ectopic. If she has had one ectopic in the past, there is a 10% increased chance of another ectopic pregnancy. If she has had two ectopics, there is a 25% increased chance of developing an ectopic pregnancy. This is followed by a history of tubal surgery. But even though this is the most important risk factor, the most common risk factor, it is different from the important risk factor. The most common risk factor is a tubal disease. What do you mean by a tubal disease? A pelvic inflammatory disease usually caused by chlamydia. Okay, that is the most common risk factor. Now, we were talking about the sites. Which is the most common site? It is the fallopian tube. The most common non-tubal site is the ovary. In the tube, the most common site is the ampulla and the least common is the interstitium. But within the tube, the maximum growth of the ectopic pregnancy will occur in the interstitium. It can occur up to 12 weeks. Now, what happens? What is the fate of the ectopic? It can either go in for a tubal abortion or a tubal rupture. Tubal abortion will occur if the pregnancy is in the ampulla, and tubal rupture is usually in the isthmus. So, the shortest survival is in the isthmus, while the longest survival is in the interstitium. Now, we'll come to how you will diagnose an ectopic pregnancy. There is a classic triad for the ectopic pregnancy, which comprises of abdominal pain, bleeding, and amenorrhea, of which abdominal pain is the most common symptom. Almost 50% of women present with abdominal pain. So, whenever a woman presents with this triad, what is the first thing you'll do? It is a UPT, a urine pregnancy test, which is positive in almost all cases of ectopic. There are certain supportive investigations. One, obviously, the first investigation is a transvaginal ultrasound. If you're doing a Doppler ultrasound, you can find that there is a ring of fire appearance. Know that this is not specific for ectopic pregnancy. It can also be there if it is just a corpus luteum of pregnancy. Then you can assess the beta HCG levels, which will not have the same rise as is seen in an intrauterine pregnancy. Now we have got the serum progesterone. Serum progesterone means if it is more than 25, it is probably in favor of an intrauterine pregnancy, while a progesterone value of less than 5 is more in favor of an extrauterine pregnancy. Then you have got your culdocentesis. We'll come to culdocentesis later. One more thing you need to know, which is the diagnostic biomarker. Which is the diagnostic biomarker for ectopic. The diagnostic biomarker for the ectopic pregnancy is the serum placental growth factor. These are all only for your this has got nothing to do with the clinical implications. Okay, anyway, the diagnostic biomarker is the serum placental growth factor. What is the gold standard investigation? It is laparoscopy, because it can be therapeutic also. Now we said we'll talk about cultosynthesis, right? We'll come to cultosynthesis. This is the procedure. This is no longer being done now because we have got advanced methods of imaging techniques. So it is no longer done now. See, look what is being done. A speculum is introduced and the posterior lip of the cervix has been held using a valsalum, and you've introduced a needle into the pouch of Douglas and you're aspirating. What all can you get? You can get serous fluid from the pouch of Douglas. A serous fluid will indicate that it is a mid-cycle or a pelvic inflammatory disease. Sometimes you may be getting clotted blood, which means that you have punctured a vessel. But if it is non-clotted blood, it means it is a ruptured ectopic pregnancy. Okay, that is with regard to cultosynthesis. Now there are two signs of ectopic pregnancy. One is the Danforth sign. Danforth sign means shoulder pain. Why? Pain has been referred to the shoulder because of a hemoperitoneum. That is Danforth sign. The next one is the Cullen sign. Cullen sign is also because of a hemoperitoneum or intraperitoneal or retroperitoneal bleeding produces Cullen sign. This is seen as ecchymosis around the umbilicus. So that is Danforth sign and Cullen sign, both in ectopic pregnancy. What is the next question? You're continuing with ectopic. A woman presents to you with 6 weeks of amenorrhea, bleeding, PV, abdominal pain. You've got all the triad there. The urine pregnancy test is slightly positive and HCG shows 2,800 international units per liter. A mass is seen on the left adnexa measuring 3 into 2.5 centimeters. She is hemodynamically stable. How will you manage this patient? Now, first of all, we have to know what the ultrasound features of an ectopic pregnancy are. See, when you look inside the uterus, you find that there is no intrauterine sac or there is a pseudo gestational sac. You can see an adnexal mass separated from the, which is a blob sign. Then you have got the Bagel sign, that is an intact tubal ring sign. Like we said before, the Doppler will show a ring of fire pattern. Now, how do you manage the ectopic pregnancy? If it is a ruptured ectopic pregnancy, there is no need to think anymore. The choice is a surgery. In all probability, an immediate laparotomy. Even though previously we used to say that you should always go for a laparotomy. Now that people are becoming more adept with laparoscopy, we say that you can even go for a laparoscopy in case of a ruptured ectopic pregnancy. What happens is our confusion comes if it is an unruptured ectopic. At that time, the management depends on the patient's condition and certain other criteria. It can be, there are two different ways in which you can manage. There can be an expectant management or a medical management. All this has got some criteria. In both the conditions, whether it is expectant or medical, the first criteria is that the patient be hemodynamically stable. If she is not stable, we will never go for this. We'll be directly going for a surgery only. Expectant management, the beta HCG has to be less than 1,500 international units. Gestational sac with size less than 3 centimeters, and the woman must be willing to come in and check for twice weekly HCG. Medical management, again, she is hemodynamically stable. She has mild to no pain. Gestational sac is less than 3.5 centimeters if there is a cardiac pulsation, or less than 4 centimeters if there is no cardiac pulsation. And the beta HCG value should be less than 5,000. All right. So these are the two criteria for expectant and medical management. Let us, what is the drug that is used? The drug that is used is methotrexate. Methotrexate, as you know, is a DHFRase inhibitor. There are three different regimens in which methotrexate is given. First one is the single dose regimen, which is the one that is commonly followed. You give methotrexate at a dose of 50 milligram per meter square. And then beta HCG is checked on day 4 and day 7, where there must be a fall in 15% between the two. If then after this you check beta HCG weekly. If there is not enough fall, that is 15% fall has not occurred, 15% fall has not occurred, what do you do? At that time, you can repeat methotrexate. Maximum of 3 doses of methotrexate can be repeated. If all 3 fails, then you will have to go for surgery. Right? This is the single dose regimen. Then we have got the multi-dose regimen, where methotrexate is given on day 1, 3, 5 and 7. 1 milligram per kilogram methotrexate is given, and on day 2, 4, 6 and 8 you give leucovorin, also known as folinic acid. This is called the folinic acid rescue regime. All right, because we already know that methotrexate is a folic acid antagonist. So you give leucovorin. Just like previously, you check beta HCG on day 4 and 7 and decide accordingly. Then you have got a 2-dose regimen, 2-dose, where methotrexate is given on day 0 and day 4 and beta HCG is checked accordingly. Okay, that is a methotrexate regimen. Then we have got something called a surgically administered medical management, or SAM. So many other drugs can also be used in the management of ectopic pregnancy. The most common adverse effect of methotrexate is liver dysfunction. But suppose you get a woman with an ectopic pregnancy, she has got liver dysfunction. Which is the drug you will give? At that time, the drug you give will be actinomycin D. See, these are the other drugs that can be used. I think you know this statement. Most postgraduate males are very knowledgeable. Methotrexate, prostaglandins, hyperosmolar glucose, mifepristone, actinomycin D, vasopressin and potassium chloride are the other drugs that are given. Let us look at the question. So UPT is positive, her beta HCG is 2800. She is hemodynamically stable. Whenever you have got a statement like that, that she is hemodynamically stable, think whether you can offer her expectant or medical management. Her beta HCG is 2800. So there is no way in which you can offer her expectant management. What do you do then? At that time, you can offer her. What can you offer her? Either you can, would you want to offer her a single dose methotrexate or a serial methotrexate and leucovorin? That is, you can offer her medical management. You need to know whether it is single dose or multi-dose. The best method is, initial method is always offer her a single dose methotrexate regimen. Obviously, methotrexate is not a drug without its risk. So always try to give the minimum possible dose. You offer her a single dose methotrexate regimen. Now, since we have completed that, we'll talk about the surgery also. There are 2 different types of surgery, that is conservative surgery and radical surgery. Radical surgery is when you take out the tube, salpingectomy, especially in case of a ruptured ectopic. Conservative surgeries will include salpingostomy, sometimes segmental resection and anastomosis. Fimbrial resection or milking is not that common nowadays, not done anymore. All right, that is with regards to ectopic. Next question, gestational trophoblastic neoplasm does not include. What is gestational trophoblastic disease? First of all, we'll talk about the main gestational trophoblastic diseases. That is, you've got the hydatidiform mole, it may be complete or partial, invasive mole, choriocarcinoma, PSTD, placental site trophoblastic tumor, and epithelioid trophoblastic tumor. How does this occur? I think you know about this. A complete hydatidiform mole, this is diploid. Complete mole is diploid, while a partial mole is triploid, produced due to dispermy, while complete mole is due to chromosome duplication. All right, that is the first thing you need to know. Now, these are the different features. Again, you're familiar with this. 46XX, this is a diploid complete mole, and 69 triploid is a partial mole. All the other things you know, you are aware of this. Please go through. Okay, they don't usually ask. As far as the criteria for a gestational trophoblastic neoplasia are concerned, we'll take that up in the next question. Let us just look at the hydatidiform moles alone in this question. Look at the ultrasound pictures. The 2 different ultrasounds are of the 2 different moles. This one is the complete mole and the other is the partial mole. Here, this is called a snowstorm appearance. This here that you see, this is a snowstorm appearance. While in a partial mole, there is a multicystic placenta. Look at the multiple cysts in the placenta. This is a feature of a partial mole. Okay, in partial mole, sometimes you will be able to see the fetal parts also, while it is absent in a complete mole. What are the clinical features? The most common presentation of a molar pregnancy is the vaginal bleeding. It may be preceded by a brownish or a watery discharge with the blood may be mixed in the fluid. This is called the what? White current in the red currant juice appearance. Just read this so that it will be there in your mind, because they can sometimes ask peculiar questions like this. What is the white current in the red current? You must not get confused about it. It is seen in a hydatidiform mole. The patient may have abdominal pain, some constitutional symptoms. Because it is a molar pregnancy, there is an excess of HCG being produced, and the excess of HCG can aggravate the symptoms of a normal pregnancy, like hyperemesis or thyrotoxicosis, or she can have luteal cyst, thecal lutein cyst, see, excess vomiting, and she may have breathlessness due to the pulmonary embolization of the trophoblastic cells, thyrotoxic features of thyrotoxicosis, and expulsion of grape-like vesicles per vagina, which is a molar pregnancy. And anemia may be much increased along with features of preeclampsia. How do you manage the molar pregnancy? First of all, she needs supportive care, because like we said, she has got so many other features, she needs to have supportive care. Then we have to evacuate the uterus as soon as possible, preferably with a suction evacuation. It is not advisable to do a curettage following a molar pregnancy, because the uterus is extremely soft and is liable for perforation. Then we follow up for persistence of a gestational trophoblastic disease. After suction evacuation, you need to know how to follow up the patient. Follow up is done using beta HCG. Beta HCG is done after 24 hours of evacuation, and then weekly for 3 weeks, followed by monthly for 6 months. Provided this becomes normal. That is where we'll be talking about the gestational trophoblastic neoplasia. All right. Anyway, in this case, what are the components? Choriocarcinoma, placental site trophoblastic tumor, an invasive mole, and epithelial trophoblastic tumors are all gestational trophoblastic neoplasia, while partial mole is not. Okay. Let us take up our next question. All of the following are suggestive of choriocarcinoma after treatment of a hydatidiform mole, except what are the indications for a post-molar gestational trophoblastic disease or a gestational trophoblastic neoplasia? HCG levels. HCG levels of 4 values. HCG levels of 4 values. They are plateauing. They are what? They are plateauing over a 3-week duration. That is, on day 1, 7, 14 and 21, you are not getting a fall in the HCG. It plateaus. And HCG level increase. How does it increase? HCG level increases of 3 values recorded over a 2-week duration. See, on day 1, 7 and 14, the value is found to rise. And even after 6 months of evacuation, HCG persists. And you find that there is excessive enlargement of the uterus, and there are large thecal lutein cysts of more than 6 centimeters. Suppose there is metastasis, or you have finally got histologic evidence of choriocarcinoma or PSTT or an invasive mole. All these point towards what? All these point towards a gestational trophoblastic neoplasia. Okay. Now we have got the FIGO staging. FIGO staging of the GTN. This is very important. Okay, you have got so many FIGO stagings that you'll be studying, but choriocarcinoma, gestation trophoblastic neoplasia in particular, is quite important. Stage 1 is a disease that is confined to the uterus. Stage 2 means it extends outside the uterus, but just to the vagina or the adnexa, usually presenting as a what? As a suburethral nodule. Then you've got stage 3 that extends to the lungs, which is the most common site of an extrapelvic mets in a gestational trophoblastic neoplasia. And then you've got stage 4, which is all the other metastatic sites. Here we have got the WHO prognostic scoring. See, you have to look at a couple of things here. Previously, you also had ABO blood group, but here ABO blood group has been deleted. Low risk means a single agent chemotherapy is given, which is that is methotrexate, and for a high risk, that is if it is 7 or more, a combination chemotherapy is given. These are the regimens. Single agent is methotrexate, and then you have got the EMACO regimen for the high risk groups, right? I believe. What was our question? What is suggestive of choriocarcinoma after treatment of hydatidiform mole? What is R except? What is it? It is all these are suggestive. You have got HCG reaching a plateau. Yes. No resolution of thecal lutein cyst. Yes. You may have a suburethral nodule, but a sustained increase in the uterine size is not uterine. It's not part of the choriocarcinoma. Now we come to the next question. Now we'll start with the Rh negative pregnancy, systemic diseases in pregnancy. First one is the Rh negative. Anti-D prophylaxis is required in all the cases except. These are things that you know very well. What is Rh isoimmunization, or when does it occur? See, Rh antigens. Which are the Rh antigens? These are the main Rh antigens. These are produced in the fetus at around the 38 days of gestation. Fetus starts producing Rh antigens. In Rh negative woman, the first test, one of the first tests that we do when a woman comes for her booking visit is a blood group. We find that she's negative, we'll immediately do her husband's blood group. If he is positive, there is a likelihood that this woman may become Rh isoimmunized. Why? See, if she has an Rh positive fetus and the Rh positive cells enter the maternal circulation, she can produce antibodies against this. As a primary response, the antibodies produced are IgM type of antibodies, which do not cross the placenta or attack the fetus. But as a secondary response, the antibodies being produced being IgG, if she becomes pregnant for a second time, then these antibodies can attack the Rh positive fetus in the maternal womb and cause Rh isoimmunization. What are the factors that cause Rh isoimmunization? I have, for making it easier, you can divide it into three. First one is associated with pregnancy loss. What is that? Associated with pregnancy loss means what? It can be an MTP. It can be a spontaneous miscarriage. It can be an ectopic pregnancy. It can be a molar pregnancy. See, next one is associated with procedures. What are the procedures? A chorionic villus sampling, or an amniocentesis, or an external cephalic version, or a fetal blood sampling. These are the procedures. Then you've got others. There you have the most common one. What is the most common cause of Rh isoimmunization? That is delivery. This can be vaginal delivery or a cesarean section. Then you've got trauma, manual removal of the placenta, or in a post-dated pregnancy. All these can lead to Rh isoimmunization. Now, more important thing is about the management part of Rh isoimmunization. Before we go into that, what is the problem with Rh isoimmunization? What are the complications? The red blood cells are being destroyed. When the red blood cells are destroyed, what happens? The fetus develops hemolysis, problems with RBC destruction. Hemolysis can occur, anemia can occur. Because of this, there is hyperbilirubinemia. And because there is anemia, there is extramedullary erythropoiesis. What happens then? There is hepatomegaly, there is splenomegaly, there is placentomegaly. All these are features of the Rh isoimmunization. Rh isoimmunization may be mild, or it may be moderate, in which case it is called a moderate hemolytic disease, or icterus gravis neonatorum. Or it can be severe, in which case it is called erythroblastosis fetalis, or hemolytic disease of the fetus and the newborn. Now, when this becomes very severe, it can lead on to a condition called what? Hydrops fetalis. Hydrops fetalis means what? It is there in the name itself. There is collection of fluid in the third space. There can be ascites, there can be subcutaneous edema, there can be edema around the scalp tissue, scalp edema. All this is there. This is hydrops. All these problems are occurring basically due to RBC destruction. Now, one more thing you need to know, there is something called the mirror syndrome or the Ballantyne syndrome, where the mother also has severe edema. This implies intrauterine fetal demise in 1 to 2 days time. All right. Now, we'll first start with the management. We said that we'll check the blood group of the mother. If the mother is negative, we'll also, in the first visit itself, what will we do? We'll do an ICT. You find that the ICT is negative. Then what do? You repeat the ICT at 28 weeks. That is again negative. That is when you offer RADIP. Here we are talked about RADIP. RADIP is routine antenatal anti-D prophylaxis, which is given at around 28 weeks of gestation. It is 300 microgram of anti-D or 1500 international units given IM. Why? What is the significance of this 300 microgram? 300 microgram can neutralize 30 ml of whole blood or 15 ml of fetal RBCs. That is with regard to RADIP. So, you have to know this abbreviation because it is an accepted abbreviation. You may be asked, when is RADIP given? Don't sit there and think what is RADIP. Okay, this is what RADIP is. If ICT is negative at 28 weeks, you will be giving you will be offering RADIP, and then you will deliver her at 39 to 40 weeks. You will not be going post date. At 40 weeks, you deliver. Again, you will give anti-D. Irrespective of whether or not she has taken an antenatal anti-D, you will be giving anti-D 300 microgram within 72 hours, maximum within 4 weeks. 4 weeks. This is with regard to an RH non-immunized pregnancy. What happens if it is an RH immunized pregnancy? First visit itself, you do an ICT, you find that the ICT is positive. That is when you have to do a critical titer. As far as a D antigen is concerned, the critical titer is 1 in 16. It is positive in 1 in 16 dilutions. Then you will have to repeat the titer every 4 weeks. The critical titer is repeated every 4 weeks till 24 weeks, and then every 2 weeks. And you will deliver the baby at 37 to 38 weeks. Do you think this baby needs anti-D? No, because the baby has already been exposed, is isoimmunized, does not need anti-D. Now, this is when the critical titer, titer remains below the level of the critical titer. But suppose it crosses the critical titer, that is, you are getting a positivity in higher dilutions, or 1 in 32 positive, 1 in 64 positive. In that case, what you do, it has crossed the critical titer, then you want to know whether this baby is anemic or not. Then you should do either an amniocentesis, which was previously done, or you will do a MCA PSV. First, we will talk about the amniocentesis and what is being done with that. You take the amniotic fluid and you do a spectrophotometric analysis of the amniotic fluid, and you see for a spike at delta OD 450, at 400 optical density 450 nanometers. Is there a spike which corresponds to bilirubin? Bilirubin is what we look for, and then you plot it on a graph called the Lilly's graph. In the Lilly's graph, if the hemoglobin of the baby, if it falls in zone 1, if what you plot is in zone 1, it means that the hemoglobin is more than 14 gram %. Zone 2 is further divided into an upper zone 2 and a lower zone 2. Lower zone 2 means hemoglobin is 11 to 13.9 gram %. Upper zone 2 means it is 8 to 10.9 gram %, and if it is in zone 3, it means it is less than 8 gram %. Okay, that is an anemic baby. If it falls in here within these two ranges, you can go and repeat the amniocentesis, repeat it in every 2 weeks and see if it is becoming worse. But if it falls here, you have to do a codosynthesis to determine the blood, the hemoglobin of the baby. Now, that is about the amniocentesis. Nowadays, we don't go for an amniocentesis, we go for the MCA-PSV or a Doppler study. That is, if there is anemia, there is a brain sparing effect, which means that the blood flow through the brain is increased. There is an increase in the what is called the peak systolic velocity of the umbilical artery. What happens when that is there? Look at the spikes, there is a greater velocity. So, if this is more than 1.5 multiples of the median, you say that there is a fetal anemia. Again, you have to do a codosynthesis and then you will have to determine the hematocrit. What will you do next? Check the hematocrit. If it is falling above 30%, then you can wait. But if the hematocrit is less than 30%, what will you do? And if the hematocrit is less than 30% and the gestational age is more than 34 weeks, don't wait, go ahead and deliver. But if it has not yet reached 34 weeks, you will have to go for intrauterine transfusion. Intrauterine transfusion means it is O negative blood that is transfused with a hematocrit of 80% or more, obviously serology negative and irradiated. All right, that is about intrauterine transfusion. A couple of other things you need to know here. One is the AB test and the Klehor-Betke test. AB test is a qualitative test to distinguish between that distinguishes between maternal and fetal blood. This is of help in vasa previa. All right. This is an alkali denaturation test and it makes use of potassium hydroxide. While Klehor-Betke test is a quantitative test by which you need to assess the amount of anti-D that needs to be given in an RH sensitized, RH immunized pregnancy. And here it is an acid elution that is used, that is a basis. Citric acid phosphate buffer is used. Means that if there is 1 ml of fetal-maternal hemorrhage has occurred, you need 125 units of anti-D to neutralize it. So, if you get a question that says that 5 ml of fetal-maternal hemorrhage has occurred, it means that you need to give 625 international units of anti-D. All right. But if you are asked what is the best test to determine, best test to distinguish between maternal and fetal blood, your answer should be flow cytometry. All right. Okay. Now, since we have been discussing hydrops, one other thing, what is non-immune hydrops fetalis? Non-immune hydrops fetalis means the baby has got hydrops, but there are no circulating antibodies against the fetal antigens. This can be seen in certain cardiac problems like a congenital heart block or some chromosomal problems. Hematological problems like thalassemia, which is the most common cause. It can also be seen in twin-to-twin transfusion, GI problems, torch infections, etc. Okay. What was the question? Anti-D prophylaxis is required where? Anti-D prophylaxis is required in all cases except you don't need anti-D prophylaxis for intrauterine infusion. Okay. Let us move on to the next question. It is an assertion reason type of question. Hemoglobin cutoffs to diagnose anemia in pregnancy is more than in a non-pregnant state? No, it is not. It is less. So that is false. So immediately you have the answer. Assertion is false, but reason is true. What is that? Physiological hemodilution is seen in pregnancy. That is right. You know that pregnancy is a state of physiological hemodilution. Physiological anemia of pregnancy begins at 7 to 8 weeks. And it becomes maximum at 32 weeks. The important thing about physiological anemia is that it will never fall below 11 gram percent. It always remains above 11 gram percent. Okay. Now, about the nutritional anemias that we are planning to discuss here, the most common nutritional anemia is the iron deficiency anemia. You know that what is a normal iron requirement in pregnancy? Normal iron requirement in pregnancy is around 1000 milligrams. So we have got the National Nutritional Anemia Control Program where you give 60 milligrams of iron and 500 micrograms of folic acid to every pregnant woman, which will continue for 6 months post pregnancy also, right? So these are the cutoffs. This is the WHO cutoff, that is hemoglobin less than 11. Now, this one you have to know, hemoglobin less than 11 in the first trimester, 10.5 in the second and 11 in the third trimester, all indicate anemia in pregnancy, or postpartum it is less than 10. Also, we have got the ICMR grading into mild, moderate, severe and very severe anemia. If it is an iron deficiency anemia, all the RBC indices in an iron deficiency anemia, all RBC indices are reduced. The TIBC and the red cell bandwidth are increased. What is the most sensitive test for iron deficiency anemia? It is serum ferritin. The most sensitive index is mean corpuscular hemoglobin concentration, or the MCHC. What are the complications? All the complications of pregnancy are aggravated. There is a greater chance of cardiac problems, greater chance of postpartum hemorrhage, greater chance of hypertension, preterm labor, preeclampsia, APH. So that is it. As far as a baby is concerned, the most common one is a low birth weight. How do you treat iron deficiency anemia? If the depending on the gestational age, if the pregnancy is less than 30 weeks and if you have got a confirmed diagnosis of iron deficiency anemia, the treatment is oral iron. Oral iron can be given. Which is the one usually given? It is ferrous sulfate. If they are not tolerating or incompliant to oral iron, then you can think about a parenteral form of iron. But if it has crossed 30 to 36 weeks, then you will have to think about giving parenteral iron. Or if it is a folic acid deficiency, obviously you will have to give folic acid. If the pregnancy has crossed 36 weeks and you're detecting severe anemia, you'll have to give blood transfusion. We'll take these up one by one. Like we said, oral iron, which is the most common form that is used, it is ferrous sulfate. The treatment dose is 180 to 200 milligram. That is about 2 to 3 tablets per day. The first parameter that will increase after treatment is the reticulocyte count. Now, 2 to 3 tablets per day has to be taken throughout pregnancy, followed by 100 days postpartum also. Now we come to parenteral iron. The main advantage is that you have got a certainty of administration. What are the main indications? A patient has got malabsorption or is non-compliant or has got a chronic kidney disease. In that case, you will give parenteral iron. The rise in HB is the same as that for oral iron, that is around 0.7 to 1 gram per week. What are the ones that are given? You can give iron sucrose or at a maximum of 600 milligrams per week. Or you can give iron dextran, or you can give ferric carboxy maltose, which can be given 1000 milligram for over 15 minutes time. Iron can be given in two ways, intramuscular and intravenous. Intramuscular is not usually given. It is given by the Z technique. It can cause severe pain, it can cause abscess, it can cause infection and fever. So that is not usually given. So when you're giving parenteral iron, you might need to calculate the iron requirement. This is a formula that is used. This is the hemoglobin deficit, that is normal iron minus the patient's HB into weight into 2.21 plus 1000, or it can be the hemoglobin deficit into weight into 4.4. Both these formula can be used. So I'll give you an example. Suppose a woman has got hemoglobin of 10 and she weighs 50 kilogram. How much iron does she need? What is her iron requirement? HB deficit is normal. HB is always taken as 14. So HB deficit will be around say 4 into 50 into 2.2 plus 100, 1000. Okay. So that is how you calculate the iron requirement parenterally. So what happens when the pregnancy has crossed 36 weeks or she has got an active blood loss or she has got refractory anemia. She's got very severe anemia, or there are associated infections. In all these cases, you would like to give her a blood transfusion. So, blood transfusion means 1 unit of packed red cells will increase the hemoglobin by 0.8 to 1 gram percent. Okay, that is the importance of giving blood transfusion. So, what was our question? Yes, we have already answered the question. Let us take up the next one. Heparin in a pregnant lady with prosthetic valves is restarted from. It is only with prosthetic valves that we usually give anticoagulation as a routine. Heparin is restarted from 36 weeks. What are the anticoagulants that are used? That is warfarin and heparin. Warfarin is oral while heparin is parenteral. Warfarin is the stronger one. Heparin is weaker than warfarin. Warfarin can cross the placenta, heparin does not. Warfarin produces a dose-dependent toxicity, dose-dependent syndrome called the Kumaran syndrome or the De Salas syndrome, which comprises of stippled epiphysis, nasal hypoplasia and chondrodysplasia punctata, usually seen when the warfarin value is more than, when you are taking warfarin of more than 5 milligrams per day. The importance is that warfarin being the stronger one, warfarin is given not given up to 12 weeks. So, if you can divide the pregnancy into 0 to 12 weeks, 12 to 36 and above 36. 0 to 12 weeks you give heparin, 12 to 36 you can give warfarin, after 36 again switch back to heparin. All the anticoagulants should be stopped before delivery. When do you restart? You can restart heparin 6 hours after a vaginal delivery and 12 hours after cesarean section. You can revert back to warfarin depending on the PT-INR values. Now we come to diabetes. According to the IADPSD screening criteria, what is the cutoff value of blood glucose level for diagnosing gestational diabetes in a fasting state? You have the answer there. There are multiple things that are used, but IAD, here the one that is asked is the IADPSD criteria, which is 92. Remember that we are no longer following IADPSD, we are following the DIPSI criteria of GTT, where there is no fasting value, no 1 hour value, only the 2 hour postprandial value of more than 140 is considered. That is the only one that is important to diagnose gestational diabetes. Okay. Next question. A 30-year-old G3P2 patient visits an antenatal clinic at 20 weeks. She reveals during history that her first baby weighed 4.6 kilograms, second baby weighed 4.8 kilograms. All these are big babies. Both were delivered by C-section. Gynecologist suspect gestational diabetes, orders a GTT. Blood sugar level after 50 grams oral glucose are 206. And the patient is a confirmed case of gestational diabetes. All the following are known complications except. What are the complications that you expect in gestational diabetes? The main complication that you always know is the fetal macrosomia. Fetal macrosomia is due to fetal hyperinsulinemia. There can also be fetal hypoglycemia, fetal hypocalcemia, hyperkalemia, all these can occur as a part of gestational diabetes. But remember that in this case, 206 means a value of over 200 means that this woman is an overt diabetic, not a confirmed case of gestational diabetes. Okay. Anyway, what is a known complication? Which one is not a known complication? Fetal hyperglycemia is not a complication. In fact, it is fetal hypoglycemia that occurs in gestational diabetes. We have already talked about the complications. I just want to say a few things about some anomalies that are seen. Remember that GDM does not produce any anomaly. It is overt diabetes that can produce anomalies. What are the common anomalies? The common anomalies are produced in the cardiovascular system, followed by the central nervous system. The most specific anomaly of diabetes is the caudal regression syndrome, also known as a sacral agenesis. The most common cardiovascular system finding is hypertrophic obstructive cardiomyopathy, while the most specific finding is the transposition of the great arteries. Okay, these are the main complications. Now we come to management. We are not going into detail about all these things because I'm sure that you know all these things. The first line of management is a dietary therapy, which is called the medical nutrition therapy, whereby you advise the woman to follow a proper diet. If the drug of choice or the treatment of choice in all cases of diabetes in pregnancy, be it gestational, be it overt, the treatment of choice is insulin. But suppose a woman is not willing to take insulin, you'll have to give her some oral hypoglycemics, right? The oral hypoglycemics that can be given in diabetes are metformin and glyburide. So we'll have our next question. Again on diabetes, when to terminate pregnancy in insulin dependent diabetes? When do you terminate pregnancy in each of the diabetes? How do you deliver the baby? If the baby's weight is more than 4 kilogram, definitely go for a cesarean section. But otherwise, if the depends on what the woman is taking, how well controlled her blood sugars are. If the woman is on medical nutrition therapy, you'll deliver her from 39 to 40 plus 6 weeks, well controlled. All right. If she is on insulin, you'll deliver her from 39 to 39 plus 6 weeks. If she's an overt diabetes on insulin, you'll deliver her from 37 to 37 plus 6 weeks. As we said, if the weight is more than 4.5 or more than 4 kilogram even, we'll go for a cesarean section. If she presents in preterm labor, what is the tocolytic of choice? The tocolytic of choice is nifedipine. Remember that the beta mimetics are contraindicated in a case of gestation diabetes. Here, your best answer here would be 38 weeks. When do you terminate insulin dependent diabetes? You can go for 38 weeks. Now we come to hypertension. You have a pregnant lady, she's 35 weeks, 5 days with the BP of 170 over 110, proteinuria of 3 plus. She also has blurring of vision and headache. What is the next line of management? So, regarding hypertension in pregnancy, hypertension is of different types. It can be a gestational hypertension. It can be, if it is a hypertension with proteinuria or hypertension with features of end-stage organ dysfunction, you call it as preeclampsia. Depending on the severity, it may be preeclampsia with or without severe features. Then we have got eclampsia and preeclampsia superimposed on chronic hypertension. These are the main requirements. What is proteinuria? It is 300 milligram in 24 hours. Or you've got a urine protein creatinine ratio of more than 0.3. Or dipstick 1 plus persistent. Here you have got it is proteinuria of 3 plus and BP of more than 170 over 110, 35 weeks and 5 days. What will you do? You will treat the hypertension, start magnesium sulfate and then terminate the pregnancy. What is the significance of each of these? First we'll start with the drugs that are used in hypertension. The drug of choice for hypertension in pregnancy, be it preeclampsia, be it having severe features or not, be it an hypertensive crisis, it is always labetalol. If it is a crisis, it can be given intravenously also. Right? So we discussed this one. Now we'll discuss the expected management of severe preeclampsia. That is less than 34 weeks. Obviously, you will hospitalize her. You need to record her daily weight, input, output charts and start the antihypertensive treatment, which is labetalol. You will want to give her betamethasone for lung maturity, and then the PIH profile, that is laboratory tests are done every other day or even more frequently. You would ask the patient to monitor her daily fetal movement count, and then we'll have to monitor her frequently with daily NST depending upon the growth status and the like present. You would also like to do a twice weekly Doppler, amniotic fluid and the ultrasound. But when do you interrupt, when do you stop the expected management and immediately go ahead to deliver? See, in this case, in our question, the woman was having persistent symptoms. Mother is having severe headache or visual changes. He is going in for eclampsia. It is an impending eclampsia. then you will definitely have to terminate the pregnancy. Like in if she's got any features suggestive of pulmonary edema, the hypertension remains uncontrolled, she is having oliguria or a persistent thrombocytopenia, in all these cases you will terminate. Also, if there is a severe fetal growth restriction or the reversal of flow, or if the biophysical score has come much down, then also you will terminate the pregnancy. Now, before we had talked about that we'll give magnesium sulfate. Why? Because you want to prevent eclampsia. What is the regimen, or what are the what is it regarding MagSulf? Magnesium sulfate, as you know, is an NMDA receptor antagonist. It has got a very narrow therapeutic range of 4 to 7 milliequivalents per liter. When you're giving MagSulf, there are two different regimens. One is a Pritchard regimen. There are so many regimens. There is Pritchard regimen, and then there is a Sebai regimen, both of which you give loading dose followed by an infusion. So when you are giving an infusion of MagSulf, there are certain things that you need to look for. You've done this already, you know what it is. Obviously, since you're giving for BP, you will check their BP. What else will you look for? You will be looking for the deep tendon reflexes, the knee jerk, right? Deep tendon reflexes. Magnesium sulfate is one that is very much prone to toxicity. So the deep tendon reflexes should always be present. The first sign of toxicity is the loss of the deep tendon reflexes. When is it lost? When it is 10 milliequivalents per liter. Then the respiratory rate should always be maintained more than 14. When does respiratory depression occur? If when the value reaches 12 milliequivalents per liter. Likewise, cardiac arrest can occur if it reaches 30. Okay, these values are important, right? Now, next one we've got is a HELP syndrome. That is there, you know this, hemolysis, elevated liver enzymes and low platelet count. This is the most common cause of low platelet count in pregnancy is gestational thrombocytopenia. But in that case, the platelet count never falls below 1 lakh. This HELP syndrome, this is the most severe complication of preeclampsia. This is more common in the third trimester, and in many cases the BP can be normal. All right. There are certain criteria to diagnose this, that is the Tennessee criteria. The LDH should be 600 or more, which indicates hemolysis. AST, that is the SGOT, should be more than 70 and the platelet count less than 1 lakh. This is the Tennessee criteria. Then there is the Mississippi classification of HELP syndrome. 1, 2 and 3 depending on the platelet count. 3 means the platelet count is 1 to 1.5 lakhs. 2 is moderate, 50 to 1 lakh, and 1 means it is very severe, less than 50,000. So if the woman is presenting to you at more than 34 weeks in HELP syndrome, what do? You give MagSulf and then you deliver. But if she presents between 24 to 34 weeks, which is unlikely, again you give MagSulf, steroids for lung maturity, and you deliver. So ultimately, whenever a woman presents with HELP syndrome, you have to deliver her. Okay. Let us take the next question. What is the best treatment for impending eclampsia at 35 weeks? What is the best treatment? What is it? You have to induce labor. That is the best treatment. Impending eclampsia at 35 weeks comes to you. What will you do next? What will you do next? You will give magnesium sulfate. You know the difference between the next and the best. Okay. Next means how you have to control this and then you have to do something. Best means how will you take care of the disease? How will you prevent this, or how will you treat this disease? Okay. Identify the type of twin pregnancy seen here. See, you have got two sacs, two gestational sacs, two yolk sacs, two fetal poles. More importantly, you are able to see a thick intertwin membrane. And there is this sign here. What is this sign? This is the lambda sign. The lambda sign, which is seen in a, where is it seen? In a dichorionic diamniotic twin pregnancy. There is another sign, which is the T sign, which is seen in a monochorionic twin pregnancy. Look at the difference between the two. What is what is the difference between a DCDA and a monochorionic twins? If the division of the conceptus or the fertilized ovum occurs within 3 days, it produces a DCDA twins. Then from there on, if it is within 4 to 8 days, it is MCDA. More than 8 days, it is MCMA. And if more than 13 days have passed, it results in the formation of a conjoined twin pregnancy. So, always the problems are more with the monochorionic twins. We are not going into all the details of twins. We'll be just discussing the important points, right? Monochorionic twins, here this one, this is the Quintero staging. What is the Quintero staging used for? It is in twin-to-twin transfusion syndrome. Please study the stages. The first stage, there is only a difference in the amniotic fluid volume, that is a polyoligo sequence. In the second stage, the bladder of one twin is not visible. Third stage means there is abnormal Doppler. And in the fourth stage, there is ascites, pericardial effusion or overt hydrops. And by the fifth stage, there is a single or a double intrauterine death. Right, we'll take a short break now. So now we have the Quintero staging. How will you manage this? From 16 weeks onwards, if it is a monochorionic twin pregnancy, you will be monitoring the amniotic fluid volume. That is, from 16 weeks, the amniotic fluid volume will be checked every 2 weeks. If you are able to diagnose the TTTS, or you are able to see an oligopoly sequence before 20 weeks, if diagnosed, then you can offer fetal reduction using potassium chloride. What you're aiming for, if it is done after that, if you're diagnosing it after 20 weeks, then you'll have to go for an amnio reduction. Amnio reduction means you'll be doing serial amniocentesis with an aim of keeping the AFI less than 15 centimeters. You know what will happen if there is one twin acts as the donor, the other becomes the other acts as a recipient. The recipient twin will go in for a high output cardiac failure. The recipient twin will get HOCM or cardiomegaly and going for cardiac failure. The donor twin will have anemia or even become a stuck twin. Okay. From 2 to 4, all these stages, the treatment of choice is fetoscopic laser ablation of the anastomosis. From 2 to 4, that is the treatment of choice. Now, what is it that you've got here? This is not a TTTS, this is a trap. TTTS was an arteriovenous anastomosis, while TRAP or a twin reverse arterial perfusion is an arterial anastomosis. What happens is that the blood from the donor goes into the umbilical artery and it goes into the iliac vessels of the recipient, thereby perfusing only the lower part of the body, and see, only the lower part of the body is formed here. Alright, that is about TRAP. Now, how do you manage labor in a twin pregnancy? Always, if the first twin is vertex, then you can think about the option of a vaginal delivery. In the case of a DCDA twin pregnancy, which you will deliver at 38 weeks. But suppose it is a monochorionic twins. If it is a MCDA twin pregnancy, you can go up to 34 to 37 plus 6 weeks. Then also you can offer vaginal delivery. Triplets are delivered at 35 weeks, but an MCMA twins, monochorionic monoamniotic twins, are always delivered at around 32 to 34 weeks only by cesarean section. There is a high chance of death in a monochorionic monoamniotic twins. What is the most common cause of death? Most common cause of death is due to cord entanglement. That is why you would like to terminate the pregnancy at around 30 to 34 weeks. Next question. You have did we answer that question? Yes, we did. So next question, we have got a G2P1 female with mitral stenosis. She develops dyspnea, chest pain and palpitations. Her period of amenorrhea is 37 weeks. On examination, her pulse rate is 120 beats per minute. Respiratory rate is 30. Basal crepes are present in both the lungs. What is the management option? What should you do here? This is about the cardiac disease, cardiac problems in pregnancy. Previously, when we were studying about the maternal systemic adaptations, we learned that maximum cardiac output is in the immediate postpartum period. That is also the time when there is a greatest risk of cardiac failure, followed by the second stage, followed by the 20-32 weeks, the late first stage, early first stage. Okay. So, in pregnancy, if the woman is pregnant, the maximum risk of cardiac failure is at 28 to 32 weeks. Or if you're asked, when is it the highest risk for cardiac failure? You've got a choice immediately after delivery. That is your answer. All right. Anyway, is this woman in failure? How do you know that this woman is in failure? If she has got a respiratory rate of more than 24 per minute and a pulse rate of more than 100 per minute, you should always suspect an impending heart failure. See, 120 and 30, that is an impending heart failure. What do? We've got, you are aware of the NIHA classification. There are 4 classifications. Class 4 is the one where pregnancy is contraindicated. Like you just go through this: pulmonary hypertension, Marfan's, bicuspid AV with a dilated aortic root, severe LV obstruction. See, all these are conditions where pregnancy is contraindicated. Anyway, if the woman is in heart failure, what is it that you do? You do not wait anymore. You terminate a pregnancy. Do a cesarean after treating the heart failure. How do you treat the heart failure? You can treat it using just like any other heart failure, digoxin and diuretics and oxygen and morphine. You treat heart failure, you terminate the pregnancy. A couple of things about heart disease that you need to know. What is the most common heart disease? The most common heart disease in developing country like ours will be the rheumatic heart disease. If it is a developed country, it is a congenital heart disease. And the most common lesion is mitral stenosis. Also, the most common cause of maternal mortality in heart disease during pregnancy is also mitral stenosis. Okay, that is with regard to heart disease. Now we come to the infections. We are not going to go through all the infections. Which is not transmitted perinatally? Rubella is not transmitted perinatally. Rubella has got a classic triad. You know that: cardiac abnormalities, cataract and sensory neural hearing loss. So now we have got these infections. Okay, which of the infections have got the maximum risk of transmission in the first trimester? The risk of transmission in the first trimester is rubella. Before 20 weeks, maximum risk if infection occurs before 20 weeks is for varicella zoster. After 18 to 20 weeks, it is syphilis. But look at this, even though the risk is maximum of infection is maximum in the first trimester, the rate of transmission increases as pregnancy advances. That is, a maximum risk in the third trimester is for toxoplasmosis and hepatitis. Least risk of transmission during delivery is for toxoplasmosis. Remember this one also. Most severe congenital infection is rubella, and the most common one is the cytomegalovirus. But the one that has got the minimal teratogenic effect is the HIV. All right, a couple of things about HIV. See, there are no teratogenic effects. What is the most important risk factor? Most important risk factor in transmission of HIV? It is the maternal viral load. You also need to know how HIV is treated, especially in the neonatal period. In the neonatal period, you can give a single dose of nevirapine. It can be repeated within 72 hours. The mother should receive highly active antiretroviral therapy, and she can get zidovudin IV if her RNA count is 400 or more. So that is with regard to HIV, and then you have got the GBS prophylaxis. As far as the GBS prophylaxis is concerned, the best drug is penicillin, the second drug is ampicillin, and if at risk for anaphylaxis, you should give cefazolins. All right. Now we come to the next question. You have a 32-year-old woman. She visits the OPD with history of painless ulcer on the vulva. Obstetric history reveals history of stillbirth at 28 weeks, contact with multiple sexual partners. What is the next step? Always when you have got a painless ulcer and a history of stillbirth, you think about syphilis. So what is the best next step to diagnose syphilis? It is VDRL testing. But this is in no way a confirmatory test for syphilis. You will have to do a treponemial antibody test. Syphilis, primary, secondary syphilis. The primary syphilis presents as a single, hard, painless, something called a solitary chancre. Solitary chancre. This is a feature of the primary syphilis. There will also be non-tender inguinal lymphadenopathy. That is also a feature of the primary syphilis. The primary chancre will resolve spontaneously in around 2 to 6 weeks time. For a confirmatory test, you need to do a treponemial antibody test, and the treatment is by benzathine penicillin. What about a secondary syphilis? A secondary syphilis presents as condyloma lata. This is a flat-topped, moist necrotic papules that you can see. It is a tertiary syphilis, that is the gamma, which is a punched out ulcer with rolled out margins. Now here we have got a few obstetric instruments. What is this? What is this here? The scissors with the bend. This is the episiotomy scissor. And what is this? The next one that you've got here. This one also, you know, this is a scissors that is used for cutting the umbilical cord. It's a slightly different scissor which is quite strong with a bend at the end. This is the Mayo scissor that is used for cutting tough tissues like the rectus sheath. And this one, again, you have seen this. This is the Doyen's retractor. What is a Doyen's retractor used for? Especially for retracting down the bladder when you're doing a cesarean section. And here we have got a Deaver retractor, which is of more importance in abdominal surgeries when you try to pull back the muscles and the fat. Now, what is this? Have you seen this instrument? This is a kiwi cup. This is a vacuum cup. We haven't discussed operative vaginal deliveries here. We have just gone through, we haven't discussed instrumental deliveries. So, I have given a few comparisons. Please go through them. The kiwi cup means this, the importance of the kiwi vacuum cup is that, see, here you've got a sponge where it attaches to the fetal head. And the pressure can be controlled by the operator themselves. You're not attaching it to some kind of suction apparatus. So there is much less chance of the baby developing a cephal hematoma or a caput because of the result of the action of the vacuum. Okay, so we've got some complications. The most common complication is retinal hemorrhage. Okay, and certain other complications that are common here and there. Look at the complications more with forceps. Obviously, the more complications with forceps are for the mother. There is increase in the maternal trauma. Now, one thing that you need to remember is the sixth nerve palsy that is common with vacuum, while all the other nerve palsies are more common with the forceps delivery. All right, with that, we come to the end of our obstetric session. Remember that we have not covered everything, but almost all that you will need for your final preps. Okay. So we'll quickly go through gynecology also. We'll start with the first question. All of the following muscles are attached to the perineal body except the perineal body is also known as the central tendon of the perineum. The central tendon of the perineum. What are the structures attached to the perineal body? There is this mnemonic, blessed, bulbospongiosis, levator ani, external anal sphincter, superficial transverse perineum, sphincter urethrae, and the deep transversus perineum. Which is the structure that is not attached? It is the ischiocavernosus. Okay. Look at this picture. There are a few things you need to know with regards to this picture. Here, you can form a triangle, right? You have the clitoris here. You have the clitoris there. This is the vagina. This is the anal opening. Here, you've got the central perineal body. If you form a triangle like this triangle is called the vestibule. This is the vestibule. Anteriorly, it has got the clitoris. On either side, it has got the labia minora. And then posteriorly, it has what is called the foreshoot. So these are terms that you need to know. Sometimes you'll get a picture and there will be a point and you'll be asked to mark it. So here you've got posteriorly, that is the foreshoot that you've got. There are 6 openings in the vestibule. You have the urethra, you have the vagina, and then on either side you've got the Bartholin's ducts and the paraurethral or the Skene's glands. What are the openings that you see? You have the urethral opening, you have the vaginal opening, then you have the Bartholin's ducts and the ducts of the Skene's glands. Okay, 2 of these, 1 and 1. So totally you have got 6 openings into the vestibule. The posterior part of the vestibule between the fourchette and the vaginal opening is called the fossa navicularis. Okay. So these many things you need to know with regard to that picture. Next, we will talk a little bit about embryology. The remnants of the Wolffian duct in a female are located in. The remnants of the Wolffian duct are located in the broad ligament. What is the importance of the Wolffian duct and the Mullerian duct? In embryologically, the Mullerian duct gives rise to the female internal genital structures, whereas the Wolffian ducts give rise to the male internal genital structures. In the male, the Sertoli cells produce the anti-Mullerian hormone or the Mullerian inhibiting substance, which can lead to the regression of the Mullerian ducts. Absence of the anti-Mullerian hormone will lead to the development of the Mullerian ducts. In both the male and the female, there are certain vestigial structures that remain as remnants of these ducts. So, look at this. Wolffian ducts, the ductus epididymis, the vas deferens seminal vesicles, all these are formed from the Wolffian ducts. And the Mullerian duct, the remnant of the Mullerian duct in the male forms the appendix testis, which is also known as the what? The hydatid of Morgagni. Alright, the hydatid of Morgagni. Now, in the female, the Wolffian duct, the remnant of the Wolffian duct produces the Gardner's duct, which can look like a cyst, Gardner's duct cyst that will be similar to the cystocele. But the different, you may be asked to differentiate between a cystocele and a Gardner's duct cyst. In a Gardner's duct cyst, there are no rugosities like in a bladder. There is no impulse on cuffing and it is not reducible. Okay, that is a difference between a Gardner's duct cyst and a cystocele. Right, then what else is there? Then we have got the epophoron and the parophoron. Epophoron is formed from the cranial end of the duct. Epophoron is also known as the organ of Rosenmuller. Now, as far as we are going through embryology, you also need to know a few structures that are homologous in the male and the female. For example, the labia majora in the female is homologous to the scrotum of the male, while the labia minora is homologous to the penile urethra. The clitoris is homologous to glans penis, while the skin glands are homologous to the prostate glands in the male. Okay, so you need to know those two. Now let us take the next question, which is with respect to physiology. Testosterone helps in the development of various organs in the fetus. Which of the following stimulates its production? Testosterone is a hormone that is responsible for the formation, for the development of the male internal genital organs, while the male external genital organs are developed as a result of dihydrotestosterone. Okay, what stimulates the production of testosterone? Where does testosterone come from? It comes from the Leydig cells, and the production starts at around 8 to 9 weeks. Now, what stimulates the production of testosterone? We are not very sure. But we believe that there is the peak levels of testosterone production coincides with the peak levels of the HCG. So we believe that HCG may be responsible for HCG from the placenta may be responsible for the production of testosterone. So actually this is an ambiguous question since we don't have a clear answer. But as we have got something like this, HCG and peak levels of HCG coincides with testosterone, you can choose that as your answer. Okay. Testosterone production reduces in the third trimester when the HCG level falls also. So it probably is. All the following can occur under the influence of, under the effect of estrogen except not hair growth. Hair growth occurs under the influence of dihydrotestosterone or testosterone. Menopause is defined as, what is menopause? Menopause means there is cessation of menses. For how long? For at least 1 year. And why does that occur? Due to the loss of ovarian activity. That is menopause. Now, the life of reproductive age woman can be divided into 7 stages. This is called the straw staging system. Okay, see, look how it has been divided from the final. There is a reproductive period, there is a menopausal transition, which is a very important period as far as we are concerned, and then you have got the menopause and the post-menopausal period. The age of menopause, what is the age? Normal age of menopause is considered to be around 51 years, while in India, the mean age is at around 47 years. How can you diagnose menopause? The diagnosis of menopause, first of all, we talked about how you need cessation of periods for 1 year. But somebody comes to you with amenorrhea, how will you know whether she has gone into menopause? The hormone that you consider at that time is the FSH. If the FSH value is more than 25, it is suggestive of menopause. And if the value is more than 40, it is diagnostic of menopause. So, you say that a woman has got a premature ovarian insufficiency if she attains menopause before the age of 40 years. And you say that the woman has gone in for an early menopause if she attains menopause before 45 years. Okay. The hormones that are increased in menopause are, there is raised FSH, raised LH, and a fall in the estradiol. Note that there is no estrogen. It is not that there is no estrogen in menopause. Estrogen is there. Which is the estrogen that is there? The main estrogen of menopause is, estrone, which is produced in the adipose tissue by peripheral aromatization. That is the main estrogen. For menopause to be diagnosed, you need a value of FSH of more than 40 on 2 occasions, at least 4 weeks apart. Right? So now we come to the treatment. Hormone replacement therapy is indicated in menopausal women for, what are the main symptoms of menopause? The most important symptom is, the most important problem is that due to certain problems with the endorphins, pituitary endorphins, the heat regulation is affected. So the most common symptom of menopause is hot flushes. That is why usually you have to treat women. Menopausal hormone therapy. Now HRT has been replaced by MHT. Menopausal hormone therapy is indicated mainly for the complaint of hot flushes. Now, how do you give this? Before you give the treatment, you have to be sure that you are addressing the specific cause. What are the clinical features? The clinical features are mostly due to estrogen deficiency. She can have a dry vagina. She can have what can you say, decreased libido. All these are due to estrogen deficiency. Now, let us look at the menopausal hormone therapy. Suppose she has got only vaginal symptoms. Then you can offer her vaginal estrogen lubricants or moisturizers, only vaginal symptoms. Now, she has got other symptoms also, say like hot flushes. Then you think about whether or not the uterus is intact. If the uterus is intact, that is, the woman has a uterus but she has got menopausal symptoms, then what do? Then you will have to give her a combined estrogen and progesterone, because if you give her estrogen alone, she may go on to develop endometrial hyperplasia, eventually leading to CA endometrium. So you will give combined estrogen and progesterone. If the woman is post hysterectomy, what are the cause for her clinical features? It is a lack of estrogen. So if she is post hysterectomy, you can offer her estrogen alone or something called tibolone. What is tibolone? Tibolone is a steer, that is selective tissue estrogen activity regulator, which has got estrogenic property, progesterogenic property, and androgenic properties. So if she's post hysterectomy, you can always offer her estrogen alone or a tibolone. Now she wants to have a non-hormonal treatment. You're offering a non-hormonal treatment. You can offer her clonidine. You can offer her venlafaxine, which is an SNRI. You can offer her gabapentin. You can offer SSRIs like paroxetine or fluoxetine. Then you may have isoflavones or soy products. That is with regard to menopausal hormone therapy. One thing I want to, let me just put a question to you. We said that if she does not have a uterus, you'll offer her estrogen alone. But you are getting a question. You have a 45-year-old lady. She is complaining of menopausal symptoms. She has had hysterectomy done 1 year back for endometriosis. What will you give her? In this case, you have to give her estrogen and progesterone together. Why? Because the surgery was done for endometriosis. She will still have her endometrial tissue here and there. She may still have her endometrial tissue here and there in the ovary or in other parts of her peritoneal cavity. So, even if you are giving her estrogen alone, in this case also endometrial hyperplasia can occur. So, don't blindly go and pocket something. She has had a hysterectomy. If nothing has been mentioned about endometriosis, then you don't have to think about that. But if the question specifically states that hysterectomy was done for endometriosis, make sure you choose a combination estrogen and progesterone. All right. So, now there are some, what are the benefits? Increased bone mineral density, there is decreased risk of fractures, decreased incidence of colorectal cancer, decreased vasomotor symptoms. There can be an increased risk of stroke, venous thromboembolism, cholecystitis, coronary heart disease, etc. There are certain contraindications for menopausal hormone therapy. We'll just look at the absolute contraindications. What are the absolute contraindications? You can remember it as A, B, C, D. A is for she's got an active liver disease. B means she has an undiagnosed bleeding PV. She has got carcinoma of the breast or the uterus. She has got deep venous thrombosis or a history of DVT. Okay, that is ABCD, absolute contraindications to menopausal hormone therapy. Now, let us look at the symptoms of menopause one by one. The most important health problem of menopause is osteoporosis. What is osteoporosis? There is a decrease in the bone mineral density. So, we'll start with the diagnosis. How do you diagnose it? Diagnose by testing for the bone mineral density, that is by the DEXA scan, dual X-ray absorptiometry scan is done, and it is best measured where? Best measured at the hip. How do you treat? What is the first line? Always you start the first line treatment with calcium and vitamin D and exercise. The drug of choice or the first line treatment, this is for the prevention, okay. The first line treatment is bisphosphonates like alendronate or bisandronate. That is the first line treatment. What is the second line treatment? What is the second line treatment? Second line treatment will comprise estrogen and progesterone. Like we said, the tier, that is Tibolon. Then you've got raloxifene. Raloxifene is like Tibolon, just not a steer. It is a SERM, a selective estrogen receptor modulator. So, these are what you will do for osteoporosis. A couple of things you need to know. These drugs will act either on the osteoclast or on the osteoblast. The only drugs that act on the osteoblast are teriparatide and strontium. All the other drugs will act on the osteoblast. Now, that is with regard to the menopause. There is something other than this, that is a well woman checkup. The well woman checkup, what are the things that you need to do? Or as a woman's health initiative, what are the things that you need to cover? That means a woman's health initiative comprises complete medical history and exam every 5 years from 40 years of age. That is the first one. Then annual visits with breast examination, vaginal examination, body mass index, and screening for sexually transmitted infections. TSH to be done every year till 40 years, then every 2 years till, then every 2 years. Bone mineral density from 60 years. Annual screening mammogram from 40 years. Colonoscopy 50 and 55 years. You have to know this because you can get a question. All the following are components of the Women's Health Initiative except. So, these are the components of Women's Health Initiative. That is with regard to menopause. Let us go to the next question. This is something you all know very well. A 20-year-old woman was diagnosed to have polycystic ovarian disease. Which of the following are the treatment options? What is the treatment option? Lifestyle changes, OCPs, anti-androgenic drugs, all of them are treatment options. Polycystic ovarian syndrome, also known as the Steen-Leventhal syndrome. It can be autosomal dominant. It can be inherited by CYP21 gene. We are not very sure of this. You say that a child or a girl has polycystic ovarian syndrome only 2 years or more after she has attained menarche. The first time she comes with irregular cycles, you do not make a diagnosis of polycystic ovarian syndrome. The main pathology is increase in serum LH. Main pathology. Increase in LH. But this is not the hallmark. The hallmark of PCOS is insulin resistance and compensatory hyperinsulinemia. Look at this picture. The testosterone is increased, DHEAS is increased, androstenedione is increased, all these are increased. But there is only a modest rise in testosterone, that is, it remains between 70 and 150. Suppose there is a huge rise in testosterone, it goes above 200, then you will have to consider a testosterone producing tumor of the ovary or the adrenal. Okay, anyway, all these are increased. Estrogen is also increased, but it is mainly the estrone that is increased. There is a rise in LH, rise in FSH, but it rise in LH and a fall in FSH. So the LH FSH ratio changes to 2:1 from 1:2. Because the LH rises like that, there is also a theca cell hypertrophy and the androgen production also is increased. So, since the LH is tonically elevated, there is no LH surge occurring. It is the LH surge that is needed for ovulation. You know that because there is no LH surge happening, there is also an ovulation that happens. Now, we come to the Rotterdam criteria. You need at least 2 of the 3 criteria for diagnosis of PCOS. First one is oligo or anovulation, that is indicative of an ovulatory dysfunction. She'll have irregular cycles. Then you have got biochemical or clinical signs of hyperandrogenism, and you have got polycystic ovaries, 12 or more follicles, 2 to 9 millimeters in diameter, or the ovarian volume is more than 10 cc. What are the risks? There is increased risk of cardiovascular disease, diabetes mellitus, carcinoma of the endometrium, carcinoma of the breast, increased risk of depression, sleep apnea, even non-alcoholic steatohepatitis. Look at this. What is this? This is the Hare-Ann syndrome. HA standing for hyperandrogenism that we discussed, insulin resistance, and acanthosis nigricans. It is this velvety color that you see here, dark velvety color, which is called acanthosis nigricans. You have also got the metabolic X syndrome. What are the components of a metabolic X syndrome? There is abdominal obesity. Abdominal obesity means the waist is more than 88 centimeters. Triglycerides more than 150. HDL falls to less than 50. BP is more than 135 over 85 millimeters of mercury. Fasting blood sugar is more than between 110 to 126. And the postprandial blood sugar is more than 140 to 199. All these are components of the metabolic X syndrome. This also you have to study. Don't by heart, these are things you know, you have studied in medicine also. All right. Now, one other thing is, how do you manage hirsutism? Management of PCOS. First management is a lifestyle modification. You ask them to do good workout, you ask them to reduce weight, reduction of the BMI. Next one is how you can control the insulin resistance. Possibly you can give them insulin sensitizers like metformin. Then another one that is coming up in these days is a inositol or a myoinositol. Then you need to manage the hirsutism. How will you treat hirsutism? The best treatment when you treat hirsutism, the best treatment is oral contraceptive pills that contain progesterones without an androgenic activity. That is the best treatment. That can be ethinyl estradiol with desogestrel or medroxyprogesterone. Others include spironolactone, cyproterone acetate, flutamide or finasteride, and then topical applications like eflornithine. But if you need to get rid of the hair that is already grown, then you'll have to offer her something like a laser treatment. That is with regard to the treatment of PCOS. Suppose we already said that the PCOS is a case of anovulation. How will you bring about ovulation in PCOS? That is where you give her something like a clomiphene citrate. Okay. Now we'll move on to the next question. A 25-year-old female with primary infertility comes to the hospital with ultrasound finding of uterine anomaly. Which of the following is used to confirm the diagnosis? How do you confirm a uterine anomaly? We had discussed in the question of on embryology that the female internal structures are formed from the Mullerian ducts. So you have got two tube-like structures, two tubes are there. What happens? First they fuse in the middle. And then this fusion is extended upwards and downwards. And here it becomes a uterus and the tubes, while the ovaries are formed from the gonadal ridges. So, suppose there is something that interferes with the fusion of the Mullerian structures, there occurs congenital defects in the uterus or the female internal genital organs, which are collectively called the Mullerian anomalies. Now, how can you confirm? How do you know? How can you confirm? The best diagnosis is by a hysteroscopy and a laparoscopy combined. Why it is, we'll come to. See, this is how the Mullerian anomalies are graded. See here a normal uterus. Then here you've got a uterine hypoplasia. Uterus itself is not formed. Uterine hypoplasia. Then a unicornuate uterus, that is only the Mullerian tube of one side develops. And in this case, see, there is only one fallopian tube also. This is a uterus didelphys. This is important, that this is the only condition with two vaginae. That is, there is failure of fusion along the whole length of the Mullerian ducts. Now we have got class 4, that is the bicornuate uterus, where only the lower part fuses. This can be bicornus bicollis with two cervices or bicornus unicollis with only one cervix. Then we have got the septate uterus. Fusion has occurred, but the septum has not resolved. Then we have the arcuate uterus, where the fundus remains flat. And finally, there are some drug-related or diethyl stilbestrol related problems in the formation of the uterus. The most common of the Mullerian anomalies is the arcuate uterus, followed by the septate and the biconvate. But if you're asked which is the most common anomaly causing infertility or miscarriage, it is the septate uterus. So the most common anomaly is arcuate. Most common anomaly leading to infertility or miscarriages is a septate uterus. Here, this is what we just discussed, what happens in each case. Now we come to something else, which is a Mullerian agenesis or the MRKH syndrome. You have got a girl who is 15 to 18 years of age, and she's being brought by her mother with complaints of primary amenorrhea. Always when you get a girl with primary amenorrhea, you will be doing a scan, or you will be doing a vaginal or rectal examination. You do a vaginal examination, you find that there is a blind ending vagina. The vagina is a dimple. There it is a blind ending vagina. Check if the girl has got a uterus. If she does not have a uterus, you should immediately do a karyotyping. You want to know whether this is a Mullerian agenesis or an androgen insensitivity syndrome. Okay, we'll start with the Mullerian agenesis. What happens? The Mullerian ducts are not formed. The genotype is 46XX. Uterus, cervix and upper part of vagina are absent, while the ovaries and the distal part of the fallopian tubes are present. So ovulation is normal. That is, this girl can have her own offspring. Estrogen is also normal. So her secondary sexual characteristics are also normal. You get a question, what is the investigation of choice for Mullerian agenesis? The investigation of choice is ultrasound. With what ultrasound? Usually it is a transrectal ultrasound, that is the investigation of choice. Now, this is associated with certain other abnormalities also. What are the abnormalities that are most commonly seen? The common associated abnormalities are renal. Most commonly it is renal agenesis, followed by a horseshoe-shaped kidney. Then you got skeletal anomalies like hemivertebra, unilateral or bilateral hearing loss. How do you treat it? Treatment is where you cannot see. Now uterine transplantation is coming up, but if you're asked what is the management is a McIndoe or a Reed vaginoplasty or Williams or a Vecchieti. It is a vaginoplasty that is done immediately before marriage or immediately before the girl becomes sexually active. Okay, that is the treatment. It is not without complications. Even after vaginoplasty, she can develop restenosis or dyspareunia. What are the differential diagnoses of this condition? Androgen insensitivity we talked about. The other one is a cryptomenorrhea. Cryptomenorrhea means she has got cyclical symptoms of menstruation, but the blood is not coming out. The most common reason for cryptomenorrhea is an imperforate hymen. See, there is a comparison between MRKH and androgen insensitivity syndrome. See, the genotype is XY. The testosterone levels are normal. There is an increased height. There is decreased pubic and axillary hair. Okay. The important thing that we always need to keep in mind is that if she's diagnosed to be an androgen insensitivity syndrome, the gonads have to be removed immediately because of the risk of gonadoblastoma. Look at this here. What is this? This is a HSC. Picture of a biconvate uterus. You may be able to ask what it is. You may be given a picture like this and asked. You will be able to distinguish most of the structures, but sometimes you might find it difficult to distinguish between a biconvate and a didelphys structure. In that case, see, this is a cannula. The one that is used is called the Leach-Wilkinson cannula. Always look at the cervix or the vagina. If there are two cannulae like that, you can confirm that this is a didelphys because two vagina are not present in a biconvate uterus. So, as that is about it. Now, if you are asked what is the investigation of choice for Mullerian anomalies? What is the investigation of choice? It is MRI followed by 3D ultrasound. But if you're asked what is the gold standard It is laparoscopy plus hysteroscopy followed by laparoscopy alone. Before we start the next question, we'll take a short break. What is the first sign of puberty in a girl? The first sign of puberty in a girl is thelarchy. What is thelarchy? It is the development of the breast. Likewise, if you are asked in a male, the first sign of puberty is the increase in the testicular volume. A couple of things with regard to puberty. What is precocious puberty? Precocious puberty is the onset of puberty before 8 years in a girl. The most common cause is idiopathic only. There are two different kinds of precocious puberty, which is a central and a peripheral. Central precocious puberty, this is a true precocious puberty. This is due to an increase in the GnRH or other gonadotropins and sex hormones. While peripheral precocious puberty, which is a pseudo puberty, it may be isosexual or heterosexual. Isosexual is due to estrogen secreting tumors, like there is excess of estrogen. While a heterosexual precocious puberty means there is excess of testosterone, which may be due to, most commonly due to a congenital adrenal hyperplasia or a testosterone secreting tumors. Congenital adrenal hyperplasia is one of the important things that you need to know. What is the most common cause of female pseudohermaphroditism? That is congenital adrenal hyperplasia. This is also, you can also get a question like, which is the most common cause of ambiguous genitalia in the female? That is also congenital adrenal hyperplasia. Now, you know this pathway of cholesterol synthesis. Here, you have got the most common enzymes that are enzyme deficiencies that are responsible for producing CAH. The most common enzyme deficiency is 21 alpha hydroxylase deficiency. And the second most common one is 11 beta hydroxylase deficiency. Now we come to the screening for a congenital adrenal hyperplasia, which is you have got a deficiency of 21 hydroxylase or 17 beta hydroxylase. There will be an increase in what? There is an increase in 17 hydroxyprogesterone. So for screening, the one that you check is 17 hydroxyprogesterone. If this is less than 200, that means you can rule out congenital adrenal hyperplasia. If it is more than or equal to 800, then you can confirm your diagnosis of CAH. But suppose this is between 200 and 800, then what do? Then you will need something of a more permanent nature. You need a diagnostic test. The diagnostic test is the ACTH stimulation test. That is, after ACTH stimulation, you check the 17 hydroxyprogesterone again. After ACTH stimulation, if the 17 hydroxyprogesterone is more than 1500, then you can confirm your diagnosis of CAH. How do you manage? In CAH, you find that there is deficiency of all the glucocorticoids, mineralocorticoids, there is ambiguous genitalia, sex steroids, everything is deficient. So, management will consist of, you have to give mineralocorticoids, you have to give corticosteroids. The girl might also need surgery for ambiguous genitalia. Now, how you give corticosteroids, how do you give the steroids depends on the age. Up to puberty, in a non-pregnant state, that is up to puberty, you're diagnosed early, young girl, up to puberty, you will give hydrocortisone. Why? Because hydrocortisone is a short-acting steroid. If you're giving a long-acting steroid, it can affect the epiphyseal closure. So, up to puberty, you will give hydrocortisone. After the epiphysis has closed, you can offer her a longer-acting steroid, which is either you can give dexamethasone or prednisolone. Reproductive age, in a non-pregnant state, you can offer hydrocortisone. Now, what happens when the woman becomes pregnant? As soon as the pregnancy test is diagnosed as positive and as soon as a UPT becomes positive, that is by 4 to 5 weeks itself, you have to begin dexamethasone. Then you will do at 10 weeks, you will do a chorionic villus sampling. This is the one condition where you are allowed to determine the fetal sex. After doing a chorionic villus sampling and determining the fetal sex, if it is a male or an unaffected female, you can stop dexamethasone and continue hydrocortisone that she has been taking. If it is an affected female, you will continue with the dexamethasone. All right. So, that is about congenital adrenal hyperplasia. Next question. Which of the following investigations is not done for evaluation in Turner syndrome? What is Turner syndrome? All these are part of Turner syndrome, something that you have been studying for a very long time. Turner syndrome is caused by a de novo or the severe structural loss of one of the X chromosomes. So, Turner syndrome is 45XO. This you know. This is caused due to there are long repetitive CAG sequences. That is about Turner syndrome. But whenever you have a patient with a Turner syndrome, it is a must that you should do a karyotyping. Why? Sometimes there may be a Turner mosaic, that is X0, XY, where in this case, if they have got a gonad, it can go on to develop a gonadoblastoma. That is why you need to do a karyotyping in Turner syndrome. This is the most common form of gonadal dysgenesis that leads to a primary ovarian failure, but the most of the affected fetuses become spontaneously aborted. Remember that there is a rise in LH and FSH in Turner syndrome. We talked about how there is a high risk of developing gonadoblastoma. If there are testes, there will be small firm testes. So, it is also the most common cause of primary testicular failure, cryptorchidism, and sterility. How do you manage? You manage by starting with estradiol 0.25 milligram. It is given for approximately 6 months. That is, you have to start the treatment at around the age of 12 years. That is, near puberty, you will be starting treatment with estradiol. Why? Because only after the endometrium has become primed with estrogen that you can give progesterone and produce a withdrawal bleeding. You need to bring about menstruation, right? So, after around 1 year of unopposed estrogen treatment, you can start progesterone and then you can bring about cyclical bleeding like that. What was our question? Which one of the following is not done? Will you be doing a cardiac evaluation? Yes, you will be doing a cardiac evaluation because there is a high risk of constriction of the aorta. Will you be doing an OGTT? Yes, there is a high risk of developing diabetes mellitus. Will you be doing a hearing test? Will you be doing an audiometry? Yes, there is a risk of sensorineural hearing loss also. But what won't you be doing? There is no need to do an ANA profile in Turner syndrome, but you will need to do a karyotyping. Question 12. A 28-year-old married female anxious about conception with complaints of profuse white discharge, no history of itching, presents on the 12th day of LMP. Which of the following is the most probable diagnosis? No, vaginal discharge is a very common complaint in gynecology. So, most commonly, that is at around the 12th day of LMP, that is around mid-cycle, the most common cause of vaginal discharge, which is clear, without itching, which is not malodorous, the most common thing is it may be related to ovulation. So, this is only a physiological vaginal discharge. Now, you have got your next question. We'll come to the pathological discharges. We'll start with bacterial vaginosis. What is true about bacterial vaginosis? Bacterial vaginosis is the most common vaginitis. Remember that this is not a sexually transmitted infection. Then what causes it? This is caused due to the alteration of the vaginal flora. That is, what is the main vaginal flora that you see? It is lactobacillus. The number of lactobacillus are decreased, and there is an increase in other organisms like cocobacilli, like Gardnerella vaginalis, like Atropium, like Mycoplasma. See, these are the main organisms that are responsible. As the number of these organisms increase, there is a decrease in the growth of the lactobacillus. How do you diagnose it? There is a criteria which is called the AMSEL criteria. 3 of the 4 criteria must be met. First of all, you've got a homogeneous non-clumping vaginal discharge. Homogeneous non-clumping. Then you have got a fishy odor or an amine odor when a potassium hydroxide is mixed with the discharge. This is called the whiff test. Then you should look for clue cells on saline microscopy. And you've got a vaginal pH of greater than 4.5. Why? Because the lactobacillus that gave the acidic pH to the vagina are destroyed, so the vaginal pH is increased. Couple of things. The gold standard for the diagnosis is gram staining. On gram staining, you will give something called a Nugent scoring. And if the Nugent score is 7 or more, you say that this is a case of bacterial vaginosis. What are the risk factors? We said that this is not caused due to sexual infections. This is not sexually transmitted. The risk factors will include excessive douching, black rays, smoking, intrauterine contraceptive devices, etc. So, one very important thing that you have to know, the patient will present with maybe offensive vaginal discharge, but she will never present with itching because there is no inflammation. So, the woman will not complain of itching. So we have the gold standard investigation, which is gram stain. What is the investigation of choice? The investigation of choice is saline microscopy. And it is on saline microscopy that you see these. What are these? This here. These are the clue cells. What are clue cells? Clue cells are only vaginal epithelial cells with attached bacteria. I am writing this down because a question has been asked before. What are clue cells? You have to remember it is just the bacteria attached on the vaginal epithelial cell. Now we come to the management. Management is different in a non-pregnant state and a pregnant state. How do you manage in a non-pregnant state? You give metronidazole 500 milligram twice daily for 7 days. Or you can give clindamycin cream. If the woman is pregnant, again you can give metronidazole 250 milligram twice daily for 7 days. Do you have to treat the partner? No, treatment of the partner is not needed. This is not a sexually transmitted infection. In pregnancy, bacterial vaginosis in pregnancy produces a greater risk of preterm birth and PPROM. Know that even if you treat it, even if you give metronidazole adequately, the risks due to bacterial vaginosis cannot be prevented. All right. Next question. A young lady presents to your office with complaints of copious vaginal discharge, but there is no cervical discharge on per speculum exam. Just a second, did we answer this one? No. So, what is true about bacterial vaginosis? Is there intense pruritus for bacterial vaginosis? This is the one that we just discussed. No, there is no intense pruritus. Is it associated with intensive mucosal inflammation? No. So, what is true? There is a gray and white discharge. That is a true. So we have a young lady here. She is coming to the office with complaints of copious vaginal discharge, but there is no cervical discharge. No cervical discharge. She has got copious vaginal discharge. Which of the following should be given for the management? We will be now talking about the syndromic management of vaginal infections. See, syndromic management means it depends on the syndromes you can manage. If it is a urethritis, if it is a male with the urethritis, you have to give treatment for it. Can be caused due to gonorrhea or chlamydia, and you will give treatment for both. If it is a vaginal discharge with itching, you are suspecting candidiasis, what will you do? You give clotrimazole pessary 100 milligram for 6 days. If it is a non-specific vaginal discharge, then again you will give metronidazole with clotrimazole for 6 days. But you are suspecting cervicitis. What causes cervicitis? Again, because of gonorrhea and chlamydia, you will be treating accordingly. Now we come to pelvic pain. Pelvic pain may be due to gonorrhea, it may be due to chlamydia, it may be due to other mixed anaerobes. Pelvic pain means it can be lower abdominal pain also. All right. Now, in this case, you see that she has got vaginal discharge, but she does not have cervical discharge. That means there is no cervicitis. It is just what? It is just vaginitis. Any discharge PV can be vaginitis or cervicitis, but here the cervix is normal. So, you have to do what? You have to treat the vaginitis. How do you treat vaginitis? You can give metronidazole for, it can be bacterial vaginosis or candidiasis. You give metronidazole for bacterial vaginosis, and for candidiasis you can either give fluconazole or clotrimazole. So, in this case, what is your answer? You will give metronidazole with fluconazole. Okay. This one also you need to know what is the color of the kits, which is the kit to be prescribed, and what are the drugs included in the kit. These are the kind of things that you need to look up just before the exam so that it stays in your mind. Even if you study it several times over and over, you are very likely to forget it. Okay. Anyway, you got 6 kits. These kits are for either discharges or for ulcers. Urethral or anorectal kit, which is a gray kit. Vaginal discharge, remember vaginal discharge kit is green. That is important. No? Vaginal discharge, the kit is green. If it is a non-herpetic genital ulcer, you got 2 kits. That is, if the person is responsive to penicillin and allergic to penicillin. So, you've got 2 kits. Genetical, that is, if it is a herpetic ulcer, the kit is red. PID, the kit is yellow. These 3 at least you try to remember. Vaginitis, it is green. Non-herpetic ulcer, it is red. And for PID, it is yellow. Others, you please go through so that it stays in your mind immediately before the exam. Okay. Next question. You have a 55-year-old multigravida, history of frequently micturating due to coughing and laughing and sneezing. What is your diagnosis? Diagnosis is easy. It is stress incontinence. Now you come to a few things about stress incontinence. The symptoms of a genuine stress urinary incontinence, that is when there is increase in pressure, urine leaks. The symptoms are caused due to the pudendal nerve. How do you diagnose? There are you need to know some names here. One is a Bonnie's test. Bonnie's test is used to demonstrate stress urinary incontinence. Coming to the treatment, the first line treatment is Kegel's exercises or pelvic floor exercises. The gold standard is the Birch-Kolpu suspension. If you're asked what is the best treatment, it is the transobturated tape followed by the transvaginal tape. Okay, these things you need to know. So many named surgeries are there in prolapse and in urinary incontinence and vesicovaginal fistula repair. Few things you should know. One is a Bonnie's test that detects or that demonstrates a stress urinary incontinence. Then the first line management of incontinence is always pelvic floor Kegel's exercises. Then gold standard is Birch-Kolpu suspension. Best test is TOT. Another one is the Marshall-Marchetti-Kranz operation. The Marshall-Marchetti-Kranz. Not for the importance of the surgery, it produces a specific complication. That is why you need to know that. What is a specific complication? It is osteitis pubis. That is about the surgeries. Next question is with regard to the vesicovaginal fistulae. What is the most important investigation done for vesicovaginal fistulae? The most important investigation is cystoscopy. What is vesicovaginal fistulae? There is a fistula from the bladder to the vagina. What causes vesicovaginal fistulae? What is the cause? We'll just go through the causes first. The most common, this is the most common urinary fistula. What is the most common urinary fistula? It is the vesicovaginal fistula. The most common cause, especially in countries like ours, is obstructed labor. The most common cause of a uretrovaginal fistula is surgery, usually wartime cystectomy. The most common cause of vesicouterine fistula is cesarean section, and most common cause of a rectovaginal fistula is a complete perineal tear. These many things you need to know. After that, now we'll take this up once more, take up the vesicovaginal fistula once more. Vesicovaginal fistula is classified based on the distance from the external urinary meatus. Just like pelvic organ prolapse is classified based on the distance from the hymen, VVF is classified based on distance from external urinary meatus. Now, there is a methylene blue 3 swab test that helps in the diagnosis. This is how it is. The uppermost swab is soaked but unstained with dye. It is a uretrovaginal fistula. Why? Because the dye is in the bladder and not in the ureter. And then you have got the vesicovaginal and the uretrovaginal fistulae also. How do you manage? The management is definitely by surgery. So if it is a very small small fistulas usually heal themselves, heal spontaneously during the first few weeks. But if it is an established fistula, what will you do? You wait for 3 months. Why? You want all the tissue inflammation to subside. Then you can attempt to cure it surgically. If one attempt fails, then you wait another 3 months. If a fistula is occurring following a surgery and if it is immediately recognized, then you have to repair it within 24 hours. Otherwise, wait for 3 to 6 months. The same is applicable to perineal tears also. If the fistula has occurred as a result of radiation, then 2 years time can be taken. At least 1 year should be taken before it is repaired. So these are the techniques. You need to know the names. Large scope procedure, Chasser-Moyer technique are used for repair of vesicovaginal fistulae. Post-operatively, you need to put in a catheter for 14 days and you need to give antibiotic coverage during the time. You are asked to avoid a PV examination, speculum examination or intercourse for 3 months time, and pregnancy should be avoided for 2 years preferably. In pregnancy following repair of a fistula, it is always better to go for an elective cesarean section. Now we come to fertility. You have a semen analysis showing absent fructose. Which of the following is the probable cause? As far as male infertility is concerned, the causes can be divided into a pre-testicular cause, testicular cause and a post-testicular cause. See, here you got it. Pre-testicular cause means it is from the hypothalamus or the pituitary. That is, there is deficiency of gonadotropin or there is thyroid dysfunction, there is increase in prolactin, there are some psychosexual problems due to drugs like antihypertensives or antipsychotics, or 47XXY like Kallmann syndrome or Y chromosome deletion. All these are pre-testicular causes. In this case, LH and FSH and testosterone all are reduced. If it is a testicular cause, as in orchitis, trauma, if there is an immotile cilia syndrome, if there is a varicocele, that is testicular causes, the testosterone is decreased. And since there is no negative feedback, LH and FSH are both increased. Alright. If it is a post-testicular cause, as in there is an obstruction or there is a congenital bilateral absence of the vas deferens, or it is a Young syndrome, there is an ejaculatory failure, or there is retrograde ejaculation. In the post-testicular phase, post-testicular failure, all the hormones will be normal. Okay, if you can just think about it, you'll be able to understand why the hormone pattern is like that: pre-testicular, testicular, post-testicular. Now we'll look at what contributes to the semen. It is from the testis or the epididymis that you get the spermatozoa. What about the fructose? Fructose comes from the seminal vesicles mainly. Then you have got the prostatic fluids, which secretes a fibrinolysin. Prostatic fluid is responsible for bringing about the acrosome reaction and all that. Then we have got the bulbourethral glands that secrete the mucus. What was our question? The semen analysis has showed absent fructose. So in most probably this is a case of obstructive azoospermia. How do you manage a case of obstructive azoospermia? Obstructive azoospermia means what? Here, seminal vesicles, if there is absent fructose, means there may be an absent seminal vesicle because that is from where the fructose comes. Or there can be also an obstruction of the ejaculatory duct. In this case, the answer is both of the above. We'll just see how an obstructive azoospermia is managed. You have a patient with obstructive azoospermia. The volume of the semen is normal and fructose is present. What does that mean? Fructose is already present. So the block is above the seminal vesicles because seminal vesicles produce fructose. In that case, what do? You do a scrotal ultrasound. You need to know if there is something wrong with the epididymis or so. Suppose volume is low and fructose is absent. That means the block is below the seminal vesicles. In this case, this can be a congenital bilateral absence of the vas difference. Where is it commonly seen? It is seen in cystic fibrosis patients. So, you will have to do a CFTR gene study. It can also be an ejaculatory duct obstruction, in which case you will go ahead and do a transrectal ultrasound. Okay. So, that is the answer to that question. A 32-year-old patient attends the infertility clinic with regular cycles of 28 days. What should be evaluated for confirming ovulation? First of all, if a woman has got regular cycles, she is most probably ovulating. Anyway, you need to confirm ovulation because ovulation is the most common cause of female infertility, which is followed by the ovarian reserve, decreased ovarian reserve. So, what are the tests for ovulation? First of all, you have got the basal body temperature. What does that mean? Progesterone is a thermogenic hormone. So, under the effect of progesterone, on the day or around ovulation, there is a rise in the body temperature of 0.5 to 1 degree Fahrenheit. This immediately comes down about 2 days before menstruation. This is called the biphasic pattern. So, that is about the basal body temperature. Then you have got the next test is the cervical mucus. Cervical mucus becomes long and slippery under the influence of estrogen, and there is a ferning pattern. This is called the spin barkite. Spin barkite occurs under the influence of estrogen. Now, once after ovulation, progesterone comes into play, this stretchability of the mucus is lost and it is thick and it starts breaking easily, which is called the tack. This is under the influence of progesterone. That also indicates ovulation. Then you have got your vaginal cytology. If there is a large amount of intermediate cells which are occurring under the influence of progesterone, again that suggests ovulation. But these are not the most important tests. The most important tests are the hormone tests. Hormone tests will start with progesterone, serum progesterone on day 8 and day 22. That is, it will be less than 1 on day 8 to more than 3 on day 22. That is the importance of serum progesterone. Then you have got the endometrial biopsy, which is done in the premenstrual phase. If it shows a secretory endometrium, that means ovulation has occurred. Even though these are the important tests, the one that is more commonly done is the serial ultrasound. Serial ultrasound means or ovulation study. This is the one most commonly done. You study the size of the follicle, see how it increases, and if ovulation has occurred, you'll find that the follicle has collapsed and there is free fluid in the pouch of Douglas, along with which what you can see is the trilaminar endometrium. If you need a direct evidence of ovulation, you will have to do a laparoscopy. And the conclusive evidence that ovulation has occurred, what is it? Conclusive evidence is pregnancy. These are the tests for ovulation. Now coming to the test for ovarian reserve. What is ovarian reserve? It refers to the quantity and quality of the oocytes in the ovary. This is the second, reduced ovarian reserve is the second most common cause for female infertility. So, first of all, we'll start with the clinical markers, that is, say, age. But chronological age is not always an indicator of ovarian reserve, and you don't have any one test that is ideal. If you're asked what is the best test will be AFC, that is antral follicular count plus the anti-Mullerian hormone. But if this is not there in the choice, you have to choose a single best answer, then it is your anti-Mullerian hormone level. That is, if the antral follicle count is less than 5, it indicates that the ovarian reserve is poor, while 5 to 15 is pretty good. And AMH also, the value decreases with age. Less than 0.5 is considered poor. So, what should be evaluated for confirming ovulation? When do you check the serum progesterone? At 21 days. Next question. A 23-year-old woman accompanied by her mother-in-law has come to the infertility clinic. She has been having regular intercourse for 6 months but is not able to continue. What is the next step in line? Ideally, the next step in line will be to reassure her and see her after 6 months' time, because it is only after 1 year of unprotected intercourse that you say that you need to work up for infertility. But here you see that her husband has not come with her. You have to look at the question carefully. Her husband has not come. So you cannot just reassure the woman and send her back. She has come with her mother-in-law. So here the ideal thing for you to advise would be to do a semen analysis for her husband. Because you can only take her history, you haven't got her husband's history. You take a semen analysis for the husband. What are the parameters you look for in semen analysis? The first one is the volume. Previously it was 1.5 ml. There are some small changes. Volume is 1.4 ml. Total sperm count 39 million. pH of 7.2. Total motility of 42% with a progressive motility of 30%. Non-motile sperms 1%. Immotile 20%. Vitality of 54%. See, I am writing all this you don't have to know. Normal morphology 4%. Here, sperm morphology, this one is the most important criteria. What else you need to know? You need to know the sperm count. You need to know the sperm concentration, which is 15 million per ml. This also you have to know. The volume you have to know. This one you have to know. That is it. These many things you need to know, and the progressive motility also. These many things you have to know. You don't have to by heart the whole thing. If all parameters are normal, you say that he is nomospermic. Then there is something called oligospermia, which means there is a decrease in the total count of sperms. Asthenospermia means there is a decrease in the motility. Teratospermia means there is an increase in the abnormal forms. Odds. Oligoasthenoteratospermia, everything is abnormal. Azoospermia means there are no sperms. Aspermia means there is no ejaculate also. Then you've got necrospermia, where all the sperms are dead, all are non-motile. See here, I've given that again, okay. This is the box that represents the semen analysis. This is the previous values. Oh, anyway, these are the only ones you need to study. That is not with regard to this question. So, you have a 24-year-old woman. She is being treated for infertility with human menopausal gonadotropin. She complains of sudden abdominal pain, nausea, vomiting, and breathlessness. Ultrasound done shows this. What is your diagnosis? What is this? This, what you see here, is a picture of an ovarian hyperstimulation syndrome. What is ovarian hyperstimulation syndrome? It is actually a symptom complex that is associated with ovarian enlargement, and it is mainly due to exogenous gonadotropin administration. Here they have administered human menopausal gonadotropin. What happens is there is increase in the estrogen. Increase in the estrogen will produce an increase in the vascular endothelial growth factor, which is the one that is responsible for producing OHSS. There is increased vascular permeability, and there is loss of fluid, proteins, electrolytes, etc. into the peritoneal cavity. And this leads to hemoconcentration, electrolyte imbalance. So, there is a rise in hematocrit. There is a rise in the hematocrit, causing increased chance of venous thromboembolism. there is increased ovarian size. What happens then? There is increased chance of rupture or torsion or hemorrhage. What are the risk factors? Risk factors, it is usually seen in young women, especially those with a history of PCOS, following injection HCG or injection of any gonadotropin, even HMG is there, after ovulation induction. Because there is leakage of fluid into the third space, there is ascites, there is pleural effusion, there is edema, all that. So, the thing is, you need to prevent this. You need to prevent this condition, OHSS. How can you do that? Usually, the ideal conditions for giving an HCG injection after ovulation induction is when the estradiolus levels are between 450 to 1000, when there are only around 1 to 2 follicles that are more than 16 millimeters in size, when the endometrial thickness is around 8 millimeters. So, if you have to prevent this, how to prevent? You should delay giving the HCG. You can also withhold it if estradiol is more than 5000 or follicles are more than 13, or you can reduce the dose, or you can cancel the cycles. The one thing you need to know is what can decrease VEGF. VEGF can be decreased by giving cabergoline. This is an important thing as far as OHSS is concerned. What is the drug that you can give to decrease VEGF? It is cabergoline. So, if you have diagnosed OHSS, you have to admit, you have to correct the hypovolemia. You may or may not need to do paracentesis, and heparin prophylaxis has to be given to prevent venous thromboembolism. A lady with primary infertility was diagnosed to have 2 uterine fibroids in the cornual region. Right side is 7 into 5, left side is 5 into 4. On HSG, both the tubes are found to be blocked. What is your management if you're told that the woman is ovulating and the semen analysis of a partner is normal? See, here you have got a tubal block on HSG. Always to study the tubes, the investigation of choice is hysterosalpingogram. But if you're asked what is the gold standard for tubal infertility or for studying the tubes, it is laparoscopic chromotubation. Why? Because this can act as both diagnostic and therapeutic. So here, this one, if you're doing a laparoscopy, it needs admission. So the first line management or the investigation of choice is always a hysterosalpingogram. The hysterosalpingogram, the problem is that it cannot differentiate between a cornual spasm and a tubal block. All right. So initially you need to inject a radio opaque dye and then you have to take an X-ray fluoroscopically. Let us say a couple of things regarding the blocks. Here you see there is block at both the cornua. Both the cornua are blocked. You don't see a spill. The most common cause of a bilateral cornual block, the most common cause is cornual spasm. This is a physiological cause. If you are asked what is a pathological cause, then it is genital TB. Now, this is a cornual block. The most common pathological cause of distal block is gonococcus. Now, tubal block can occur at 3 levels. Like we said, here it is a cornual block. It can be mid-segmental. It can be distal. If it is a proximal block, it is usually physiological. In this case, you can do a tubal cannulation or a tubal catheterization. But even after a tubal cannulation or catheterization, it is not resolved. It may be pathological. Maybe due to TB, you will have to go for an in vitro fertilization. Or the next step, what is the next step that you will do? It is a laparoscopy and a hysteroscopy. That is, you have diagnosed a cornual block and you're treating. You have a proximal block. You have put in a cannula. It did not work. What the question says, what is the next step? Say that it is a laparoscopy, hysteroscopy. But if you ask what is the best step, then it is an in vitro fertilization. Okay. If it is a mild block, that is a distal mild block, you can do a fimbrioplasty. If it is a severe block, you will have to go for again an in vitro Fertilization. If it is a mid-segmental block, it is usually due to sterilization. You can go for a sterilization reversal. Did you get me? We were talking about corneal block management. First, what do? You do a cannulation. It has failed. Next step, laparoscopy plus hysteroscopy. But best step, IVF. Mid-segmental block, sterilization reversal. Distal block, if it is mild, you can do a fimbriectomy. If it is severe, it is IVF. In this case, see, there's a fibroids that have produced a corneal block. So what can you do? You can do a myomectomy. How can an azoospermic patient be a father of a child? What did we say azoospermia was? Azoospermia means there is very absence of the sperms in the semen. An azoospermic person, you can go for retrieval of the sperms from the epididymis or from the testis. How can you father a child then? There are multiple methods have been mentioned here. IUI, IVF and ICSI. All these are different methods of artificial reproductive techniques. See, IVF, GIFT, SIFT, all are methods for artificial reproductive techniques. If the man has got oligospermia, he can always go for an intrauterine insemination, provided the number of sperms are at least 10 to 15 million. What about IVF? What is in vitro fertilization? In vitro fertilization, you retrieve the oocyte via TVOVA, transvaginal oocyte retrieval is done under general anesthesia after an HCG injection. Then, for each oocyte, around 50,000 to 1 lakh sperms are mixed with each oocyte on the petri dish, and this is done for usually for in tubal diseases in the case of a female, or if this is a donor ovum in the case of a reduced ovarian reserve, in cases of Mullerian agenesis, in cases where there is a risk of transmission of genetic diseases, or in males when there is oligospermia, that is 5 to 10 million. IUI in 10 to 15, IVF if it is 5 to 10. But suppose there is very less number of sperms, that is less than 5 million. Azoospermia, you had to have surgically retrieved sperm. In this case, you will have to go for ICSI, where it is 1 oocyte per sperm. Or if the IVF has failed, then also you go for ICSI. Okay. Moving on to contraception. Long-acting reversible contraceptives are all except. Here you can see it is laparoscopic tubal sterilization. It is a permanent method of sterilization. Let us take these up one by one. First of all, you have got an LNG IUD, levonorgestrel IUD. The one that is commonly used is a Mirena. It contains 52 milligrams of levonorgestrel, where 20 micrograms is released on a daily basis. And the time period is for 5 years, and the failure rate is around failure rate is around 1 to 3 per 1000 women years. Okay, we're talking about the LNG IUD. But the problem is it cannot be used as an emergency method of contraception. This will reduce menstrual blood loss, so it can be used as an alternative to hysterectomy also. It can reduce dysmenorrhea, it can reduce pelvic infection. It is also used in the treatment of endometrial hyperplasia, adenomyosis, endometriosis, and some leiomyomas also. That is the importance of LNG IUD. Now we come to implanon. What is implanon? Implanon is a single rod. It is 4 centimeters long. It contains 68 milligram of etonogestrel. This is the most popular implant. The lifespan is 3 years. What does it do? It prevents ovulation. The most common adverse effect is irregular bleeding PB. Okay. And then we have got copper T. Copper T we'll discuss later. Which of the following is the emergency contraceptive used in India? It is levonorgestrel 1.5 milligram. That is the emergency contraceptive of choice. Which is the most effective? The most effective is copper T. It can be used as an emergency contraception also. What does it do? Which are the drugs that are used? Levonorgestrel alone. This is the most commonly used one. You have got copper intrauterine device. The most effective hormonal contraception is ulipristal. That is not the one that is commonly used. Most common, most effective emergency contraception if asked is copper T. Most effective hormonal if asked is ulipristal. What is the choice of contraception in a female with heart disease? Obviously, it is condom. The non-contraceptive uses of oral contraceptives include all the following except oral contraceptives do not offer any protection against the sexually transmitted diseases. The only contraceptive method that can provide protection against STIs, including HIV, is condom. We have got certain non-contraceptive benefits of the OC pills, starting with benign fibrocystic breast disease, ectopic pregnancies, neoplasms, that is endometrial and ovarian neoplasms. Then there is endometriosis, fibroids, iron deficiency anemia because it reduces the blood loss, in premenstrual tension syndrome, sickle cell anemia, osteoporosis, OC pills, and ovarian cysts, and pelvic inflammatory disease. You can remember it as benefits of the OC pill. Don't try reading all that. It will be quite difficult for you. Okay. Now, this one you need to know. The tumors that are associated with OCPs. CS cervix, hepatic cancer, pituitary adenomas, and breast cancer are all associated with OCPs. While it provides protection from some ovarian tumors and cysts, from uterine cancer and from benign breast disease. See here, use of OCPs is associated. This is the one that you need to study. Candida, chlamydia, urinary tract infection, there is an increased risk with the use of OCP, while GTB, that is gonorrhea, trichomonas, and bacterial vaginosis, is a decreased risk with the OCPs. All right. Remember, very specifically, there is no relation between sexually transmitted infections. Only condoms can protect against that. A female is on Mala-N for contraception. What is Mala-N? Mala-N is a combined oral contraceptive pill. After the end of the first strip, she did not get a withdrawal bleeding. What can be done? We know that whatever it is, whatever drug she is taken, whatever contraceptive it is, if there is a slight chance of failure and if she has missed at least one OCP, there is always an increased risk of pregnancy. If such a pregnancy occurs, if a woman on contraceptive use becomes pregnant, there is a possibility of an ectopic pregnancy because the progesterone component in the contraceptive can decrease the motility of the fallopian tubes. So, if there was no withdrawal bleeding, she should immediately go to the hospital to check for a pregnancy. Copper T is contraindicated in. Now, this is about copper T. Copper T, see, look at the different types of copper T, 200, 375, 380A. It is being compared with the LNG IUS. How is copper T? What is the mechanism of action of copper T? It is by prevention of implantation. Okay, what does copper T do? It prevents implantation. And the mechanism of insertion is by the withdrawal no touch technique. These numbers here 200, 375, etc. refer to the total area of the copper wire. This one here, this is the only copper T that is presently approved for use by the government of India. It is around, it has a life of around 10 years. The ideal time for insertion of the copper T is from 10 days from the start of the menses. Then you have got certain complications. The most common complication being definitely bleeding. The second most common being pain. Now it can get expelled. Then there is a possibility of infection. Infection means the most typical infection that is associated with copper T is infection by actinomyces. there is an increased risk of infection, especially PID, especially in the first 20 days. There is also an increased risk of ectopic pregnancy if the woman becomes pregnant while on Copperty. Now here you've got the main contraindications. I've given it as wash the cup. W will stand for Wilson's disease. T is for trophoblastic disease. We mentioned once before, the uterus will be very soft, and if you're trying to insert the Copperty, there is a possibility that you can perforate the uterus. Then you have got C, copper allergy, carcinoma of the uterus, the breast or the cervix, and cervicitis. U is for unexplained bleeding PV, uterine fibroids, or uterine distortion where you just cannot place the Copperty properly inside. P, maybe pregnancy, puerperal sepsis, or postpartum endometritis. Okay, these are the contraindications. Now, suppose a woman who is on Copperty becomes UPT positive, or urine pregnancy test becomes positive. What will you do? The first thing that you need to do is an immediate ultrasound, UPT positive while on Copperty. Ultrasound to rule out ectopic. That is the first thing that you should do. Now you see whether you can see the strings of the intrauterine contraceptive device. If the woman is requesting, if the intrauterine device is seen and the woman is requesting a termination of pregnancy, you will have to do it, because contraceptive failure is an indication for MTP according to our MTP Act. But you are not able to see it, and if it is in the fundus, if you are doing an ultrasound and if it is in the fundus, you can go for an ultrasound guided removal, or you can leave it in place if she wants to continue the pregnancy. If the pregnancy is continued, always look for signs and symptoms of an intrauterine infection. That is whether this woman has got fever, whether she has pain, whether she has bleeding. At the first sign of infection, you have to start high dose antibiotics. All right, because especially if this is inside the cavity, there is a Copperty inside the cavity, there is a high chance of an infection and an inflammation, because there is no possibility of waiting and watching. Immediately you start on high dose antibiotics. All right. The following instrument is useful. What is this instrument? What is this instrument? This tube-like thing here. This is a fallope ring applicator. The surgery that is being done here is a laparoscopic tubal sterilization using fallope ring. See, there are two rings here. That is a surgery that is being done here. So, the answer is this is done for tubal ligation. As far as sterilization is concerned, there are a couple of things you need to know. Starting with the postpartum sterilization, which is done within the first week of delivery. Interval sterilization can be done any time after 6 weeks. The age of the woman at which sterilization is done is in between 20 to 45 years. She should ideally have at least one child. The husband should be around 25 to 50, but that is not necessary. Even without the consent of the husband, sterilization can be done. What is the most common method that is used for sterilization? It is the Pomeroy's technique, the modified Pomeroy's technique. If it is a laparoscopic sterilization, you can go for a fallope ring, a Hashka clip, or a Filshie clip. The Filshie clip is the best method for sterilization reversal. In laparoscopy, it is by aseptic necrosis that tubal sterilization occurs. Okay. Question 30, we are coming to fibroid uterus. There is a pregnant woman with fibroid uterus. She develops acute pain in the abdomen, low-grade fever, mild leukocytosis at 28 weeks. What is the most likely diagnosis? See, I believe you are very familiar with fibroid uterus, so we won't be discussing too much about it. This is the most common of the solid tumors of the uterus. See, look at it. This is how it is classified. Figo classification. You have to know the Figo classification because they can give a picture and ask you which classification this is. So first one, there is 0, which is the pedunculated intracavitary. You've got the 1, which is actually a submucosal myoma with a 50% component, less than 50% component, that is intramural. Then you have got 2, where you've got more than 50% is intramural, still it is a submucosal myoma. Then we have got the others, starting with 3 here, which is an intramural myoma that contracts the endometrium. 4 is a completely intramural. 5 is a subserosal myoma, but more than 50% is intramural. 6 is a subserosal myoma, only less than 50% intramural. You see how it is, right? So, that is about the classification of the fibroid uterus. Next thing is regarding the effect of the fibroid on pregnancy. Here you are asked about the fibroids in pregnancy. What can fibroid do? If it is a corneal fibroid, it can cause infertility. It can cause abortion or preterm labor, abruption, malpositions, obstructed labor. All these are part of fibroid in pregnancy. What happens when, what are the effects of pregnancy on fibroid? Most of the fibroids don't have any change in size just because pregnancy has occurred. But the important thing is red degeneration can occur, which is the answer here. Red degeneration. There are different degenerations of fibroid. There is hyaline degeneration, there is calcareous degeneration, there is sarcomatous degeneration, there is red degeneration. The most common is hyaline degeneration, but in pregnancy, the most common degeneration that you see is the red degeneration, usually seen in around mid-pregnancy. This is an aseptic condition. The patient will present with acute pain, mild fever, mild leukocytosis. There will be tenderness, vomiting or malaise. If you take out the fibroid, you'll find that it is soft and it has got a salmon pink appearance. Salmon pink appearance because of the thrombosed vessels. There is also a fishy odor. Fishy odor, why? Due to secondary infection with coliforms. It can be diagnosed by ultrasound. And what do? Just conservative management is enough. You can give some paracetamol or NSAIDs for fever and pain, and that will do. Here you've got 2 instruments with regard to fibroids. This is the myoma screw. You see how there is a screw at the end. This is used to fix the myoma during myomectomy after opening the capsule or to give traction to the myoma in order to pull it out. And here you've got a Bonney's myoma clamp. This is the Bonney's myoma clamp. What does it do? If it is applied, it can decrease the blood supply to the uterus during myomectomy. What are the other things that can decrease? You can also tie a tourniquet, or you can give a pre-operative GnRH. This will also decrease the blood supply. Or like we said, you can put in a tourniquet. You can inject vasopressin, or you can give hypotensive anesthesia. All these are helpful in reducing the blood supply in a case of during myomectomy. So we had our answer there. Next question. A 27-year-old female presents with painful bleeding during menses and pain while having intercourse. Physical examination shows this. There is adnexal tenderness, uterus is retroverted. What is the investigation that is done to confirm the diagnosis? What is this? This is a case of endometriosis. Now, endometriosis is an estrogen dependent condition. The main risk factors would be a family history. Since it is estrogen dependent, early menarche, late menopause, heavy alcohol and caffeine, a nulliparous woman. It is a disease of the higher socioeconomic status. In utero exposure to diethylstilbestrol, Mullerian agenesis. Almost all cases of Mullerian agenesis have got endometriosis. Okay. It is more common in the reproductive age group, that is 25 to 35 years of age, and the most common sites are the ovary followed by the pouch of Douglas. If you do a PV examination, you'll be able to feel a cobblestone appearance in the pouch of Douglas. Anyway, it can occur anywhere, but the rarest site is the CNS. And the site that is not involved is the spleen. What is the most common symptom? The most common clinical feature is pain. In pain itself, the most common pain is secondary dysmenorrhea. It is followed by chronic pelvic pain and dyspareunia. So there is a classic triad which is dysmenorrhea, infertility and dyspareunia. Okay, the second most common clinical feature after pain, the second most common clinical feature is infertility. Now, there are so many reasons that have been cited for infertility, including inflammatory cytokines or hormonal imbalances. Anyway, it is an unexplained infertility. You can try treatment with ovulation induction using clomiphene citrate and IUI. But if it is a moderate to severe, if the treatment, here we are mentioning some of the treatments here. First line management, first of all, you need to control the pain, right? You can always give some NSAIDs and see if it works. If it does not work, you'll have to go for oral progestins, continuous administration. The best management is a GnRH analog. Then you've got letrozole, OCPs, gestrinone, danazole. There you also have a mnemonic there. Anyway, as far as infertility is concerned, if it is a mild infertility or minimal, you can go for clomiphene citrate plus IUI. But if it is a moderate to a severe disease, you have to go for in vitro fertilization. When you are doing a PV, like we said here, you have got a fixed retroverted uterus. You may be able to make out a fixed firm adnexal mass. There is tender nodularity of the uterosacral ligaments. Okay, that you need to know. PV will show tender nodularity of the uterosacrals. This is the cobblestone appearance. What are the investigations that you will do? The first investigation is a transvaginal scan, which will show a ground glass appearance. The investigation of choice is laparoscopy, which can show powder burn appearance in the peritoneum. But the gold standard investigation is a histopathological examination. Okay, so in this case, which is the investigation that you would do to confirm your diagnosis? It is a diagnostic laparoscopy. Now we'll take a short break. $164 33 pages. 5:30 ആയി 5:15 5:15 6 മണി 6 മണിക്ക് കഴിഞ്ഞാൽ എനിക്ക് ലുലുവിൽ പോയിട്ട് പോകാൻ പറ്റുമോ? അതിൻ്റെ ഉള്ളിൽ നിന്ന് എങ്ങനെയാ മെട്രോയിലോട്ട് പോവാ? അവിടെയൊക്കെ എഴുതി വെച്ചിട്ടുണ്ടാവും അല്ലേ മെട്രോയിലോട്ടുള്ള വഴിയിൽ? വലിച്ചോളാം. Next question. A lady came with amenorrhea after 3 months of spontaneous abortion and FSH was 6. What is the cause of amenorrhea? She has got amenorrhea. What will you be suspecting? She has come after a spontaneous abortion after 3 months and her FSH values are normal. What is the cause of amenorrhea? The cause of amenorrhea is uterine synechia, also known as what? Asherman syndrome. See, this is an acquired uterine defect. It is most commonly caused after curettage, postpartum curettage. This is very important. What is the most common cause for Asherman syndrome? It is postpartum curettage. Second one is a curettage done for MTP. Then you have got certain other causes also. The most characteristic symptom is a hypomenorrhea. There is scanty bleeding. Then others will include infertility. If an Asherman syndrome is suspected, then you should do an HST. See, here I have given you 3 pictures. This one here, this is a picture of HST. See how there are small cavities within the uterus. And here you have a saline infusion sonogram. This is also the adhesions that are seen. And this is the hysteroscopic picture of an Asherman syndrome. What do? Once it is suspected, you can... the diagnosis and treatment is also by an adhesive. Again, you will be going for a hysteroscopy only. You can place an intrauterine device or a pediatric Foley's catheter to avoid the contact between you. You have to do an adhesive hysteroscopically, following which you can keep a catheter there. Okay, and you will be giving estrogen treatment so that the endometrial growth is also promoted. Anyway, in this case, the answer is Asherman syndrome. Question 33. Which of the following is a feature of a primary dysmenorrhea? We had discussed secondary dysmenorrhea previously in our question on endometriosis. Primary dysmenorrhea means the pain is there. It is present for the first 48 hours and then it subsides. Primary dysmenorrhea is usually a spasmodic kind of dysmenorrhea, usually produced in puberty, that is due to anovulation, and you can take some kind of NSAIDs for it and it will subside on its own. While the other one, secondary dysmenorrhea, is a congestive dysmenorrhea, right? Congestive dysmenorrhea means you need immediate treatment or you have to treat the basic cause. It can last for nearly half of the month. It can start 1 week before the cycle and go on till 1 week after the cycle also. Which of the following is not a cause for secondary amenorrhea? Turner mosaic can cause secondary amenorrhea. Fragile X, yes. Sheehan syndrome also, yes. So here, Coleman syndrome is not a cause of secondary amenorrhea. What are the characteristic features of Coleman syndrome? It is a hypogonadotropic hypogonadism. What is there? There is anosmia and amenorrhea. These are the main features. Others will include some anosmia and amenorrhea. Sometimes there may be absence of the puberty development. How do you treat it? You need to give hormone replacement therapy to promote the sexual maturation, and the fertility is by using intramuscular gonadotropins. Then we have Sheehan syndrome. This is another very important thing. How does Sheehan syndrome occur? It is like a pituitary apoplexy. That is, suppose a woman has had a severe postpartum hemorrhage and she has gone into shock. The arterioles leading to the pituitary can go into a state of vasospasm, causing a pituitary necrosis. And if you're taking an MRI, you'll be seeing an empty cella. All right, that is diagnosed by a failure of lactation. She may have secondary amenorrhea, she may have hair loss of libido, all the hormones are reduced. So how do you treat it? She will need lifelong hormonal support. That is with regard to Sheehan syndrome. Now we have a 32-year-old woman. She presents with complaints of heavy menstrual bleeding for 6 months, not controlled by non-hormonal treatment. TVS and perrectal examination were normal. What is the next step? Abnormal uterine bleeding, AUB, and DUB, dysfunctional uterine bleeding, where there are no pathologies that have been discovered. AUB palm Cohen classification, you know, we have the structural causes, that is palm, and the non-structural systemic causes, that is Cohen. You know about this. The first thing that you do is a prostaglandin synthase inhibitor, non-hormonal pharmacological method, which is NSAIDs like mefenamic acid. Then you can try antifibrinolytics like tranexamic acid. But if both of those have failed, what do you do then? Then you will have to resort to the hormone treatment, hormonal therapy. How? If it is a premenopausal woman and she is complaining of abnormal uterine bleeding, always you have to check for a cervical cytology. You check her you do an ultrasound to check for endometrial thickness. You may even have to do a sonohysterography to rule out whether there are any other endometrial pathologies. A hysteroscopy and an endometrial biopsy, an endometrial sampling, a D&C should be done. Once you have excluded a malignancy, you look at the endometrium. If you are talking about a premenopausal woman, right? If it is simple hyperplastic endometrium, you can offer her progestins. The first line is Mirena or levonorgestrel intrauterine hormone releasing system is the first line. We'll talk about this in detail in the coming questions. Screening for cervical carcinoma, we are moving on to oncology. When is the screening for cervical carcinoma done? It is done from 21 to 65 years of age. What are the methods of screening? First one is the pap smear, which is a conventional pap smear or liquid-based pap smear. The conventional pap smear is done using an instrument called an Ayer's spatula, while the liquid-based pap smear is done using the cervical brush. This is started at 21 years of age, and it is done every 5 years. Co-testing, that is HPV plus pap smear together. This is done. Co-testing is done every 5 years. If the woman is HIV positive, then an annual pap screen is done. What about VIA and VILI? Again, these are done for peripheral health workers. VIA being visual inspection with acetic acid and VILI being visual inspection with leukocidin. 5% acetic acid, 5% leukocidin. In VIA, that if there are dysplastic cells, they will appear white and opaque, known as aceto-white areas. While in VILI, that is with visual inspection with leukocidin, the normal vaginal epithelial cells have got glycogen, which take up the iodine, appearing mahogany brown in color, while dysplastic cells will appear mustard yellow in color. That is with VIA and VILI. Okay, these are the screening methods. If the lesion is visible, you will have to take a punch biopsy. If the lesion is not visible, we will do a colposcopy. We'll discuss that in the next question. You have a 38-year-old patient. She attends a gyneco-PD. The cytology report comes as high-grade squamous intraepithelial neoplasia. What is the next line of management? What is the next line of management? You will do a colposcopy. In the Bethesda system, that is the Bethesda system, there is low-grade squamous intraepithelial neoplasia and high-grade. High-grade means it is either CIN2, 3 or carcinoma in situ, while low-grade is only CIN1. Colposcopy is the gold standard for visualization of an abnormal cervical cytology, examination of the lower genital tract and anus using a microscope. So, you have an abnormal pap smear. What do you do? If the lesion is not visible, if it is an L cell or an H cell and the lesion is not visible, then you will have to go for a colposcopy. If the lesion is visible, you will take a punch biopsy or an endocervical curettage. If it is an ascus, that is atypical squamous cells of unknown significance, and the woman is more than 25 years of age, you will do an HPV DNA, or if you will repeat the pap smear in 12 months. If it comes to be suspicious or a high-risk DNA is positive, you will do a colposcopy. How do you manage it if the age is more than 25 years and it is a first diagnosed condition? You can offer co-test with PAP and HPV after 12 months. If it is negative, you will continue with the screen. 21 to 25 years is diagnosed for the first time. Again, pap smear 12 months and 24 months instead of co-testing. All right. So, how do you manage a CIN that is confirmed on colposcopy? If it is CIN1 and persisting for 2 years or more in a woman age more than 25 years, it is cryosurgery. Cryosurgery means you can either offer liquid nitrogen or carbon dioxide. CIN 2 and 3, at any age, any parity, you will offer LEEP or LETS. Recurrent CIN, the treatment is hysterectomy. And if it is a CIN extending to vagina, that is important. If it extends to vagina, you will go for a laser therapy. What is the limitation of colposcopy? The upper two-thirds of endocervix cannot be seen. Now we come to the staging. Which of the following are features of stage 1B2 carcinoma of the cervix? What are the symptoms of carcinoma cervix? The most common symptom of carcinoma cervix is irregular bleeding PV. Irregular bleeding PV. What is it? Metrorrhagia. But the most specific symptom is postcoital bleeding. There are 4 cardinal signs. That is hardness, friability, fixity, and bleeds on touch. These are the 4 cardinal signs. Now you have got the staging. Remember that in the staging, stage 1A, this one is the microscopic cancer. Here, from here on, it is a clinically visible lesion. Go through the stages, and you have no option but to study the stages. Go through all the FIGO stages on the day prior to the exams. Okay, at least something will strike in your head. Here the size of the lesion less than 4 centimeters. That is the criteria for stage 1B2 carcinoma cervix. What is used in staging carcinoma of the cervix? These are the ones that are used. There is a physical examination, radiological studies, and procedures. Physical examination means what? You do examine the vagina, you do a bimanual recto-vaginal examination, you give a barium enema, you palpate the lymph nodes. Then as part of the radiology, you do a chest x-ray, a skeletal x-ray, and an intravenous pyelography. What about the procedures? You can do a biopsy, conization, endocervical curettage, and the 4 scopies. The scopies you need to know because you might get which of the following is not done, and there might be a scopy that is not there and you will get confused. What are the scopies? It is BSC. 4 types of scopies. B, biopsy, conization, and the 4 types of scopies. That are the procedures. What are the scopies? Colpo, hystro, cysto, procto. Colposcopy, hysteroscopy, cystoscopy, and proctoscopy. These are the scopies that are done. A 35-year-old woman with 1 child is found to have a visible cervical lesion measuring 2 centimeters. Biopsy shows squamous cell carcinoma of the cervix. Lesion is confined to the cervix. She wants to preserve her fertility. What is the most appropriate treatment? If she wants to preserve her fertility, the treatment is radical trachelectomy with lymph node dissection. This is not for everyone. Not everyone can preserve their fertility. If it is an early stage cancer without any lymphovascular space invasion, that is 1A1, she can have a cervical conization. Here, what is the stage of this cancer? It is measuring around 2 centimeters in size. 2 centimeters, say it is 1B1. At that stage also, she can have a radical trachelectomy if it is less than 2 centimeters with a pelvic lymph node dissection. A few other things are the primary group where the lymph node group of cancers you need to know: HOPE, hypogastric, obturator, presacral, and external iliac. Then you need to know this one also. What are the signs of inoperability of cancer cervix? If there is fixity of the cervix and parametrium to the lateral pelvic wall, infiltration of the vagina, extrapelvic mets, extensive infiltration of the bladder, and presence of vesico-vaginal fistulae. Now, all stages of CA cervix are radiosensitive, but in a young girl, we prefer surgery. Why? One is to preservation of the ovarian function. Then you need to preserve the vagina for coital function. Then for some psychological support. These are the points A and B where you give what are the structures that are present. A, there is a paracervical or parametrial lymph node, and B, there is the obturator lymph node. Chemotherapy in cervical cancer is a platinum based one, a platinum based chemo. From that, we are moving on to the carcinoma of the ovary. It is classified which under the following categories. What is this? Clear cell carcinoma is an epithelial tumor. So, the type of cancers: epithelial, sex cord stromal, germ cell, and metastatic. One very important thing, the question that you often get from ovarian cancer is with regard to the tumor markers. CA125, CA199, CEA, all these are markers of epithelial ovarian cancers. Here, we have got the primordial germ cell cancers here. So, this is where you can get a bit confused. I'll just show you how I have studied. So, if it is easy enough for you, you can remember it that way. Or if you've got your own method, please follow it. Don't go for this one. You have the embryonal cell carcinoma. You have the endodermal sinus tumor. You have the choriocarcinoma. And you have the teratoma. Okay. AFP and HCG plus plus. Okay. So, look at this embryonal cell carcinoma. You have got the AFP and HCG, both are usually present in the embryonal carcinoma. Then you have got the endodermal sinus tumor or the yolk sac tumor. AFP is present, HCG is absent. Then we have the choriocarcinoma. AFP is absent, HCG is present. And you have the teratoma where both are absent. What is there in teratoma? Usually you will be able to see LDH or in teratoma. See how I have written it. You write it this way, then it is plus plus minus minus plus minus plus minus. That is how I have remembered it. If you have got your own method, please follow that. Don't do this. But still, you will have to know. You need a method to know the tumor markers in the ovarian cancer. Okay. Now we come to the staging. She has carcinoma ovary, bilateral involvement with ascitic fluid. The stages, here the stages 1C. Look at the staging. Even though this is a pretty extensive staging, this is not a very difficult staging. Okay, it might seem big, but if you go through this a couple of times, it will stick in your mind. Before that, we have got the ultrasound differentiation of the malignant from a benign ovarian tumor. See, in a malignant ovarian tumor, you'll have a hypoechoic solid area within the mass due to fat or maybe calcification. There will be thick septations. Septation thick means more than 3 millimeters in size. The size is more than 7 centimeters. The size of the mass is more than 7 centimeters. There are certain simple cysts that can grow to be very large, like a mucinous cystadenoma. It has got a central vascularity. Look, this is a central vascularity, while a benign tumor may be having only a peripheral vascularity. It has got a very low resistance index also. Now, how do you manage an ovarian cyst? If it is a premenopausal ovarian cyst and the size is only 3 to 5 centimeters, you can wait and watch. But when the size becomes more than 5 to 7 millimeters, the ultrasound has to be repeated. And if it remains clear, you can wait and watch, or you can give OCPs for and see if this is regresses. If there are solid areas or if the size is more than 7 centimeters, you have to go for a surgery. In postmenopausal cysts also, the size less than 7 centimeters, you can wait. But if the CA125 levels are raised, whatever the size be, you will have to go for a surgery. So, what are the indications for surgery in an ovarian mass? if the mass is showing any kind of high risk features on ultrasound. If the size is more than 7 centimeters, that is ovarian mass has a size more than 7, the adnexal mass with a size more than 10, or there is increased CA125 in a postmenopausal woman. Then we have got the RMI, which is a risk of malignancy index, that is the ultrasound score into the menopausal score into the value of CA125. If this is more than 200, you have to immediately refer the woman to a gynec oncologist. Next question. What is this? The following tumor was removed. What is this? This is a mature teratoma, also known as a dermoid cyst. A dermoid cyst contains derivatives from the ectoderm, the endoderm, and the mesoderm. The most common element is from the ectoderm. 100% will have 100% of the dermoids will have a derivative from the ectoderm. See, that is the hair. Then it is a unilocular cyst. It has got hair and other cheesy material, teeth, bone, thyroid tissue, and the epithelium is a keratinized squamous epithelium. Keratinized squamous epithelium, which is why if at all a cancer develops within the dermoid cyst, the cancer is likely to be a squamous cell carcinoma. Here you've got an area of localized growth. The area of localized growth that contains a hair, teeth and bone, which is called the Rokitansky protuberance. The Rokitansky protuberance can be seen on the gross section. It can be seen on the ultrasound. It can also be seen on the X-ray. But this is the typical ultrasound pattern, which is called the dash and dot pattern. This is produced as a result of the hair in the dermoid cyst. Treatment of choice of endometrial hyperplasia without atypia in a 32-year-old female, young girl. What is the treatment of choice? It is medroxyprogesterone. Here in this case, since the choice is given that way, we'll take it as medroxyprogesterone. So we have endometrial hyperplasia without atypia. There are 4 different types. It can be a simple hyperplasia without atypia, which is a cystoglandular hyperplasia, without complex without, simple with, and complex with atypia. And this is the risk of progressing to cancer. Now, if she has got no atypia, she is a young girl, you can give her progesterone. Which is the progesterone? Medroxyprogesterone acetate. But now, if there was a choice for Mirena or an LNG intrauterine device, that would have been your best answer. Okay. After this, if you have given a progesterone, what do? You will repeat the endometrial biopsy every 6 months till you get 2 consecutive negative biopsies. But if there is no regression, you are not getting a negative biopsy after 12 months, you will have to go for a hysterectomy. If there is atypia, if it is an older woman, directly offer her hysterectomy. And a young woman who refuses hysterectomy, what will you do? Again, you are giving her megestrol. Then what do? You repeat endometrial biopsy after 3 months. You need to get 2 negative biopsies. Once she no longer requires fertility, you have to go for a hysterectomy. Ultimately, the treatment of choice is hysterectomy. A couple of other things, a postmenopausal bleeding. First investigation is transvaginal scan. Investigation of choice is an endometrial aspiration biopsy, but the gold standard investigation is a fractional curettage. How do you manage a woman who comes with postmenopausal bleeding? What is the first thing that you'll do? The first investigation that you have to do is a transvaginal scan. Why? You want to measure her endometrial thickness. If it is less than 4 millimeters, you can review after 3 months. But if it is more than 5 millimeters, again, you've got your investigation of choice. You have to do an endometrial aspiration biopsy. Gold standard is a fractional curettage. If it is 4 millimeters and there is a focal area, then your gold standard investigation becomes hysteroscopy and biopsy of the focal area. It's probably a polyp. This is regarding the staging of the carcinoma endometrium. It is unlikely that you will get a question from carcinoma endometrium because a new staging has come in December 2023 that involves lymphovascular space invasion and other newer mutations, etc., which I don't think you will be asked to study. Okay. Anyway, this was the previous one. Please go through this also. Remember that there is no routine screening available for carcinoma endometrium. But for patients of HNPCC, there is a screening, that is you can do a PV examination, endometrial biopsy and transvaginal scan every 6 to 12 months beginning a HNPCC screening. It comprises what? It comprises a PV, endometrial biopsy, transvaginal scan every 6 to 12 months from 35 years of age. The best screening method, if asked, is a fractional curettage. The best method to prevent cancer is a prophylactic hysterectomy after completion of the family. So also just look at the tumor grades. How do you stage the endometrial cancer? It is a surgical staging. But if you have got an endometrial cancer diagnosed by an FC, the first thing that you have to do is an MRI. Why? Because you want to know the extent of the myometrial involvement. After that, you'll go for a surgery, which is a THBSO usually. In addition to all these, if it is a clear cell or a papillary serous cancer, in addition to all the surgeries that you're doing, you will also do an omentectomy. You will also do omentectomy and peritoneal biopsy along with lymph node dissection up to the level of left renal vein. All right. So we've got the chemotherapy that is used, which is the TAP regimen. TAP. Paclitaxel, adriamycin and doxorubicin. Doxorubicin, paclitaxel and cisplatin. Okay, that is the TAP regimen. Sometimes for young women in whom surgery is contraindicated, progesterone can be used as a primary treatment. And in also young premenopausal women who desire fertility. I'll just, we've got something about the lymph node dissection also. Before that, the treatment is quite complicated. Whom will you do surgery for? Whom will you not do surgery for? I'll try to make it a little bit easy for you. If it is 1A and the tumor grade is 1 or 2, you have to do a TH. Remember, this is for endometrioid cancer, not for clear cell or papillary serous. TH plus BSO, and the size is less than 2 centimeters. There is no need for lymph node dissection. If the size is more than 2 centimeters, you will do a pelvic lymph node dissection. If it is 1A, grade 3 or 1B, again TH plus BSO plus pelvic and para-aortic lymph node dissection plus postoperative radiotherapy. If it is 2, then you'll go for a Wertheim's hysterectomy plus a pelvic and para-aortic lymph node dissection plus a postoperative radiotherapy. In the case of 3 and 4, you will have to go for a debulking surgery plus pelvic and para-aortic lymph node dissection plus postoperative chemo and RT. Okay, read this a couple of times, it will stick in your head. Next question, a female patient presents with a lump in her breast. All the following can be used to rule out malignancy, except you cannot use a PET scan to rule out a breast malignancy. All the following are risk factors for vulval cancer, except. These are the risk factors for vulval cancer, like vulvar dystrophy, smoking, vulvar warts produced due to human papilloma virus. We had to talk about that while we were discussing CA cervix also. In CA vulva also, the main risk factor is the human papilloma virus. More important ones are 16 and 18, while human papilloma virus 6 and 11 are the ones that are responsible for causing warts. Okay, we have discussed this in detail in the previous classes also. Anyway, what is not a risk factor for vulval cancer? Vulvar hamartoma is not a risk factor for producing vulvar cancer. The most common site of vulvar cancer is the labia majora, followed by the labia minora. What is the most common variety? It is the squamous cell carcinoma. The most common symptom is pruritus. There is a lymphatic spread. If it is a unilateral tumor, it will only spread to the ipsilateral lymph node. If it is a midline tumor, it will spread to bilateral lymph nodes. The sentinel lymph node is the superficial inguinal lymph nodes. Now, if this is a microinvasive cancer, that is the size is 2 centimeter or less with an invasion of less than 1 millimeter, this question has been asked. The size is less than 2 centimeter. Invasion is less than 1 millimeter. You will go for a wide local excision or a simple partial valvectomy. CA vulva is not a topic from which you will be getting a lot of questions, but still for the sake of completion, you can go for a wide local excision or a simple partial valvectomy. If this is a higher grade of cancer, you will have to go for a more radical valvectomy along with an inguinofemoral lymph node dissection. If this is more than 2 centimeters from the midline, again you will go for an ipsilateral lymph node dissection. Here we will take a small break. Arrange the following steps of dilatation and curettage in order. What do you do for dilatation and curettage? You need to get the endometrial lining. What is the first thing that you do? You assess the direction and size of the uterus by doing a PV examination. Then you sound the uterus. Why? You need to know the length of the uterus so that you can put in your curate accordingly. Then you will go for serial dilatation using Hegar's dilators, and finally you will offer curettage. Finally, you will be doing a curettage. This is the correct series of steps. During the removal of a submucosal fibroid during hysteroscopy, a fluid deficit of 2000 ml is estimated in a patient. What is the immediate complication of this? What is the immediate complication? She can have pulmonary edema. What is a hysteroscope? What are the complications of hysteroscope? A hysteroscope is like a camera that can help you visualize the interior of the uterus that you can put into a uterus. So please don't by heart the complications of hysteroscopy, what can be done with hysteroscopy. Whatever is inside the uterus, you can see if there is a congenital malformation inside the uterus, if there is a fibroid, if there is an intrauterine contraceptive device, if there are synechia, all these you can see using a hysteroscope. Then, what are the therapeutic indications? If there is a uterine septum, you can excise it. If there is Asherman syndrome, you can do adhesive lysis. You can retrieve a lost IUCD. You can do a myomectomy using a hysteroscope. These are the main things. Now, the main problem with the hysteroscope is, as we said, the fluid deficit that usually occurs with isotonic solutions like lysis. The next question, cryosurgery is effective in all except. What is cryosurgery? There is destruction of the tissue that is effective by freezing. It is done in the case of a cervical ectopy, some benign cervical lesions such as CIN, condyloma, leukoplakia, some condyloma acuminata of the vulva. What is it? There is cellular dehydration that is produced. What you need to know, what is used here? Carbon dioxide, nitrous oxide and liquid nitrogen are what are used in the case of cryosurgeries. Okay. So with that, we have come to the end of our final dash. Just as the name indicates, we have just dashed through the topics. I am pretty certain that you're fed up with your studies and all those things. But please don't worry. And as long as you feel confident, as long as you keep up the memento, there is nothing that can stop you from achieving your goals. Okay. Thank you. And all the best for your exams. കഴിഞ്ഞു വാ